A very good morning to everyone. Let's begin the session in a minute or two. Dr. Anila and Dr. Ankit have logged in.
Yeah, I'm Dr. Anila.
Yes. Hello, ma'am.
Hello.
Dr. Ankit.
अपने को प्रेजेंटर्स लाउंज में जाने का
हम नहीं करेंगे चलेगा जिसके लैपटॉप में करेंगे वो भी होए
हाँ हाँ
इसके लैपटॉप से करेगा चार्जिंग
Dr. Ankit, have you logged in? Good morning, Dr. Ankit. Can't hear you. I think you're on mute. Yes.
Can you hear me now?
Yes, I can hear you.
Okay.
Yeah. Okay, so good morning, Dr. Anila. Good morning, Dr. Ankit. Let's begin with our session for the day. A very good morning to our judges and our participants. A warm welcome to all of you on our behalf of the 45th ISP virtual conference. I would like to introduce our judges in brief. Dr. Anila S., Professor and Head, Department of Periodontics, St. Gregorius Dental College, Ernakulam, studied BDS from Government Dental College, Bangalore, MDS from Government Dental College, Trivandrum. She has numerous publications in national and international journals. Special areas of interest are biomaterials in periodontal regeneration and photodynamic therapy. Welcome, ma'am. A second jury is Dr. Ankit Desai, who completed his BDS from Sharad Pawar Dental College, Wardha in 2004, MDS from D.Y. Patil Dental College, Pimpri, Pune, 2008. Currently working as a reader in Terna Dental College at Nerul. He has 13 years of teaching experiences and many publications in national and international journals. Welcome, Dr. Ankit.
Thank you.
Should we begin with our session? we have 3 minutes for the students to present and 2 minutes back for question and answers. So we will ask the participants to stick to their timing because we have a schedule to follow. Janvi madam, can we have the first slide, please? The evaluation sheets have been sent over to you all. You can just follow those. Yeah, thank you. Can the first participant start the presentation, please? Dr. Rahul. Dr. Rahul, are you here?
Hello, am I audible?
Yes, yes.
Okay, shall I start?
Yes, definitely.
Very good morning to all of you. My poster presentation is a case report on the topic minimally invasive buccal roll flap technique for peri-implant soft tissue augmentation. First of all, let's have a brief introduction. As we all know, extraction of the tooth often leads to deficiency of both hard and soft tissues. Gingival augmentation is required along with implant placement for correction of the defect because adequate thickness and width of peri-implant keratinized tissue is important for implant health and good aesthetic results. Various soft tissue augmentation procedures have been recommended for the correction of these defects. Abraham roll technique has been widely used for the soft tissue ridge augmentation in the maxillary anterior region where aesthetic is a prime concern. Now I present a clinical case report which discusses the modified roll technique as an option to treat moderate horizontal soft tissue defect in mandibular first molar region. A female patient, 35 years, presented with an edentulous space in relation to lower right first molar after successful placement of the implant. Clinical presentation as after 3 months can be seen in figure 1A. There was a deficient buccolingual width and the thin keratinized mucosa. Soft tissue augmentations with the augmentation with the buccal roll flap was planned to improve the buccal tissue thickness around the future implant supported prosthesis. So after procuring the adequate anesthesia, firstly 2 full thickness vertical incisions 2 mm from the sulcus of the adjacent teeth were given. They were connected with 1 paracrustal horizontal cut, thus forming a U-shaped zone as seen in figure 1B on the left-hand side. The second step was the deepithelialization of the crustal gingiva area with a round burr 2 mm larger than the cover screw diameter as seen in figure 1B, just below it. The third step was to raise a partial thickness flap lingual to the crust as seen in figure 1C, which was further reflected as a full thickness flap on approaching the crust, extending buccally, followed by rolling the flap into the buccal pouch as seen in the topmost left side of my poster. The last step was to place the healing abutment. A wider healing abutment was used and 6-0 polypropylene microsutures were used. It can be seen in figure 1D. So now coming to the conclusion, if we see the pre and the post op picture in the last in my poster, so the conclusion we make is the buccal roll flap technique as described in this case report resulted in correction of moderate buccal ridge deficiency and increased the bulk of the marginal gingiva, which improved the buccal profile. So the advantages of this technique is that firstly, it resulted in adequate keratinized tissue around the implant, which is essential to prevent peri-implant diseases and mucosal recessions. Secondly, it allowed for faster healing as graft vascularity was maintained. And lastly, a rapid prosthetic restoration was given to the patient. Thank you, sir. Thank you, ma'am.
Can we have the question answers, please?
Dr. Rahul, did you go in for any heart tissue augmentation along with this?
No, sir. Actually, the heart tissue defect was not that much severe. It was within the limits. So only the soft tissue defect was corrected in this case, and we got the results in the post-operative picture we can see.
Okay. So no augmentation was done, heart tissue.
No, heart tissue augmentation was not done. Only with the buccal roll flap technique, we were able to provide a good peri-implant tissue around our implant.
Okay.
Thank
Is there any disadvantage of this technique over other ridge augmentation procedures?
Disadvantage of this technique, actually, ma'am, this technique is used mainly in maxillary teeth. as for now, the publications are only for the maxillary one. In
Okay.
those we have only publications. First of all, Abrams gave a traditional in which the full thickness was raised from the palatal side. Then Tarnow in 1992 gave a pedicle modified roll technique in which 0.6 mm of the tissue as a pedicle was taken out and the epithelium was kept back on the palatal side. But for the mandibular, as such, there is no published article. So this is actually an original, we can say, we have done it. And I don't, it actually, I found it can be done only for the mild to moderate defects only, not for the severe defects, because in that we have to go for connective tissue graft, either with a tunnel approach, VISTA, or some other approaches, and we may need opt for free gingival graft, but for that we have other complications like a secondary donor site. In this, we don't have a secondary donor site, and for the graft healing also, we have like we need to wait for at least 2 months so that it matures, and then we proceed with our processes. But in this case, after 15 days, we can take the impressions, and we can see the result after 15 days. In the last photo, we can appreciate how well our tissue have molded, and without any donor site it is.
Okay, fine.
Thank you.
Thank you. Could we go to the next presentation, please? Dr. Neha, could you begin your presentation with your camera on?
Yes, I have. Am I audible? Good morning, everyone.
Yes, you can proceed.
A very good morning to all of you. My poster presentation is a case report on topic interseptal bone expansion for immediate implant placement using osteodensification technique. First, let's have a brief introduction. Implant stability is one of the most important factors for the success of endosseous implants and is directly related to surrounding bone quality and quantity. Standard drills, which are used in osteotomy preparation, cut and excavate the bone to create room for an implant fixture, reducing the implant insertion torque. Removing the bone bulk is contrary to achieving the primary stability desired. Thus, to prevent the bone tissue from being sacrificed, a new osteotomy preparation technique, osteodensification, was introduced by Dr. Salah Huis. Now I will present a case report in which osteodensification facilitated creation of an osteotomy in the interseptal bone of 2 mm width, which was expanded to 4.3 mm using specially designed Densha burrs. The patient is a systemically healthy 30-year-old female who presented with the chief complaint of pain and inability to chew from right side since 2 months. Clinical and radiographic examination, as seen in figures 1A and 2A, revealed non-restorable previous endo-treated fractured right first molar. A treatment plan was finalized to extract and place immediate implant for a fixed prosthesis to restore tooth number 4-6. Area was anesthetized. Tooth was sectioned with a long shank carbide burr using high-speed drill. The mesial and distal roots were gently removed using periotomy, taking special care to keep the interseptal bone intact as seen in figure 1B. Preparation started with a 1.5 mm initial pilot osteotomy as seen in figure 1C, created with the pilot drill rotated at 1200 rpm in a clockwise rotation. An X-ray was taken with the pilot drill as seen in figure 2B. Osteodensification started with Densha burr rotating in non-cutting clockwise direction at 1200 rpm, that is the densifying mode, and an osteotomy of 4.3 mm was created as seen in figure 2C. And finally, a 4.5 mm fixture was placed in autogenous bone without any thread exposure as seen radiographically in figure 2D and clinically in top right corner of the poster. A wide healing abutment was placed over the fixture and sutures were given. So now conclusion. In this case, we saw how with the use of osteodensification technique, a beautiful crust of compacted and autografted bone was seen around the periphery of the osteotomy as seen in figure 1D. In such low bone density region, increased bone to implant contact and increased primary stability will lead to improved bone healing and long-term success. Thank you. Thank you, sir. Thank you, ma'am.
Doctor, can you please explain the design of the burr?
Sir, the Densha burr, they are specially designed and they are different from the standard drills because they have more number of lands. They have 4 to 5 lands and they are tapered. And the standard drills, they have only 2 to 3 flutes and they cut the bone. But the Densha burr, the diameter is tapered, so progressively the osteotomy size increases and they do not cut the bone. They slide the gliding motion, rather the autografting and the densifying mode, the bone is autografted, sir.
And in what direction does the burr rotate?
Sir, both the modes, they are the cutting mode also and the densifying mode also. When the clockwise direction the burr is rotated, it will cut the cutting mode, and the densifying is the counterclockwise direction.
Okay, thank you.
Thank you,
Okay, is
sir.
there any contraindications for using this Densha burr for osteodensification?
Yes, ma'am. It cannot be used in the cortical bone. Only we use it in the cancellous bone area.
Okay. Any other contraindication? Usually, I think it's indicated in maxillary areas, isn't it? To get a dense bone.
Yes, ma'am. If the bone does not allow us, if the bone is like knife edge or to get a space for the osteotomy to be started, first we can use the lance drill and then we can proceed with this. Otherwise, as such, there's only the cortical bone we should not use it, so, ma'am.
Okay, fine.
Thank you, ma'am.
Thank you. Could you go to the next slide, please? Thank you. Doctor, can you begin with your video on? Who is presenting? Can you please begin?
Velcodontics, periodontically accelerated orthodontic tooth movement. Now, in 2001, Velcodontics was introduced by Wilco brothers, William Wilco and Thomas Wilco, which is a periodontically accelerated osteogenic orthodontic tooth movement, was based on the healing pattern of bone known as the regional axillary phenomena. Now, this is a treatment modality which consists of a periodontal procedure combined with the orthodontic tooth movement. Now, here alveolar corticotomies were performed before the application of the orthodontic forces. It enhances the tooth movement and reduces the aid of a periodontist to perform the decortication of the bone. The main objective of this is that it accelerates the tooth movement by a periodontal approach. Now, a patient of 25-year-old female was referred from the ortho department to the perio department because 2-4 and 1-4 was extracted, but due to some reason, there was no tooth movement was seen. So we wanted to perform this alveolar corticotomies. So flap was raised in this 1-4 and 2-4 region here, and with the help of vertical grooving and ditching in the buccal cortical bone was done with a piezoelectric device, and then the flap suture was placed. Then after that, with the help of a stainless steel wire, it was placed, and tooth movement was observed of in the figure 8 pattern. It was placed, and 2 mm of tooth movement was observed after 3 months. So this it can be concluded that this interdisciplinary amalgamation, this reduce the orthodontic treatment as a whole. Now, the main biomechanics of this Velcodontics is that whenever there is injury or any insult to the bone, this causes the localized surge in the osteoclast and osteoblast activities. Then there is decrease in the bone density with increase in the bone turnover. Now, this causes a tissue response, which is known as the regional axillary phenomena, where the regeneration of tissue is faster than the normal regeneration and healing process. then this causes a transient osteoporotic condition, and thus it facilitates the tooth movement. So this corticotomies, which actually really, causes the bone to get activated in the intended tooth direction. So thus there's increase in angiogenesis, and when pressure is there, in the tooth movement, there's highlighted lesion of the periodontal ligament fibers. But this in case of RAP, that is regional axillary phenomena, this macrophages removes the hyalinization, and bone resorption, transient bone resorption takes place, and this facilitates in the tooth movement. Thank you, sir. Thank you, ma'am.
Okay, can you quote some studies related to this Wilcodontics?
Ma'am, not much studies have done, but the recent studies was 2014 studies by it's a novel synergy of time, Wilcodontics novel synergy with time to save time. It was by H. Srinivas and Shirisha K. et al. And
That's it.
that's it. Yes, ma'am.
And how long was this? Did this patient require ortho treatment? Like how fast could you complete the treatment?
Ma'am, initially maybe the orthodontist did not mention why there was no tooth movement, but maybe he has placed high post. So because of that, we went for this Wilcodontics. So 2 mm of tooth movement, like canine to canine, as a whole, the entire unit it shifted. But of the and so 2 mm what tooth movement was. So actually the patient complained of
recorded.
Yes, it was recorded because the patient complained of class 1 anterior proclination. So we need to fill the gap. So for that, the entire unit moved for 2 mm.
Okay.
Thank you, ma'am.
Was the treatment done for the localized site or the entire upper arch?
It was for the localized site, sir. Only 2-4 and 1-4 area, interdental area. This root prominences were got active. Bone was activated.
Okay. Thank you.
Thank you, sir. Thank you, ma'am.
Thank you. Could we go to the next presentation, please? Yeah, thank you. Dr. Rachna, who is going to present? Can you please start your presentation?
Myself Rachna Pandya.
Myself Faizan Khan.
Myself Maitri Pandya.
And we are going to present a poster on frenectomy with lateral distal flap of function.
There is some disturbance on your side.
Sorry, ma'am.
Yeah. Now we can hear you. Continue.
Okay. Can I start?
Yes, start.
Okay. Today we are going to present a poster on frenectomy with lateral distal flap, a functional and aesthetic concern, a case series. As we all know that the frenum is formed by the membranous fold, which contains connective tissue and sometimes muscle fibers. Plesak et al. In 1974 classified frenum according to the attachment of the fibers in 4 groups: mucosal, gingival, papillary, and papilla penetrating. Clinically, papillary and papilla penetrating frenum is considered as a pathological and have been found to be associated with the loss of papilla, diastema, recession, difficulty in brushing. There are various techniques in frenectomy procedure are like conventional technique, Miller's technique with lateral displaced flap, VY plasty, Z plasty. In our poster, we are performing frenectomy with lateral displaced flap, which is an alternative approach for the primary closure in the midline to avoid unaesthetic scar by the creating a zone of attached gingiva in frenectomy with lateral displaced flap. As you can see in pictures that there are pre-operative pictures in which we perform the tension test, which is positive. After that, we anesthetize that local area and with 2% lignocaine in 1/80,000. And after that, we first insert the hemostat in up to the depth of the vestibule and give the horizontal incision which connecting the coronal ends of these two incisions. And after that, we mobilize the flap mesially, and after that, we give the suturing and the periodontal pack placement. And we advise patient to follow up after 1 week and the 1 month. After 1 month, we see the major advantage that there is a no scar formation in according to this technique. Advantages of this procedure are that the post-operatively on healing, there is continuous collagenous band of the gingiva across the midline rather than the scar formation. And transseptal fibers are not disrupted surgically, so there is no loss interdental papilla, and healing takes place by the primary incision. Disadvantages are that the broad, thick, hypertrophic frenum can be seen above the lateral incisor. Thank you.
Question answers, please.
Okay, for how long were these cases reviewed? For how many months or years were they reviewed?
Ma'am, until 1 month.
1 month. So we don't know whether it's stable over a long period of time, isn't it? Is there any advantage of this, disadvantage of this procedures over other root coverage procedures?
Sometimes the secondary frenum formation on the vertical incision, which we give the parallel to the lateral incisor, in which there are sometimes hypertrophic frenum formation are there.
Okay, thank you.
Thank you. Thank you. No questions.
Okay, thank you. Should we go to the next presentation, please?
Yes, please.
Yeah. Doctor, could you begin?
A very warm good morning to the respected panelists. I am Captain Dr. Sumita from AFMC. I'm presenting a case report on revisiting failures in soft tissue surgery, incorporating best treatment protocols. Soft tissue grafting is relatively common technique for gingival augmentation and treating mucogingival defect. However, failures in soft tissue grafting, it can be stressful for both patient and clinician. Given the right indication and the technique, gingival grafting works well most of the time. Factors that predict the success of the procedure are the type of the defect, choice of the procedure, and type of the graft selected. This is a case report of 27-year-old female patient reporting to Department of Periodontology with a chief complaint of pain and discomfort in the upper right front tooth region since 2 years. On eliciting her history, present case was operated 4 times with episectomy with PRF, FGG, and twice with subepithelial connective tissue grafting. Intraoral examination revealed mucogingival defect with a probing depth of 4 mm, presence of sharp exposed bone, sinus tract, and purulent discharge on digital pressure. On radiographic evaluation, 111213 was RCT treated with 1112 episectomy performed previously. Finally, case was managed implementing protocols that include thorough evaluation, proper diagnosis, treatment planning, careful handling of the soft tissue during surgery, encompassing the principles of microsurgical triad by microsurgical loops and fine cutting instrument. Free gingival graft was placed for the coverage of the defect, and photobiomodulation was also incorporated, which was achieved by low-level diode laser of 6 joule per square centimeter, having positive effect and biomodulatory action on soft tissues. Procedure involved after local anesthesia. Horizontal incision was placed 1 to 1.5 mm away from the gingival margin, exposing the defect, and then the recipient site was carefully inspected, degranulated, and sharp bony margins were smoothened and cleaned of excess tissue tags with epithelialization on the margins, and a template was made to ensure graft of appropriate size and proper contour from the left palatal mucosa. Now, and then it was sutured with 3-0 silk suture at the lateral borders, and finally secured with 5-0 proline for promoting stability and immobilization of the graft. And photobiomodulation, it was performed at multiple settings on the day of the surgery, 4th day, and 1 week, and finally it was restored with the zirconia crown for achieving optimal aesthetic. To conclude, this case of relapsed failure with soft tissue grafting produced significant coverage after the therapy, suggesting various factors governs the success of the periodontal surgery, important of which are appropriate diagnosis, gentle handling of the tissue. This combination modality of free gingival grafting, microsurgery, and photobiomodulation, in this case, improved the predictability and outcome of the procedure substantially to a clinically relevant level as compared to conventional technique without post-operative sequelae. Thank you, sir.
Is there any studies which tell this photobiomodulation is good in such failure cases?
Yeah, ma'am, there is a study given by Hedari et al. In 2012 where they have implemented this photobiomodulation. They have implemented this therapy photobiomodulation after pre-gingival grafting. They have included, they have taken the cases. This is a split mouth technique where they have included these patients, and photobiomodulation has shown a promising result regarding the wound healing, anti-inflammatory effect, by bactericidal effect, and analgesic effect.
Okay, so these are the advantages. And how long was the patient reviewed? Is it 3 months?
Ma'am, the patient reviewed 1 week, 1 month, and 1 week, 3 weeks, 1 month, and 3 months. And now it's 4.5 months, ma'am. Again, we are recalling the patient after 6 months. As per the Marines classification, we in the first year after the therapy, we recall patient every 3 to 6 months. So we are next recalling the patient after 1 month, ma'am.
Okay, thank you.
How many times have you done this biomodulation?
So photobiomodulation we have done on the day of the surgery, sir, and the 4th day and 1 week, and we finally restored with the zirconia crown. Now at a 4-week recall period, when the patient was recalled in the Department of Periodontology, she has no signs and symptoms, and the healing is also promising, sir.
And any hard tissue augmentation have you done in the defect?
Sir, while opening the defect, clinically, we had thorough evaluation, and hard tissue augmentation was not done. Because the patient was already treated 4 times, and we didn't want to heroically jump into any of the procedure, any of the complicated procedure, as it was a guarded prognosis, and we have already informed the patient. So we instead we opted for clot as a substitute for augmentation. So,
oh, thank you.
Thank you, sir. Thank you, ma'am.
Thank you. Could we go to the next slide, please? Yeah, Doctor, could you begin with your presentation?
Good morning, everyone. Today I'll be presenting a poster on the topic Management of Periodontal Intrabony Defect by Modified Vestibular Incision Subperiosteal Tunnel Access Technique, a case report. So here the periodontal regeneration always aims to regenerate the damaged tissue around periodontally compromised teeth. So in this case report, we have described a novel modified vestibular incision subperiosteal tunnel access technique for the management of intrabony defect. So this was first used for rich augmentation, and then it was later used for soft tissue coverage, that is in gingival recession by Zade in 2011. Later, this modified Vista technique was used to treat intrabony defect by Najafi et al. In 2018. And so we have done this technique in a healthy 46-year-old male patient who came to a department with a chief complaint of bleeding while brushing, with a history of difficulty in mastication, and the intraoral examination of the patient revealed a probing pocket depth of more than 5 mm in relation to 1-2 and 1-1, and the radio IOPA in relation to 1-1 and 1-2 also revealed angular bone loss extending till apical third on the mesial aspect of 1-2. So we have devised the treatment plan of the patient to be phase 1, which consists of scaling and root planing, and phase 4, which is recall and review. Then we went to phase 2, that is modified vestibular incision subperiosteal tunnel access technique in relation to 1-2 and 1-1. And then in phase 4, we again recall and we reviewed the patient. So these are the photographs that are showing the technique that we have done. So the first photograph shows you the pre-operative photo and radiograph of the patient in relation to 1-1 and 1-2. So here we have placed 2 vertical incision on either side of the defect in 1-1 and 1-2. Then we have elevated the flap using microperiosteal elevator. Then we have placed a bone graft, that is putty of Morecker, with a particle size of 40 to 500 micrometers. And we have done a suturing where we have used a composite stop, and the vertical sutures the vertical incisions were sutured using simple interrupted sutures. And the post-operative photograph and radiograph shows you the 6 months follow-up of the patient. So this technique is a bit technique sensitive, but it is less time consuming, and access to the defect is very limited, and there is no gingival recession that occurs during when we manage a case with conventional technique. And we can also expect the improved osseous coverage, because we have the primary wound stability here, and besides the patient also has less morbidity, and there is no need for the use of surgical physiological loops and etc. But this technique cannot be applied in areas with less than 2 mm of keratinized tissue height, and this technique also provides limited access to the defect. So here I would conclude that modified Vista is shown to provide a good bone fill and minimal gingival recession in comparison to the traditional Kirkland flap in the treatment of intrabony defect. Thank you.
Madam, couldn't you have done a
Sir, I'm not able to hear you.
Dr. Ankit, we cannot hear you.
couldn't you have done a modified Whitman flap here? Sorry, papilla preservation flap. Sorry.
Yes, sir, we could have done, but the morbidity is more, sir, and moreover, this technique is less time consuming and the patient morbidity is also less. But doing a like papilla preservation flap, there is we can't achieve a primary wound stability. So we have to place many incisions, but in this technique, it is very like simple. We just need to place 2 vertical incisions on either side, tunnel, and place the bone graft directly. So we went for this technique here.
Was any material used for bone graft in this technique for heart tissue augmentation?
Ma'am, I have used no raker putty material, ma'am. It consists of silicium, calcium, sodium, and phosphorus, and many minerals that are naturally present in the human body, ma'am. And the particle size that I have used here is 40 micron to 50 micrometers.
Okay, thank you.
Okay.
Thank you. Could you go to the next slide, please? Yeah. Doctor, could you begin? Dr. Ruchita?
A very good morning, ma'am and sir. Today I'll be presenting a case report on the use of PRF membrane for accelerating healing in gingival depigmentation. To begin with, gingival health and appearance are the essential components of attractive smile, and hence the correction of unsightly pigmented gingiva is the need for a pleasant and a confident smile. The objectives of my study was to compare clinically and histologically the wound healing between PRF membrane and Copac in gingival depigmented wound. The method includes: the first picture shows the preoperative maxillary and mandibular wound. The depigmentation was done using burr abrasion method. A football-shaped diamond grid burr with a feather-like brushing strokes was used for the depigmentation. Following which the PRF membranes were prepared at 2700 RPM for 12 minutes. The PRF membrane were applied on the maxillary arch and the Copac was applied on the mandibular arch. The fourth picture shows the healing on the 5th day after the application of methylene blue dye, which shows more dye uptake in the mandibular arch as compared to the maxillary arch. The results were using the visual analog scale. During the first 5 days, the patient noticed mild discomfort in the Copac sites, whereas no pain was reported on the PRF site. Staining with methylene blue, the dye uptake was substantially less on the PRF sites as compared to the Copac sites because of the more inflammation in the lower arch, leading to more dye uptake. The healing the Copac sites had greater erythematous areas as compared to the PRF sites. The histologic evaluation was performed using a punch biopsy on the 5th day, which showed stratified squamous epithelium with underlying connective tissue and no inflammatory cell infiltrate in the PRF sites, whereas Copac sites revealed mild inflammation and some hemorrhagic areas. So PRF accelerates healing by effective neovascularization and it promotes tissue remodeling, and hence it can be used to shield open wounds. To conclude, PRF membrane can be used to cover the depigmented gingival wound as it promotes healing and it provides a better post-operative comfort. Thank you.
Doctor, how have you managed to suture the membrane? Have you sutured the membrane to the surgical site?
Yes, sir. I had used 40 Vicryl to suture the membrane over the maxillary arch.
And then it was kept open? Or
Yes,
was it
sir.
covered with the bag?
No, sir. It was kept open.
Okay. Are there any studies related to this using PRF membrane for gingival depigmentation?
Yes, ma'am. I had referred a study in GISP in 2018, wherein they had compared PRF membrane, PRF gel, as well as Copac following depigmentation.
So which is superior according to that study? Yes.
PRF, according to that study, they had said that PRF gel was superior. Here again, PRF membrane was superior as it accelerates healing as compared to the Copac sites.
Okay, you said you sutured the PRF membrane. Na? So after 1
Yes,
week, when you recalled, was the membrane still in place or has it had it disintegrated?
It was disintegrated.
Okay, thank you.
Thank you.
Thank you. Could we go to the next slide, please? Doctor, could you begin with the presentation? Doctor?
Good morning, everyone, and respected judges. I'll be presenting my poster on the topic that laser biomodulation after coronally advanced flap surgery in the treatment of gingival recession. Gingival recession is the exposure of root surface due to apical migration of gingival margin. It is more prevalent in male than female. The etiology of gingival recession is multifactorial, followed by faulty toothbrushing, coronally
Doctor, there's some disturbance from your side. We can't hear you clearly.
Am I audible now?
Yes.
Ma'am, hello?
Yes. Now you're audible. You can continue.
Okay. Gingival coronally advanced flap is a predictable method for root coverage, but according to Cairo et al. In 2008, the percentage of root coverage is only 34 to 86%. So modification can be introduced for the success and predictability of CAF procedure. Low-level laser therapy is introduced by Mester et al. In 1971, and it has been used as an adjunct to conventional therapy, and it also has the added advantage of pain reduction, anti-inflammatory effect, and promote enhanced wound healing. So the low-level laser therapy with CAF for the management of patients with Miller class 1 and class 2 gingival recession. Now we come to the case series. Two male patients reported to the Department of Periodontology presenting with Miller class 1 gingival recession, and complete case history were taken, and clinical parameter such as gingival recession depth, keratinized tissue width, clinical attachment level, and proving depth were measured. After that, CAF surgery was performed on the recessed area, and once the suture is done with 50 black silk biomodulation by dentless diode laser with 980 nanometer wavelength, with a setting of output power of 0.3 watt, is used along the suture line for a duration of 30 seconds in a continuous non-contact wave mode. After that, post-operative instruction is given to the patient, and the patient was recalled on the 14th day post-operatively for suture removal. The patient were again evaluated 6 months after the surgery, and uneventful healing and sufficient amount of root coverage were observed during this recall period. Thus, in conclusion,
Madam, our time is over, ma'am.
Okay.
It's more than 3 minutes. Can you have the question answers, please?
Again, how many times have you done biomodulation and what effect did it have on your patient?
Sir, just on the day of the surgery, and the healing, patient reported pain reduction and healing was uneventful.
So how does the low-level laser therapy help?
Sir, it enhanced the healing period, enhanced the healing of the gingival margin.
Okay.
Okay, so the laser was done after suturing, is it?
Yes, ma'am.
Okay, so
To
can you quote?
stabilize the, yes, ma'am.
Yeah, can you quote some studies which shows it is good in
Ma'am,
healing?
like yes, ma'am. Ma'am, like Osturan et al. In 2012, he also did a similar study. For him, he used 580 nanometer wavelength, and he also indicated the improve in predictability of GAF in multiple recession.
Okay, thank you.
And again uses okay. Thank you, ma'am.
Thank you. Could we go to the next slide, please? Yeah.
Good morning, everyone. Today I'm going to present a poster on a collagen matrix versus connective tissue graft in the treatment of gingival recession defects, a case series. Now, as we know, gingival recession is the apical migration of the gingival margin below to the cemento-enamel junction. Now, it causes attachment loss, root surface caries, cervical abrasion, as well as dentinal hypersensitivity. To treat the gingival recession, there are various treatment modalities are available, among which connective tissue graft along with the coronally advanced flap has been termed as the gold standard for the treatment of gingival recession. But it also requires secondary donor site from palate or maxillary tuberosity area. So as an alternative to that, collagen matrix, which is a synthetic bovine porcine collagen, it is available to treat the gingival recession defects. Now in this case series, we have included 16 sites from 6 patients in which Miller's class 1 and 2 gingival recession defects were present. We have included class 1 and class 2 recession defects as we do not want any soft tissue or bone loss present at the recipient site. Now if we come to the methodology, in both the group A and group B, the methodology was same. First, the horizontal incisions, along with that vertical releasing incisions were given. Then the full partial thickness flap was elevated. In group B, collagen matrix was cut and adapted to the recipient site, whereas in group B, connective tissue graft was harvested from the palate by using single incision palate harvesting technique, and it was adapted at the recipient site. And 50 vicryl suture were taken. In result, post-operatively, we took follow-up for 1 month, 3 months, and 6 months, which revealed that the mean root coverage was gained in the group A for CTG. It was 1.87 mm, whereas for collagen matrix, it was 1.5 mm. If we see the gain of the keratinized tissue width, it was 62.5% for the CTG group, whereas it was 50% for the collagen matrix group. So coming to concluding that, we know that the CTG has been already given the good results in terms of root coverage as well as for the keratinized tissue width, but it also requires second surgical site. Even though in this all the cases, the healing donor site healed uneventfully, but connect collagen matrix also showed the good results in terms of root coverage as well as for the keratinized tissue width. So it can also be used as an alternative to CTG in which we do not want any second donor site. Thank you, sir. Thank you, ma'am.
Any difference in the amount of gingival coverage by the two techniques?
Yes, sir. It was more in the CTG group compared to the collagen matrix group. In most of the cases, we have achieved 100% of root coverage for the CTG group, whereas in some cases we have achieved 70 to 80% for the collagen matrix. But there are some technique sensitivity is also there, and main first disadvantage, or we can say drawback of the collagen matrix, it has to be properly stabilized with sutures. Any instability causes the results downfall.
So the difference in the recession coverage, was it statistically significant or was it insignificant?
No, sir, it was not significant.
It was not significant. And what is the same question regarding the keratinized tissue?
Sir, as well as for keratinized tissue, same. It was more in the CTG group compared to the collagen matrix group, because
Statistically significant?
No, sir, it was also not significant.
Okay, thank you.
Yes. Thank you, sir. Thank you, ma'am.
Okay, which collagen matrix, commercial matrix was used in the study?
Ma'am, in this, the mucograft was used, which is available from the gels biomaterials.
Okay, any adverse reaction was noted for any
No,
patients?
no, ma'am, none. Even there was no post-operative pain was present after 1 week.
Okay, thank you.
Yes. Thank you, ma'am.
Thank you. Can we go to the next slide, please? Can we go to the next slide, please? Yeah, thank you. Doctor, could you begin with your presentation?
Am I audible, ma'am?
Yes, you're audible. You can start.
Good morning, respected personnel. I am going to present today's case report on an approach for regenerative treatment with amniotic membrane as GTR with xenograft for human grade 2 periodontal furcation defects. We all know that open flap debridement cannot regenerate the lost periodontal tissues. So if we want regenerative treatment, we have to go for some kind of GTR technique. In this case report, I would like to describe this case, which I had done in my OPD with the help of GTR membrane, with the help of amniotic membrane as a GTR, along with xenogenic bone graft. So coming to its methodology part, a 52-year-old male patient came to our department with the chief complaint of bleeding gums. Upon clinical examination, we found that the patient was suffering from chronic periodontitis along with grade 2 furcation defect. So we did the scaling and root planing at that day, and we recalled the patient after 7 days. After 7 days, the patient was recalled, and on that day, we did the surgical treatment. After achieving full anesthesia, we gave the full thickness. We gave the clavicular incision, followed by raising the full thickness flap. After the whole debridement process, we irrigated that surgical site with copious saline solution, and finally we placed the xenograft at the grade 2 furcation site. For making sure that the graft material is intact in that grade 2 furcation site, we added that amniotic membrane as GTR membrane, and finally we sutured back, the flap was sutured back to its original position. And after 3 months, we recalled the patient, and we saw that there was marked reduction in terms of pocket depth. And after 6 months, we again recalled that patient. We found that there was marked radiographic bone fill at the grade 2 furcation site. So we can conclude that with the help of amniotic membrane as GTR technique, we can achieve the lost periodontal tissue in the cases of chronic periodontitis. Thank you.
Doctor, how did you stabilize the membrane?
Sir, amniotic membrane is an excellent membrane which doesn't need any kind of suture material, basically. It got adhered by its own.
Okay. So suture, the membrane was not sutured?
No, sir. No, sir.
Oh. Thank you.
Okay, is it commercially available? Can you name
Yes,
the
ma'am. It is commercially available. Dry amniotic membrane.
trade name?
Ma'am, trade name is ma'am AmnioCare, I guess.
Okay, and which xenograft was used? You mentioned you've used a xenograft.
Yes, ma'am. Ma'am, it was a xenograft with collagen granules, actually. Ma'am, should I use the trade name?
Yeah, do you know the trade name?
Ma'am,
Of
I
the
cannot
xenograft?
recall the trade
No
name.
problem.
Sorry.
Okay, thank you.
Thank you, ma'am.
Thank
But
you.
the reason why you have used a xenograft and not any other graft?
Sir, it was having some kind of collagen molecules, sorry, collagen particles in that bone graft. So collagen, if the bone graft is having collagen molecules, then it can regenerate the lost periodontal tissue more effectively. So I used that xenograft.
Oh, thank you.
Thank you, sir.
Thank you. Could we go to the next slide, please?
Am I audible?
Doctor, could you begin? Yes.
Very good morning to all.
Can you be a little louder, please?
A very good morning to all respected judges. I'll be presenting my poster on vestibular deepening using modification of periosteal fenestration technique, a case series. Periodontal plastic surgery focuses not only on the biological and functional, but also on improving the aesthetic appearance of the periodontium. Vestibular depth is measured from gingival margin to the depth of the vestibule. Shallow vestibule jeopardizes the maintenance of oral hygiene and thus facilitating plaque accumulation and initiation of gingival inflammation. If there is inadequate vestibular depth, it is accompanied with a minimum or no attached gingiva, then maintenance of oral hygiene is compromised. In case if there is adequate attached gingiva, then no surgeries are advised, but where there is no attached gingiva, then vestibular deepening procedures are performed. Vestibular deepening procedures have always been a point of concern. Various techniques have been developed to increase the depth of the vestibule, including Clark's technique, Kazanjan's technique, soft tissue grafting, vestibuloplasty, etc. Coming to the case series, 3 cases were with a shallow vestibule where vestibular deepening was required, were selected, and vestibular deepening was performed. Under local anesthesia, mucosal incision was made to approximately 2 to 3 mm away from the mucobuccal fold. After the incision, lip cheek mucosal flap and a mucosal alveolar flap were raised, and the muscles and fibrous tissue were dissected. After this, the alveolar mucosa was fenestrated by giving 4 oblique incision, full thickness incisions, and a window of fenestration was created. Following this, sutures were made at the apical level to the lip cheek mucosa was sutured to the periosteum at the most apical level, and the Copac dressing was placed. Following this, after follow-up, the results showed good vestibular depth was appreciated after 2 weeks, as well as after the follow-up of 1 month and 6 months. Another technique which was done by Rajpal in 2013 was where they used periosteal fenestration and used that periosteal pedicle flap for coverage of gingival recession was used in case of inadequate attached gingival width. So to conclude this case series, this technique showed an excellent post-operative outcome. The advantage of this technique was there was less chances of relapse of the vestibular depth, which was achieved after the surgery when compared to the other techniques.
What are the advantages of this technique over the Kazanjan's technique or any other technique for vestibuloplasty?
Sorry, sir.
Advantage of this technique over other techniques?
Sir, there were relapse of the cases like the decrease in the vestibular depth after post-surgical relapse were less, like even after 6 months follow-up, adequate depth was achieved. Vestibular depth, like in case 1 series, adequate vestibular depth was achieved even after 6 months.
Okay.
Okay, for how long were these patients reviewed? Maximum duration?
Maximum duration, ma'am, 6 months.
6 months. So there was no relapse.
There was no relapse till 6 months.
Okay. And can you quote some studies in which this modification of
A
periosteal
study
penetration?
by yes, ma'am, a study by Bhavna Jakupreja, where she did a study where prosthesis was given. Prosthesis was supposed to be given in a patient with edentulous mandible where implants were placed and vestibular deepening was required for prosthesis to be given, where she did the same technique.
Okay, thank you.
Thank you, sir.
Thank you. Could we go to the next slide, please? Dr. Shruti.
Good morning, ma'am. Ma'am, I'm audible.
Yes, you're audible. You can begin.
Good morning, everyone. My poster presentation is on a case report that is called collagen and injectable platelet-rich fibrin with coronally advanced flap in the management of Miller's class 1 gingival recession defect. Gingival recession is defined as the apical migration of marginal gingiva, as well as the fact that later is gradually displaced away from the CSA, thereby exposing the root surface to the oral environment. Among various surgical options available, coronally advanced flap is a widely used procedure. The foremost challenge in any regenerative surgery is direct delivery of growth factors to the tooth surface. To overcome this challenge, PRF is the best option. Moreover, collagen membrane is another biohealing material that mimicking the natural healing. Wound healing is a complex phenomenon, and the simultaneous use of collagen membrane and injectable PRF is expected to enhance this process. In this case, report gingival recession was treated with coronally advanced flap with collagen membrane and IPRF. A 45-year-old male patient had Miller's class 1 gingival recession of 3 mm recession defect in right maxillary canine. After performing oral prophylaxis, surgery was performed. 10 ml of blood was obtained from the patient and centrifuged immediately at 700 rpm for 3 minutes. The upper liquid layer was collected as IPRF. Then the collagen membrane emerged in IPRF for 15 minutes. At the same time, coronally advanced flap was performed. A full thickness flap was reflected till mucogingival junction by giving clavicular incision, and 2 vertical incisions were given, followed by partial thickness flap elevation. Root surface were instrumented and irrigated with sterile saline water. Then at the end, IPRF clot enclosed the collagen membrane similar to a scaffold adapted and sutured on the recipient side. Copac were placed. After 14 days, the patient was recalled for suture removal. And at 6 months, results showed complete root coverage with good soft tissue healing, demonstrating good color and texture of gingiva. To conclude, that this technique showed an excellent post-operative outcome. It minimizes the chance of relapse after the surgery.
Any studies where IPRF was compared to connective tissue graft?
Yes, Durer Rossi et al. In 2019 reported that the addition of IPRF to the coronally advanced flap plus CTG, connective tissue graft treatment, and showed increased keratinized tissue height and decreased recession depth.
Dr. Anila, any question? Yes. Dr. Anila, ma'am?
Yes, sorry, I
Yeah.
had a problem with my connection.
Yes,
So
ma'am.
now it is fine.
Ma'am, any questions for Dr. Shruti?
Okay, so is there any, Shruti, is there any studies you can quote related to this collagen and injectable PRP? PRF?
Ma'am, Raja Rajeshwari et al. Conducted a study on collagen membrane with PRF. With
Okay.
PRF, not IPRF, collagen membrane with PRF, and the result the result in their result there is a good keratinized width of gingiva, and from 5 mm recession depth they achieved 2 to 3 mm recession depth.
Okay, thank you.
Thank you. Could we go to the next presentation, please? Thank you, Doctor. Could you begin with your presentation? Who is presenting this poster? Doctor, anyone here?
Yeah. Good morning, ma'am. Very good morning to all.
Good morning.
My post presentation is periodontally accelerated osteogenic orthodontic a case report. Let me take brief introductions. Adult patient seeking orthodontic treatment to correct aesthetic and occlusal abrasion is increasing significantly. However, successful orthodontic treatment can be difficult in adult patients due to physiological and biological changes and may development causes after a particular age and average orthodontic treatment. Biology of periodontally accelerated osteogenic orthodontic. The rapid tooth movement produced after POW is substantially different than the periodontal ligament cell-mediated tooth movement. It is the movement of teeth due to demineralization and remineralization of the alveolar bone and around the tooth by normal healing process. According to POW case selection, POW can be used to accelerate tooth movement. In the most of the case requiring orthodontic treatment, it particularly effective in treatment of moderate to severe crowding in class 2 malocclusion requiring expansion or extractions and mild class 3 malocclusion. According to Dilbert 2019, indications of POW, dehiscence and fenestrations on the prominent root surface POW and not only prevent formation of new fenestrations and dehiscence, it can also convert existing one, ultimately leading to indicate bone volume. According to Dilbert 2019 contraindications, patients with severe active periodontal disease and patients on the medications such as biphosphonate, NSAIDs, steroids with disturbs bone remodeling. In this case, flap design, the basic flap design is a combination of a full thickness flap in the most coronal aspect of the flap and a split thickness dissection performed in the apical portion of the both surface of the alveolus vertical, releasing incision or giving if required. After that, the decortication, the purpose of the decortication is to initiate the rapid response. Vertical corticotomy cuts are made between the roots using a diamond per size to stopping just short of the alveolar crest. These cuts are connected beyond the apical of the teeth with scalloped horizontal cut. After that, particulate bone grafting is done is the most areas that have undergone corticotomies. The volume of graft materials used is dictated by the direction and amount of tooth movement predict the predominant thickness of the alveolar bone and the need for level supported by alveolar bone and precision. After the
It's time up, sir. We're already done with 3 minutes. Could we have the question and answers, please?
What is the average time action that happens when you use technique of treatment?
Sorry, sir, I can't hear.
You use technique to accelerate. Okay. So, what is the amount of time that is reduced?
Time reduced, not the tooth segment of the faster regeneration is.
How fast is the movement?
2 to 3 times after the pout, the regional accelerated from the
Okay, thank you.
So that I can.
Dr. Anila, can you ask the question,
Yeah.
please?
Was the procedure done from only in the upper arch, from canine to
Yes,
canine?
Yes, sir.
Okay.
Only
And how
upper arch.
fast was the treatment after doing this?
Faster going to have to full treatment of the 2 to 3 times. Further, it's 1/3 of the time required for traditional orthodontic treatment.
But for this case, how when was the treatment finished? Orthodontic treatment finished? Yes. Okay, no problem. Thank you.
Thank you.
Thank you. Will you go to the next slide, please?
Good morning, ma'am. Am I audible?
Yes, you are audible.
Okay. So my case report is on smile designing with gingivectomy using choose aesthetic gaze. In orthodontic treatments, gingival hyperplasia is very common due to local irritants along with plaque accumulation. So most of the time, simple phase 1 therapy, non-surgical therapy is initiated, and that regresses the situation. But many is the time, because of the growth of the gingiva, only non-surgical treatment is not possible. So we had this patient, a 26-year-old patient, undergoing orthodontic treatment for malocclusion. Her treatment had already commenced for almost an year, but she developed hypertrophic gingiva in her anterior region during the treatment. And she personally had this, she was very apprehensive about her appearance. Hence, she wanted that to be corrected immediately. Her anterior aesthetic was a concern to her. So she was from orthodontic department. She was referred to periodontics for further management. So what we did was we saw that there is pseudo pocketing and there is gingival hyperplasia in the anterior region, and we had to correct that. So as it was the anterior region, aesthetic was a concern. We needed to use a proper proportionate clinical procedure for which we needed an instrument. We had choose aesthetic gauge by Hugh Frady, which was invented by Dr. Stephen Chu. This instrument is basically used for crown lengthening. It has three parts: the proportion gauge, the the crown lengthening gauge, and the sounding gauge. So they had the total. There are 6 tips, out of which 2 tips were used in our case. The T bar, which is the proportion gauge, which has it is a T shaped, which measures the crown, the length and width simultaneously. And we use the papilla tip for management of the papillary and height, as there was extensive papillary growth as well. Now the T tips has color coding. The upper margin of the red coding was for the central incisor, simultaneously the blue for the lateral incisor. So no cast was required. We could do it very fast. We used the T tips with we did gingivectomy by external bevel incision and gingivoplasty of the papillas. So finally, we increased the crown height to about 3 to 4 millimeter, and proper interdental papilla shape was achieved. Hence, the rationale for this treatment was, as aesthetic was a concern, we needed proper proportions of the teeth, and aesthetic was achieved very beautifully by just a simple procedure, as we used a very authentic instrument. Thank you, ma'am.
Did you take the biologic width into consideration?
Sir, yes, sir, we did, for which the sounding gauge is used, but there was pseudo pocketing. We measured that. There was around 3 to 4 millimeter increase in the height.
So the biologic width was not violated.
No, sir, biological width was not violated. We checked that the patient had pseudo pockets, sir.
Okay. And how did you do the gingivectomy, with what instrument?
Sir, we used a 15 number BP blade we did an external bevel incision, and we used Castrovizio scissors for gingivoplasty.
Okay, thank you.
Okay, so can you mention some advantages of this choose aesthetic gauge over using routine stents?
Yes, ma'am, because this is they have standardized the measurements in this instrument. Also, simultaneously, we can measure the width and the height of the crown, and because the golden proportion of the anteriors are necessary, the standardization can be used faster in this case, and disproportionation of the mirror images of the crown will be less. So basically, it is standardizing and making the procedure faster.
Okay, and all the 3 tips were used for this?
Yes, ma'am. Not all the 3 tips. Basically, we needed T tip for the measurements and papillary tips, ma'am.
Okay, thank you.
Thank you.
Thank you. Could we go to the next slide, please? Doctor, could you begin with your presentation?
Am I audible?
Yes, you are audible. You can proceed.
Good morning, everyone. Welcome to my poster presentation. Topic of my poster presentation is the minimal invasive periodontics. Now, the periodontal regeneration is the intramonic defects has been achieved with the different principles. These include the barrier membranes, demineralized creased bone, allograft and xenograft, many combination of the barrier membranes and grafts. So basically, there is in fact, from the last decade, so there are the special emphasis has been focused mainly on the design and the performance of the surgical procedure for the periodontal regeneration. So basically, specific surgical approaches have been proposed to preserve the soft tissue and to reach the stability of the primary enclosure of the in order to seal the area of the regeneration from the oral environment. So minimally invasive surgical therapy is a surgical technique using of the small incision, which is indicated for the promising the regenerative therapy in periodontal defects. The exclusive property of the minimally invasive surgical technique is that it includes the chair time required to perform the procedure and result in limited mobility to the patient during the surgical procedure as well as in the post-operative period. So the main objective of this therapy is to assess the clinical and the radiographic effectiveness of the minimally invasive surgical technique in the treatment of the periodontal intrabony defects.
Coming to the methodology, the two clinical cases with the intramural defects were included, in which the defect is mainly assessed by the two papilla preservation technique. According to the anatomy of the interproximal space, it could be classified into the simplified papilla preservation and the modified papilla preservation, in which the here we can do the intracircular incision has been made to preserve the height and width of the gingiva. Their mesorystal extension is kept at the minimum to allow the corona-apical elevation of the very small full thickness flap, with the objective to expose just 1 to 2 mm of the defect associated with the residual bone crest. The shortest mesorystal extension of the incision and the minimal slab reflection occurred at the intrabony defects. The debridement of the defect and the root conditioning will be carried out with the 24% of the EDTA will be applied on the instrumented root surface for the 2 minutes. The area will be carefully rinsed and with the saline. Root instrumentation should be carried out. And after that, the bone graft materials should be placed and the flap will be closed with a suture, 4-0 silk sutures. So basically, the result, these cases reveal the microsurgical SS flap is with the high potential to seal the healing wound by the primary closure, and the soft tissues were the mostly preserved, reduction in a pocket depth, and a minimal gingival recession has been observed. So basically, the minimal invasive surgical technique alone or the combination with the regenerative material has to be achieved the predictable clinical outcomes for the regenerative periodontal therapy. Thank you.
Is this the study that you have conducted or is this a case series?
It's a case series.
Okay, so only 2 patients have been done.
Yes, sir.
Right. And what bone graft are you using?
Sir, allograft. Especially in this case, I have used a Novabone Patti bone graft.
And any type of magnification that has been used?
Yes, sir.
What magnification has been used?
I have used microsurgical loops, and for the instrumentation, I have used mini and micro curettes.
Okay. Thank you.
Okay. Is there any studies related to this minimally invasive techniques?
Yes, ma'am. There are lots of studies based on this minimal invasive surgical technique. Eleni et al. had done lots of studies, and in which there is a study on 2006, there is a study on 2007, study on 2011, which all was done by the Cortellani et al. He had studied this minimal invasive surgical technique with different bone graft material, especially he also studied the minimally invasive surgical technique with the emlogging and also the combination of the bone graft plus the GTR technique. So he had done different types of the combination bone graft material and other.
Okay, thank you.
Thank you. Could we have the next slide, please?
Am I audible?
Yes, you're audible. You can proceed.
Very good morning to one and all present here. Today, my topic of presentation is Aesthetics Unveiled, a case report. Before going into it, first we'll see about a brief introduction. Any feeling of pleasure, happiness, joy, laughter, or simply greeting leads to smile, which result in exposure of teeth and gingiva. A harmonious smile is determined not only by shape and position of the teeth, but also by the color and position of the gingiva. Excessive gingival display and gingival hyperpigmentation are the major concern for large number of people visiting the dentist. Etiology of excess gingival display include vertical maxillary excess, gingival hyperplasia, or altered passive eruption. Excessive gingival display due to gingival hyperplasia or altered passive eruption can be efficiently corrected by means of gingivectomy alone or in combination of gingivectomy along with osseous recontouring and apical vertical maxillary excess can be corrected by means of complicated resective osseous surgery. Next, we'll move on to the etiology of hyperpigmentation. Hyperpigmentation of gingiva can be either because of physiological factor or pathological causes. It can be corrected by means of scalpel method, burr abrasive technique, laser method, cryosurgery, electrosurgery, chemical method, free gingival graft, or ASLR dermal matrix. Next, we'll move on to the case report. A 25-year-old female patient reported to the Department of Periodontology with a chief complaint of black gums and excessive gingival display which affected her smile and speech. On clinical examination, it was found that the clinical crown was much shorter than the anatomical crown, and the patient also had a personal desire to have a longer teeth along with the correction of dark gums. Periodontal plastic surgical procedure combining gingival depigmentation and aesthetic crown lengthening was performed in maxillary arch using diode laser of 980 nanometer in a gated pulse mode at a power of 2 watts using fiber optic delivery system in a contact mode. Whereas depigmentation alone was done in mandibular arch by burr abrasive technique using low speed rotary instrument. After giving adequate local anesthesia, a grid football-shaped diamond burr and long tapered diamond burr was used to denude the pigmented epithelium. The patient was reviewed after 1 week. Healing was satisfactory with no post-surgical complication. The gingiva appeared to be firm and pink with slight pigmentation. The patient was satisfied with the color of the gingiva. At the end of 1 month, the patient was again reviewed. Re-epithelialization was completed. However, certain area of repigmentation were seen. Both the technique shows satisfactory result, but laser method have given many advantages such as bloodless field, better patient comfort, less postoperative pain, and shorter operating time. Whereas the burr abrasive method was simple and economic for the patient, but caused more postoperative pain and discomfort, and it was also time consuming, and repigmentation were seen in some areas when compared to that of the laser method. Finally, I would like to conclude that the restoration of proper smile is significant not just because of its aesthetic value alone. It brings whole lot of socialization by boosting
Sorry,
itself.
doctor, we are out of time. Can we have the question answers, please?
So can you just throw some light on the recurrence rate of the pigmentation when you use laser or any other method?
Sir, study done by Kapoor et al. And Samir et al. They showed they used the scalpel method and burr abrasive technique. There in burr abrasive technique, there is more chance of repigment. After they did around 20 cases. In that 20 cases, 5 cases there is a repigmentation which was treated by a burr abrasive technique. Sir.
But after how long?
After 6 months, sir.
And anything for laser as to how long would the recurrence happen?
Laser in many studies there was a repigmentation was seen by using a diode laser. It was recurrence was there after 12 months. Out of the 12 patients which are treated, only 2 patients were recurrence were there, sir.
And the crown lengthening that you did included any osseous recontouring?
No, sir. No, sir. Biologic weight was checked. There is no amount of maintained, sir. So adequate pseudo pockets only there. So we didn't do any osseous recontouring procedure. Just crown lengthening alone we did, sir.
And that was done with the laser?
Yes, sir. Yes, sir. With laser.
Okay, thank you.
Okay, in the 2 cases you did you review for recurrence? Was there recurrence in any of
yes,
this
ma'am.
case?
The picture was post-operative 1 month was there. Now again the patient came 2 days back. There was again a mild repigmentation were seen in mandibular arch, ma'am, which was done by burr abrasive technique, ma'am. Upper which was done by laser, it was same as before, ma'am.
So recurrence seen more with the burr technique.
Burr abrasive technique, ma'am.
Okay, thank you.
Thank you. Could you go to the next slide, please? Yeah.
So
Yeah,
good
doctor.
morning. Yes, ma'am. Good morning, ma'am. Am I audible, ma'am?
Yes, you can proceed.
Okay, thank you. Good morning. So topic of my poster presentation is autologous dentin, an enhancer for bone regeneration. So different graft materials have been used for the bone regeneration. Among the various graft materials available, autogenous grafts are considered as a gold standard materials because of its properties like osteogenesis and due to the no risk of the disease transmission. So in this present case report, autologous tooth graft material was used, which was obtained from the extracted tooth. And it also has properties like osteoconductive and osteogenesis, and it also has excellent biocompatibility properties, and it shows high bone formation activity. So the aim of the present case report is to evaluate the clinical efficacy of autogenous tooth grafts in the treatment of intrabony periodontal defects. So clinically, the probing pocket depth and cal were recorded, and radiographically, the percentage of the bone fill was calculated by using the CBCT. So following the initial examination and treatment planning of the patient, patient underwent phase 1 therapy and also reevaluated after 3 weeks, and later surgical procedure was done, in which LA was administered, and LA was administered to both the extraction site and also surgery site, and then tooth was extracted, and patient was then subjected to the flap surgery. Incision was given, and full thickness mucoperiosteal flap was elevated, and complete debridement was done. And coming to the preparation of the tooth graft, after extraction of the tooth, any debris and calculus that was present on the tooth surface was completely removed, and the prepared clean tooth surface was then placed on the grinding sieve next to the blades in smart denting grinder, from which the graft material was obtained. And to this, the dissolving agents like 20% ethanol was added, by which the organic substances which get dissolved, and then it is again dehydrated by using the saline, and the excess solution was removed by using the gauze, and this graft material was properly packed and condensed into the defect area. And then the flap was again bring back into the original position by using the sutures, and it is covered by using the periodontal dressing. After 14 days, sutures were removed, and patient probing pocket depth and cal were recorded after 9 months, and also percentage of the bone fill was recorded by using the CBCT after 9 months, which showed that there was decrease in the probing pocket depth reduction, and there was increase in the clinical attachment level, and there also significant increase in the percentage of the bone fill was observed in the CBCT. So based on all these findings, I would conclude that the use of the autogenous tooth graft may also show predictable results in the treatment of the intrabony periodontal defects. Thank you, ma'am.
So will this graft act as osteoconductive, inductive, or genic?
It has a properties like osteoconductive properties, sir.
And what is the particle size that you get after grinding?
And the particle size should be in the range of 300 to 1200 microns. After preparation of the graft, if we feel like it is a bit more in size, we can also place it in the sieve grinder, and also we can go with another round of grinding.
Thank you.
Okay, and when is the tooth extracted? Is it extracted before and the graft prepared prior to the surgery?
No, ma'am. Before performing the flap surgery, the extraction of the tooth was done, followed by preparation of the graft, and then after opening of the flap and complete debridement, and preparation of the graft was done, and then it was placed into the defect area.
So it is in the same sitting, this preparation
yes,
of
ma'am.
the
Same
graft
sitting.
and surgery. Any disadvantage of using this autologous dentin?
No, ma'am. No disadvantages. No, ma'am.
Okay.
Preparation of the graft is also it also takes minimum time. It requires just 5 minutes is enough for the preparation of the graft.
Okay. Okay. Thank you.
Thank you, ma'am.
Thank you. Could you go to the next slide, please? Dr. Soumya?
Yes, ma'am. Am I audible, ma'am?
Yes, you're audible. You can proceed.
A very good morning to one and all gathered here. I'm here to present about management of intraoral scar. As per the quote, the management of a scar which we cannot see is the most hardest to establish. Intraoral scars are relatively rare because when we compare with an extraoral environment, the presence of saliva, the type of fibroblast, and also the phenotype of the mucosa and difference in angiogenesis and inflammation relatively reduces scarring in an intraoral environment. But intraoral scarring is not completely negligible when there is sufficient or traumatizing incisions given, or a suturing where over approximation of tissues have been done, or due to a very severe trauma, intraoral scarring are occurring, but we are not very aware, and we're missing it in such situations. According to Park, Jardins et al., the spectrum of intraoral scarring the spectrum of intraoral scarring ranged from the cleft lip and cleft palate management to there are many scarrings in such cases. So I'm here to present
I request others to please mute yourself. The speaker would get distracted. Thank you.
Thank you, ma'am. So the spectrum of intraoral scarring ranged from the management of, in cases of cleft lip and cleft palate, where severe defects were there, we could see severe scarring, and also in the injuries of labial and buccal mucosa and vestibule. Here, a patient reported with the intraoral scar. His chief complaint was the inability to operate his lower lip like he could do before 2 years. Before 2 years, he faced with a road traffic accident, after which an extraoral suture was given for the laceration of the lip. The extraoral suturing was very severe that it resulted in an intraoral fibrous band of scar, which extended from the labial mucosa to his alveolar ridge. So we plan to go with releasing the fibrous mucosa and also keeping the vestibular line in line with the other dentulous region. So Clark's technique was employed here. Instead of giving the incision on the alveolar ridge, we decided to go with the mucogingival junction. So after which a supraperiosteal dissection was given, and PRF membrane was used to separate the labial mucosa from the exposed periosteum. PRF also helped in healing to a greater extent. So after 2-month follow-up, we could see the removal of the fibrous scar tissue along with the gain in vestibular length. So what we have concluded is, though these scars are rare in intraoral environment, unlike extraoral scar, intraoral scars have a functional debilitation. In extraoral scar, the main thing is the aesthetic concern, whereas in intraorally, we have a compromise in function, which therefore should be identified and treated. To heal someone's scar is the best thing we could do, and that's how I wish to conclude my presentation. Thank you.
What technique of vestibuloplasty was used?
Sir, we employed a modification in Clark's technique, sir. In original Clark's technique, they give the incision at the alveolar ridge. Here, we wanted to preserve the keratinized tissue present, so we opted for the mucogingival junction line, sir. So a horizontal incision were placed at the mucogingival junction, and supraperiosteal dissection was given according to Clark's techniques.
Okay.
Okay. Is there any other case reports in which this PRF has been used for scar healing?
Scar healing they have not done, ma'am. Actually, they have used PRF along with vestibuloplasty to support the vestibular healing, ma'am. But removal of scar tissue along with PRF, we have tried with other support, ma'am. With vestibuloplasty's experience, we have tried it for removal of scar tissue, ma'am.
Okay. In this patient, because of the scar, the patient had any problems because of the scar?
Yes, ma'am. Because of the scar, he had inability to operate his lower lip like he could do before. Before the trauma, he was able to brush and use the function of the lower lip was compromised, ma'am. He was unable to open it like he could do before. So it was his chief complaint with which he reported to us. After the surgery, he was actually comfortable with operating.
That's good.
Thank you. Thank you, sir.
Thank you. Could we go to the next slide, please? Yeah.
Very good morning to all sir and ma'ams present. Hello, am I audible?
Yes, you're audible. You can proceed.
This is my case report in which I am going to present as a gingival depigmentation through various approaches. With a brief introduction, I'm going to start as a beautiful smile surely enhances the individual's self-confidence. Gingival pigmentation is present as a diffuse, deep purplish discoloration or as irregularly placed, irregularly shaped brown and light brown or black patches or strands because of cumulative contribution of byproducts of melanin, melanite, keratin, oxyhemoglobin, bilirubin, reduced hemoglobin, iron, or pathological diseases and conditions. Furthermore, environmental risk factors may also add up to the process of hyperpigmentation actively and passively, which can also be backed up with the ethnicity and age. To overcome the aesthetic concern, we undertake a perioesthetic treatment modalities known as gingival depigmentation. In my first method, I have used with a scalpel, in which I am going to remove surgically the gingival epithelium along with a layer of the underlying connective tissue under adequate local anesthesia and allowing the denuded connective tissue to heal by secondary intention. It has a lot of advantages as well as disadvantages, in which in advantages it is non-expensive, less armamentarium is required, and less chances of recurrence. And disadvantages as if like no clear surgical field because of lot of bleeding and requires dexterity of clinician, and post-operative swelling and scarring is also seen, and also the patient experiences post-operative pain. And method 2, in depigmentation by using a burr. This involves depithelialization of the pigmented areas of the gingiva by using high-speed rotary burrs after giving adequate amount of local anesthesia using a medium-grade football-shaped burr, diamond burr rather than small-shaped burr. Advantages over it is like simple and less discomfort to the patient, easy to perform and economical. Disadvantages as if you use a high speed, then it can cause excessive tissue removal. Fitting of gingiva, inappropriate application may also result in gingival recession, injury to the underlying periosteum and delayed wound healing and enamel loss. Third method which I have used is used of the chemical methods, in which it is very easy is for application and no anesthesia is required, no bleeding and scars is also seen. Disadvantages like we cannot control the depth of it, and it is a treatment that it destroys epidermis and other epidermis using chemical agents. Commonly used peeling agents are phenol, salicylic agents, glycolic acid, and trichloroacetic acid. And as a conclusion that there are multiple methodologies that can be used to carry the process depigmentation. Few are gold standard, few are with no or minimal side effects, and few are less frequently practiced. However, all the methods of depigmentation have shown a considerable result in elevating the aesthetic objectives of depigmentation procedure. Thank you.
Can you throw some light on the recurrence rate of all these surgical techniques?
Yes, sir, there is a lot of recurrence in a burr ablation technique, because we are superficially removing the epidermis and we are not going until the connective tissue. So there is a chances that recurrence may occur in a burr ablation techniques.
Right, but recurrence is least in which of these techniques?
Yes, sir. Pardon, sir.
Which of these techniques result in least amount of recurrence?
Least amount of recurrence we have seen with using a scalpel, as we are removing the underlying connective tissue also.
Okay, while using chemicals, which chemical was used for depigmentation?
Ma'am, TCA, that is trichloroacetic acid, which I have used.
Okay. Did you find any disadvantage of using this?
No, not as such I have seen.
Okay, and in recurrence rate, was there any difference when chemicals were used compared to burr method? Yeah,
No.
the recurrence.
The recurrence rate I've seen in a burr ablation techniques, because as I've already said that because we are using a light feather movement for removing only of epidermis. So the recurrence of repigmentation is more in burr ablation than that of the chemical method.
And how long were the patient reviewed?
Ma'am, 2 weeks.
Maximum duration? Yeah, maximum for till how long were they reviewed?
After 12 weeks also.
Up to 12 weeks. Okay.
Yeah.
Thank you.
Okay. Thank you, ma'am. Thank you, sir.
Thank you. Could we go to the next slide, please?
Yeah. Acha hua na mera?
Hello, I'm audible, ma'am.
Yes, yes, you're audible. You can.
Very good morning to everyone. Poster presentation, a case report on topic root coverage using tunneling and free gingiva, which is a two-stage approach. Usually, we all know that root coverage, which is used to widen the attached gingiva, where it is initially described.
Doctor, you lost your voice. You're mute.
Yes.
Yeah.
Yeah. Okay.
Yeah,
so,
now we can hear you.
Okay, usually the free gingival graft is used to create a widened zone of attached gingiva. Initially, it was described by John, whereas the name was given by Neyman and P.D. Miller, who introduced this graft for root coverage procedures. So initially, a patient named 26-year-old female patient who is reported to the Department of Periodontology, the chief complaint of receding gums in lower front tooth regions. In clinical examination, there is a lack of attached gingiva and also shallow vestibules with 6 mm of loss of attachment present. So at a two-stage procedure, at first stage procedure, we have planned for tunneling technique, that is with the vestibuloplasty with tunneling approach, horizontal incision which is given at the mucogingival junction, which is obliquely extending from 3 to 3. Where a full thickness flap has been elevated and a subpapillary connective tissue and a connective tissue which has been procured, which is seen in the third pictures, where the connective tissue is procured and which as a tunneling, a partial incision which is given in the both side of mesial and distal of relation to 4-1, and a tunnel with the tunnel approach, graft has been procured in that region. And stabilizing suture which has been given, followed by sling suture which is given, and other region of 4-1 and a post-operative injection which has been given. This is the 2-week follow-up and the 2-month follow-up, where we can clearly evidence that there is presence of adequate attached gingiva with we can able to get attachment gain of 3 mm, which has been attained. Still, it is in an organic union phase. Then we have gone for second stage procedure, that is pre-gingival graft, where a graft has been procured from the palatal region. Before procuring, we have made a template at the site of recipient and the donor, and the procured graft is trimmed and placed at the region. Before placing, we have done de-epithelialization at the forward region, then followed by placing the graft and placed in intended sling sutures and stabilizing sutures for the graft placement. This is the 2-month follow-up, where we can clearly evidence that there is attachment gain of around 3 mm, which has been given. Still, it is in a 2-month follow-up only. The patient has to report after 3 months and 6 months according to Merin's classification. The main indications of these procedures to increase the keratinized tissue and also root coverage or denuded root surface. Since patients primary concern was aesthetic and sensitivity, so we have done a 2-stage approach. The advantage is simplicity, high predictability. We can treat multiple days and also less post-mortality will be there. Thank you. Thank you, sir.
What class of recession were you treating?
Class 2.
According to Miller's classification?
According to PD Miller's class 2 regional recession. Hello, sir. Am I audible?
Yeah, got it. Thank you.
Thanks.
Okay, so first stage, you said vestibuloplasty is done. So
Yes,
using which
first
technique
stage
is this done?
vestibuloplasty as a modified Kassanjian technique with the tunneling approach we have done.
Okay. So is there any other case reports in which this 2-stage procedures is followed for recession, class 2 recessions? Any other reported case reports or studies?
Reported as study by Eagle et al. In Journal of Clinical Peridontics in 1988, a classical study where they have done modified Kassanjian with subhead connective tissue graft. So the graft has procured at that region around 33%.
Okay, thank you.
Hello, ma'am.
Yeah, thank you.
Thank you.
Thank you. Do we go to the next presentation?
Hello, ma'am. Am I audible?
Yes, you're audible. You can begin.
Okay. Good morning, ma'am. Good morning, sir. Today I'll be presenting a poster on guided bone regeneration, rebuilding what has been lost. So implant therapy is a major part of dentistry right now. Most of the aesthetic and posterior regions are treated by implant placement, especially in the edentulous regions. But we also know that if there is deficit bone width, if there is, if not enough bone width or height is available in the region, not all cases can pertain to proper implant placement. So deficit bone width in post-extraction heel sockets are a common finding nowadays owing to after extraction therapy, management of which is usually difficult, but in many cases can be managed by guided bone regeneration, GBR, to prepare the site for implantation later in the future. So my case was something similar to that. The patient came to our department with chief complaint of missing tooth in relation to one tooth. So upon clinical and radiographic observation, a defect was detected, and then the site was prepared for GBR. So following proper phase 1 therapy, the surgical procedure was performed, where 2 vertical incisions were placed along with a mid-crestal incision in the area of the defect, following which a proper full thickness mucoperiosteal flap was reflected. After careful debridement and cleaning, the defect size was measured, which was about 9 to 10 mm of size, and the bucco palatal dimension was about 6 mm. So after cleaning and debriding and proper cleansing of the area was grafted with DFTBA, which is demineralized freeze-dried bone allograft. Although I have not mentioned it in the presentation, I also used Colacast, which is a xenograft in the area. After which the graft was covered with a chorion membrane, the chorion membrane was cut according to the chorion membrane was cut 2 millimeter more than the size of the defect, and it was carefully stabilized on the region. Chorion membrane was used in place of non-resorbable membrane because patient was not willing for a second surgical re-entry for removal of any non-resorbable membrane. Therefore, the membrane was stabilized and sutures were taken accordingly. The last panel shows a follow-up of the patient after 4 months of the surgery. Although the bone height is still not very appreciable, there is still some positive result that can be seen. Bone has been formed in the region. Although the resorption of the granules is still not complete, so we are still waiting for 2 to 3 more months, after which implantation can be done in the region. So, to conclude the session, guided bone regeneration can be still one of the gold standard and one of the best techniques to follow if implant placement cannot be done in any region owing to deficit bone region. Thank you.
Any decortication was done?
Sorry?
Decortication was done.
Yes, sir. Decortication was done. Sir, decortication was done
What are
using
the advantages?
Sir, decortication.
Advantages of decortication?
Sir, it provides vascularization in the region, so that helps in further the resorption of the granules to form bone.
And what could be the potential disadvantage of using a chorion membrane in such a case?
Sir, one of the main disadvantages is that it is still a resorbable membrane, so it would resorb at a faster rate than that of the resorption of the bone graft particles. So, because of that, it is one of the major disadvantage. And according to GBR, it should ideally be a non-resorbable membrane where it would give enough time for the granules to resorb and for bone to for the area to be isolated for bone to form in the region.
And also, it won't be stiff enough to maintain the space.
Yes, sir. Chorion membrane, although it is slightly, sir, it is. I can't exactly say elastic, but it is a little less stiff, so it is more prone to distortion of if not maintained properly.
Yes, thank you.
Okay, you mentioned 2 bone grafts were used, isn't it?
Yes.
So why was it DFDBA plus 1 more graft? Why was 2 grafts used?
Ma'am, there have been many studies which have been performed which show synergistic effect when allograft and xenograft are used. There was also another composium guideline which was released in 2019 by Alessandro Gucci, and he also along with other doctors, they also mentioned that usage of DFDP or any other allograft with xenograft shows better results compared to standalone when used standalone, like alone DFDP or alone xenograft.
Okay, thank you.
Thank you, ma'am.
Thank you. Could we go to the last presentation, please? Thank you. Dr. Hira?
Yeah, am I audible?
Yes.
Yes, I'm over here. Am I audible?
Yeah. Yes, you're audible. You can start.
Yeah. Good morning, everyone. Today I'll be presenting a case report on simultaneous implant placement and bone augmentation and an unconventional approach to an age-old dilemma. The placement of implant in an anterior aesthetic region is already a main challenge for the clinician. When there is a defect in the region, it is even more complicated. So we can manage these cases when doing a simultaneous implant placement and the guided bone regeneration. Over here, a 65-year-old male patient came to our hospital with a chief complaint of missing tooth in the anterior region. After the clinical and the radiographic investigation, we reduced a defect of 15 mm to 6 mm in length and width. You can see over here the post pre-op pictures, and after placing incision, the mucoperiosteal flap was reflected, and after the proper debridement and the cleaning of the defect, you can see over here the 16 mm length of the defect and 6 mm width of the defect. After this, the implant placement was done, which was engaged in the palatal as well as the distal wall of the defect. Now, this implant was then treated as we treat a dehiscence defect, which includes we are doing grafting on the implant. Now, the graft that we have selected to use is a combination of IOS and DFTBA. IOS is a xenograft, whereas DFTBA is an allograft. Now, on this Korean membrane was placed. Now we are always again using PRF membrane for better result compared to scarring. When for the post-op results, the last picture shows the suturing and the post-op IOPA, and you can see the quite good bulge that we have found after the grafting. This surgery was performed around 1.5 months before this period. So we are waiting to see the results of this.
Can others please mute yourself, please? Yeah, thank you. Question answers, please.
After how much time would you go? After how much time would you go in for the second stage surgery?
So I would like to wait for at least 5 to 6 more months before we enter the site.
And what temporization and sort of time?
So we did give him a wing retainer for after 1.5 months, which was just recently, because it's a interior tooth, so it would he was very conscious about the way he looked.
It would be better if you had put that photograph also.
Sorry, sir?
It would have been better if you had put that photograph also.
Yes, sir.
Okay, thank you.
Thank you, sir.
Okay, no questions. Thank you.
Thank you, ma'am.
Yeah, I think this is the end of the session. Yeah, I would like to thank Dr. Anila and Dr. Ankit for judging our session. And we'll be sending you an email address. We would like you to send the evaluation sheets to the email address. Thank you. Over to Dr. Rashmi.
Hello, good morning, everyone. Am I audible? Hello?
Yes, ma'am, you're audible.
Thank you. Thank you, Shituja. So
Thank you,
now we'll start with the second session for the day. Okay. So for today's session, we have Dr. Nagaraj Kalburgi and Dr. Ashu Bharadwaj. Sir, good morning to you.
Good morning.
Good morning, ma'am. Good morning, ma'am. Ashu, ma'am, are you there? Ashu, ma'am. Janvi, can you please check whether ma'am has joined in?
Okay, bye.
Good morning, ma'am.
Good morning. Good morning. How are you?
I'm fine, sir.
Thank you.
I welcome you for the session.
Thank you so much. Thank you, Dr. Rashmi.
Yeah. So today, Dr. Ashu Bharadwaj, who is presently Professor and Head Department of Periodontology at Jamia Millia Islamia, New Delhi. She is working there since 2011. She has teaching experience of more than 30 years. She has worked in various capacities as professor, principal, and dean at HP Government Dental College and Hospital, Shimla, and currently working at Jamia Millia Islamia. She is an alumni of King George Medical College, Lucknow. She has guided many postgraduate theses and has many national and international journals to her credit. I welcome you, ma'am, for today's session. Our second,
Dr. Rashmi. Thank you.
Thank you, ma'am. Our second judge for the session is Dr. Nagaraj Kalburgi. He is professor and head of Department of Periodontology at PMNM Dental College and Hospital, Bagalkot, Karnataka. He has many national and international research work with many citations. He has a total experience of 19 years and he is a pass out of PMNN Dental College. I welcome you, sir, for today's session. I welcome
Thank you,
all
sir.
the participants. I welcome all the participants. The participants will get 5 minutes, of which 3 minutes are for presentations and 2 minutes is question answer session. I would request you to stick to your time. Thank you, sir. With this, I announce commencement of the session. Can we have the first slide, please? Yes, Dr. Nishanta, you can start your presentation. Yes, you may start your presentation.
Ishan?
So just you have
The
started not
presentation
on
is
time
from
today.
Dr. Jyotsna. Dr. Jyotsna, are you there?
You may start with your presentation, please.
I doubt.
Ma'am, I think Dr. Jyotsna
Yeah.
hasn't been joined yet. So should I skip
Yes.
next?
So just give me a minute, sir.
Oh.
Just one remember.
Hello, ma'am. Am I audible, ma'am? Hello.
Yes, you are audible.
Sorry for the delay, ma'am.
Is this your poster?
No, ma'am. No, ma'am. Mine is second, ma'am.
Just a minute there. Janvi ma'am, can we have the next poster by Dr. Nishant Bura? Yeah.
Yes, ma'am.
You can start with your presentation.
Good morning, everyone. Yes, ma'am. Good morning, everyone. My poster presentation is on the topic use of different types of autologous platelet concentrates in info defects, a case series. So autologous platelet concentrates like PRP and PRF are frequently used in surgical procedures. Most recently, APRF and IPRF are the techniques that are developed. And these are used in combination with degenerative materials like DFDBA, xenograph, or porous hydroxyapatite crystals for treatment of osseous defects. The objective of the case series is use of various autologous platelet concentrates along with bone grafts for the treatment of infrabony defects. In the first case, IPRF was used and combined with DFDBA or either xenograph and used for preparation of sticky bone in the treatment of infrabony defects. IPRF was prepared by using 700 RPM centrifugation speed and for a time period of 3 to 4 minutes. And then it was collected in a syringe and combined with DFDBA or xenograph, and then so that a workable consistency of the graph can be maintained. This IPRF clots and then holds the graft particles in its fibrin matrix and prevents the leaching of the graft particles. And also, the graft is easy to manipulate, and then it also increases the volume of the graft, and a wider area of the defect can be covered using sticky bone. And then in the second case, LPRF was used and combined with DFDBA. LPRF was made using 2700 RPM for a period of 12 minutes. And after that, it was placed in the interbony defect. And in the third case, PRF was combined with hydroxyapatite crystals. Hydroxyapatite crystals are inorganic bone substitutes with 600 to 700 micron size, and then they are placed in the interbony defect. Now, in the result section, there was mean pocket probing rate reduction of 4 to 5 mm and mean clinical attachment gain of 3 to 4 mm in the 3 cases after a period of 6 months. And the follow-up was done for 6 months. In the discussion, in the past studies, we have found that that the synergistic properties of osteoconduction and osteoinduction was improved by combining bone substitutes with PRF. And the sticky bone, for example, sticky bone was mostly used while placement of implants. In addition, better clinical outcomes was obtained, and reduction of probing depth and clinical attachment gain was seen after 6 months post-surgery. So I am to conclude that the use of different platelet concentrates in combination of different graft materials showed significant improvement in clinical parameters when used for the treatment of intrabony defects. Thank you.
Hello.
Yes, sir.
What is Chopran's PRF protocol?
Sir, for that, centrifugation speed of 2700 RPM was is used, and for a period of 12 minutes. And then PRF is combined either with any regenerative materials like bone graft, which may belong to xenograft or alloplast, and then it can be placed in the osseous defects.
So when did you measure the bone regeneration?
Sir, after a period of 6 months, I measured the bone regeneration, ma'am. Sir.
Is it feasible to assess the bone regeneration after 6 months or more?
Sir, ideally 9 months.
Usually when do you expect the regeneration of bone?
So ideally 9 months of time period is given for bone regeneration, sir.
Okay.
So
how did you assess bone regeneration?
Sir, we have taken radiograph, pre-operative and post-operative radiograph, and then we measured.
Is radiograph feasible to assess bone regeneration? And
sir,
that
along with radiograph, pocket probing depth measurement is done. So
forget about pocket probing.
Yes, sir.
This one is regarding the regeneration of bone.
Yes, sir. Sir, radiographs are assessed for regeneration of the bone, sir.
And that too in 6 months. Is it feasible? When you say it is 9 months, huh?
Sir, yes, sir. Ideally,
above.
it's 9 months. Sir, ideally, 9 months should be given for bone regeneration for proper evaluation of the defect.
Okay. Ashok,
yeah, hello. Dr.
Yes, ma'am.
Nishant, I want to ask you one thing. That
Yes, ma'am.
Is there any difference between plain PRF and the combination with the various bone grafts? Have you seen anything?
Ma'am, while combining PRF with bone graft, it can be easily manipulated, and the graft can be easily placed. So it will also cover a wider defect area. So it was easy for the placement of the bone graft if we combine both PRF and bone graft.
There was no difference in regeneration?
Ma'am, there was no difference in regeneration, ma'am. All the 3 cases showed reduction of 4 to 5 mm pocket probing depth.
So it is not actually very cost effective.
Yes, ma'am, because
Yeah, I mean PRF with bone graft or bone graft alone or PRF alone. Any difference?
I found difference, ma'am, in while putting the graft material. It was easy while easy to place the graft.
It's just the manipulation of the graft.
Manipulation, yes, ma'am, and workable consistency was good, ma'am.
Okay, fine. Thank you.
Yes, thank you, ma'am. Thank you, sir.
Next, please. Next poster. Yes, you can start with your presentation, Ms. Dr. Surendra. Dr. Yadav.
Hello.
Dr. Surendra Yadav, you're audible. You can start.
Yes, yes. Hello.
You're audible.
Hello.
You can start, sir.
Yes, sir.
You're audible.
Yes, ma'am. Good morning, respected teachers. Today I'm presenting a case report on the chronic inflammatory gingival enlargement and its management. Now, the gingival enlargement is a common trait for the gingival disease, which is characterized by an increase in the size of the gingiva. The inflammatory gingival enlargement is also known as the gingival hyperplasia or the gingival hypertrophy. Now, female patient reporting to the Department of Periodontology, the chief complaint of the bleeding gums and the swelling since 8 to 9 years, and swelling is gradually increases, and it causes the difficulty in brushing. The habit of patient is unilateral brush since 8 to 9 years. On the clinical examination, the enlargement in the gingival papilla, marginal gingiva, and it is the firm lesion. The surface margin, it is a bleed on the probing. Color was deep red, and on the basis of the clinical observation and the history, the diagnosis chronic inflammatory enlargement. Now the treatment plan, that is a phase 1 therapy, is scaling root planning, and after the phase 1 therapy, then if the fibrotic lesions do not subsided, then we go for the gingivectomy, and in starting the procedure, we first explore the periodontal pocket, and the bleeding point is marked with the pocket marker, and then it is excises by the Kirkland knife, and the tissue are removed. After the removal of tissue, the granulation tissue also are smooth removed, and the surface are the smoothing and the scaling and root planning after the done. Then after this, there is a placement of the surgical co-pack and post-operative instruction given with antibiotic and antimicrobial therapy with chloroxine mouthwash is given. Now, according to Bodhiza et al. In 2020, state that if there is chronic inflammatory gingival enlargement use the fibrotic component, they do not subsided or shrink after the phase 1 therapy, then the surgical removal should be considered for the removal of the excess tissue. Now it is concluded that if the chronic inflammatory gingival enlargement do not shrink it after the phase 1 therapy, then the surgical removal should be considered for the removal of the excess tissue. It is necessary to have good knowledge of the cause of the enlargement and underlying the pathological changes and the periodontal therapy techniques. Thank you.
Surendra.
Hello. Yes, sir.
I have two questions, sir. One, what are the different techniques for gingivectomy? What are the different techniques employed for gingivectomy?
So different techniques, sir. So
Yeah.
it is either by the chemical involvement or the laser electrocautery.
Do you prefer any chemicals for gingivectomy procedure?
Sir, now this time the chemical is not particularly because due to its harmful nature. So probably scalpel techniques is more preferable.
Okay, what are the laboratory tests which are employed for analyzing gingival enlargement?
Sir, I went for the biopsy and the histological examination.
Biopsy and?
Sir, biopsy. Histological.
That is after excision.
Yes, sir.
Before that, do you want to insist the patient for any laboratory tests? Diagnostic? No idea?
Sir, if the lesion is related to the malignancy or in that cases, then we before surgery we prefer the biopsy.
Vaccine? Ashu ma'am, please ask.
Yeah. Dr. Surendra, I just wanted to ask you, in the conclusion you have written, one must have good knowledge of the cause of enlargement and underlying pathological changes. I hope, can you hear me? So underlying pathologic changes. So did you do anything in these cases? Dr. Surendra?
Yes, ma'am, please, I can't hear clearly. Voice is not.
Hello?
Hello. Yes, ma'am.
Yeah?
Please speak close to the mic. Hello.
Yeah, did you do anything like that?
Yes, ma'am.
You did?
Yes.
So it turned out to be chronic inflammatory. And do you suggest that, in case there are pockets, then what should be done in such kind of cases? You have done gingivectomy.
Yes, ma'am. In case of the pocket, they will be go for the gingivectomy.
Yeah, which kind of gingivectomy then? Which incision is given there?
That is internal bevel. If there is true pocket.
Yeah, but was there true pocket in this?
Ma'am, in this case, it is a false pocket.
It was all false pocket. Okay, thank you. Thank you.
Next poster, please. Dr. Ashwini, you can start your presentation.
Good morning, ma'am. Ma'am, I am audible?
Yes, you are audible.
Yes. Good morning, ma'am. My topic for poster presentation is various flap techniques in parental surgery in terms of pocket reduction and pocket elimination case series. Parental flap is a section of gingiva and or oral mucosa which is surgically separated from the underlying tissues to provide visibility and access to bone and root surfaces. Flaps used for pocket therapy to accomplish the following: increase accessibility to root deposits, eliminate or reduce pocket depth by resection of the pocket wall, and for exposed to area to perform regenerative methods. Different type of flaps currently used in clinical practice, which are Kirkland flap, which is also called as conventional flap, modified Widman flap, apically position flap, and undisplaced flap. These are all the clinical procedures which I have performed in our perio department. Coming to the Kirkland flap, it is indicated for the narrow interdental spaces to gain access for root debridement and for reshaping of soft and hard tissues to attain harmonious topography, and for regeneration of alveolar bone, parental ligament, and cementum. Coming to the results, preoperatively 7 mm probing depth was there in mesiobuccal site of 1/6. After performing the Kirkland flap procedure, 6 months postoperatively, 5 mm probing depth obtained at the same site by using stent. Coming to the modified Widman flap, it is mainly indicated for mild to moderate periodontitis where sufficient attached gingiva is present for the treatment of the isolated infrabony pockets and where the better aesthetics is required. Coming to the results, preoperatively 8 mm probing depth was there in mesiobuccal site of 1/6, which is recorded by using stent after performing the modified Widman flap procedure. 6 months post-operatively, 5 mm probing depth obtained at the same site. Coming to the apically positioned flap, it is indicated for the pocket elimination and widening the zone of the attached gingiva. Preoperatively, 7 mm probing depth was there in mesiobuccal site of 2-3. After performing the apically positioned flap, 3 mm probing depth obtained at the same site. Coming to the undisplaced flap, it is mainly indicated for localized mild to moderate periodontitis with gingival enlargement and where sufficient attached gingiva is present. Preoperatively, 9 mm probing depth was there in mesiobuccal site of 1/4. 6 months post-operatively, 3 mm probing depth obtained at the same site. Coming to the conclusion, the reduction or elimination of pocket depth is main purpose of flap technique, decision of which to perform depend on the two anatomical landmarks, that is the pocket depth and the location of mucogingival junction. These landmarks establish the presence and width of attached gingiva, which is basis for decision making. By using this, better clinical outcomes could be obtained. Thank you.
Ashwini,
Yes, sir.
what are the disadvantages of modified Whitman? What are the disadvantages of modified Whitman?
Sir, this technique is mainly used for the pocket reduction, not for the pocket elimination. So, not the overall, not all the pockets are eliminated. Only there is a pocket reduction, not pocket elimination. Not pocket elimination.
No, reduction is better or elimination is better?
Sir, elimination is better than the reduction.
So you can opt other surgical techniques. Why you want to go for the modified Whitman?
Sorry, sir.
Any other surgical techniques which can eliminate pocket, that you can opt instead of modified Whitman. No?
Sir, apical position flap.
Okay. Do you prefer irrigation with chlorhexidine after post-surgically?
Yes, sir.
Okay. And what about prescribing antibiotics post-surgical? Is it
Sir,
indicated or not?
Yes, sir, they are indicated. Antibiotics are indicated along with the parental flap surgery.
अभी ये बताओ मेरा कैसे हुआ यार जैसे
Ashu ma'am.
Yeah, Dr. Ashwini.
Yes, ma'am.
Tell me one thing. What are the disadvantages of apically positioned flap?
Ma'am, there will be the recession and hypersensitivity may be there after performing the procedure.
Yeah, and you have done in canine, and canine I think is most prone to recession.
Yes,
and you know, the case. How many cases have you done of apically positioned flap?
Ma'am, till the date I have performed 5 apical position flap procedures.
Okay, the case that you have shown, it has spacing. So which other flap could have been used?
Ma'am, papilla preservation flap.
So why didn't you do that?
Ma'am, spacing is between 1-1 and 1-2. But I have shown the probing depth demarcating at 1-3 region. And the papilla preservation flap, which should be performed in 1-1 and 1-2 region.
Yeah, but you are
and
placing
I have
the
done
entire flap apically, no? You're not placing only the, where have you raised the flap in this apically positioned flap? You have involved the key.
Between 1-2 to 1-4. Sorry, 2-2 to 2-4.
Yeah, so you have raised the entire, you have placed the entire flap apically. You may have shown canine, but is it patient friendly? This kind of, you know?
Yes,
You have
ma'am.
placed the flap apically in the entire region.
Ma'am, I have placed the flap in apically in only 2.2 to 2.4 region.
Yeah, 2.2 to 2.4. So you are involving
Yes.
lateral incisor, canine, and premolar.
First premolar. Yes, ma'am.
Yeah. So in 3 teeth, you are increasing the attached gingiva and you are causing recession. What I mean to say, is it really indicated in this area?
Or may, sorry, ma'am.
Which other flap could have been done to cover the recession, to increase the attached gingiva in this area, canine? Which other surgical technique could have been done?
Ma'am, for recession, root coverage with respect to 1.3.
Yeah.
Ma'am, coronally advanced flap.
Yeah. You could have done. You could have done a simple flap surgery instead of epically repositioning it, and then you could have done the coronally.
Ma'am, recession will cause after the performing apical position flap.
Yeah, but that's what I'm
may
trying
not
to
be.
say.
But
You're not doing
ma'am,
the right choice of treatment.
pre-surgically there was no there was absence of recession in 1.3 region or 2.3 region. So I have performed apical position flap for pocket elimination and for increasing the width of the attached gingiva. If
What about
there
the recession? You've increased the recession also.
2.3 region. If
Yeah.
there was recession present with 2.3 region, then I preferred for the coronal position flap, but there was absence of recession.
Okay, but you have created recession.
Ma'am, 6 months post-operatively, there is no recession obtained at the same site.
Okay, fine.
Only 3 mm probing depth was there, which is from 7 mm probing depth. There is a we gain pocket elimination in this technique.
Okay, thank you.
Thank you, ma'am.
Can we have the next slide, please? Yes, you can start your presentation.
Yeah. Good morning, everyone. The topic of my poster is vestibuloplasty. It is a case report. Now, as you can see, the title vestibuloplasty. So it seems something to do with the shape of the shallow vestibule. Now, vestibuloplasty is basically a procedure where it helps to deepen the vestibule by modifying the soft tissue attachment. Now, a 23-year-old female patient had reported to the Department of Periodontology with a chief complaint of receding gums with respect to the lower anteriors since 2 months. Now, on examination, we observed that there was class 1 recession observed with respect to 3.1 and 3.2, along with papillary frenal attachment with mandibular labial frenum, and shallow mandibular vestibule and inadequate width of attached gingiva was observed in the mandibular anterior region. Scaling and polishing was done for this patient, and on the following recall appointments, the Clark's technique of vestibuloplasty was done. So as we can see in the pre-operative pictures, the mucogingival junction was marked using the H&E pencil, and the vestibular depth was measured using the UNC15 probe, and the depth was about 2 mm. Coming to the technique, so under local anesthesia, horizontal incision was placed at the mucogingival junction with respect to 3.2, 3.1, 4.1, 4.2, including the aberrant mandibular labial frenum that was present. And then the supraperiosteal dissection was done up to the desired depth of the vestibule, the desired depth, and the mucosa was undermined, and the mucosal flap was then sutured in the with non-resorbable silk sutures at the depth of the vestibule. The raw area of the wound of the alveolar bone was left to heal by secondary intention. Abgel was placed in the wound to control the bleeding. Then later, suture removal was done after 10 days, and complete healing was observed by the end of 4 weeks. So at the follow-up appointment of 4 weeks, again the marking with the H&E pencil was done at the mucogingival junction, and the measurement was done using the UNC15 probe. And the new measurement of the vestibular depth was about 4 mm. So the result obtained were there was an increase in the vestibular depth, there was gain in the attached gingiva, and there was removal of the aberrant frenum, and thus preventing the recession with respect to 3-1 and 4-1. Thank you.
Can you name some different techniques for vestibuloplasty?
Yes, sir. So the different techniques are, so the three categories are submucosal advancement vestibuloplasty. Then there is secondary epithelialization technique, vestibuloplasty, wherein it includes the Kazanjian technique, the Clark's technique, and the lip switch technique. And there is grafting vestibuloplasty.
Okay. Why we use the non-absorbable sutures instead of absorbable?
Sir, because as it is, the suture removal was to be done after 10 days, that like around when the healing was complete. So non-resorbable suture was used.
Did you use Copac?
No, sir. Periodontal dressing was not done.
Not done.
No.
Okay. Ashu ma'am?
Yeah. Dr. Sneha, what are the disadvantages of shallow vestibule?
So, ma'am, the disadvantages are that there is increased food accumulation that can occur. Then it can hinder the proper oral hygiene maintenance. Then also, if in case of prosthesis, if there is a removable denture that is used, the placement of the denture, so the stability of the denture is hindered. And also, if there is, like in this case, where there was an frenum, aberrant frena that was present, and also the shallow vestibule, so the tension may cause gingival recession.
Okay. What are the tangible benefits for the patient?
Sorry, ma'am?
What were the tangible benefits for the patient?
So, ma'am, the patient's chief complaint was gingival recession, wherein she was also experiencing sensitivity. So, after the treatment that was done, we could see that the gingival recession the chief complaint was resolved and the sensitivity had reduced.
Okay, thank you.
Thank you, ma'am.
Next poster, please. You can start with your presentation. Dr. Gupta, Dr. Kamashki Gupta.
Yes, ma'am.
You can start with your presentation.
Yes,
You're audible.
Hello, everyone. I'm going to present a poster on the topic, a bird eye view on gingival depigmentation treated surgically and with diode laser. So starting with the introduction. So as we all know that hyperpigmented gingiva presents a gummy smile, and when it compared to the facial skin, it appear anesthetically unpleasant. So many treatment options are available in practice for depigmentation, like which includes scalpel degenectomy, use of chemicals such as 90% phenol and 95% alcohol, burr abrasions, electrosurgery, cryosurgery, and laser. Among the various other techniques, laser, that is the light amplification by stimulated emission of radiation, offers a promising therapeutic option since it is simple, painless, and easily accepted by the patient. So here we report a case of gingival depigmentation treated using scalpel and laser technique. So when we talk about the case description, so actually the case reported to us with the complaint of a black color gingiva in maxillary anterior teeth. And when we have given him under local infiltration, what we have done is remove the superficial pigmented layer with using scalpel blade number 15. And on the contralateral side, we have used a biolace diode laser with a wavelength of 940 nanometer. And when we recall the patient after 7 days, the excellent results were seen. So we can see that here depigmentation with a scalpel has been done, and this is a picture showing after depigmentation, and then we have applied the tin foil and co-pack, and when we have done laser, so we have done laser ablation and post laser ablation, and post operative results were seen. So concluding the poster, I would say that among many intraoral soft tissue surgical procedure, the laser is a viable alternative option to the scalpel technique. So the future of laser in dentistry is promising and successfully integrate into everyday practice of in the dentistry field. Thank you.
What is cryosurgery, Kamakshi?
So cryosurgery is actually, as the name suggests, cryo. So in this surgery, we generally we use the nitrogen gas, and we generally use in the minus. There is a very cold temperature. We use that surgery. We use the cold environment to kill the melanin cells, which is actually responsible for the pigmentation.
Okay. Can you name some indices related to gingival pigmentation? Are you aware of any indices for gingival pigmentation?
No, sir.
Oh. Okay, Ashuma.
Yeah, can you tell me, post-operatively, which was better for the
So,
patient?
ma'am,
Regarding
actually,
pain, bleeding, and everything.
yes, ma'am. Yes, ma'am. Ma'am, I was in constant touch with the patient. So when I called him after 2 or 3 days, so he was like, I have no pain on the laser side, whereas he was still having a pain on the scalpel side. Moreover, he was saying there is little bit swelling on the scalpel side, whereas there is no swelling on the laser side. So these are the things which he has told me.
So did you give any antibiotics or analgesics?
Yes, ma'am. I have given him antibiotic because I have also treated with the scalpel, but I have given him only for 3 days.
Which one?
Ma'am, I have prescribed him amoxicillin.
Analgesic?
Ma'am, and I ibugesic ASP.
Okay. Okay, thank you.
Thank you, ma'am.
Next poster, please. Can we have the next poster? Next poster, please. Yes, you can start with your presentation.
Am I audible, ma'am? Am I audible, ma'am?
Yes, you are audible.
Yes, ma'am. Good morning, one and all. Today I come here to discuss about a case report on VISTA, a wisdom for the management of multiple gingival restoration. First, we show the pre-operative pic. First, we done the phase 1 therapy, scaling and root planing, and then the composite restoration. A patient, a female patient of 35 age, come to a department with a chief complaint of spacing and sensitivity in the lower anteriors 4131. First, we have to go for the phase 1 therapy. First, we done the scaling and root planing, and then the composite restoration was done. The third picture shows stunt was given. Then the gingival restoration in 4-1 is 2 millimeter and 3-1 is 3 millimeter. Under LA, we have done vestibular incision, and then a superficial canal was done using VISTA elevators, and the CTG is harvested harvester in the palatal area, and then the placement of CTG into the tunnel was done. And then after the placement, coronary advanced flap technique was done using the 6-row protein sutures using composite, and then the these are the pre-operative pick of during the first pre-op pick, and then the 6-month review, and later that 6-month review using the stent. There we have attained 100% root coverage using this technique. As I conclude that this technique, this technique can also be a promising technique even for the root coverage procedure in the mandible teeth also. Thank you.
Tarun Kumar.
Yes, sir.
Can you name some techniques for multiple recession? Multiple root coverage procedures. Multiple teeth root coverage. Tarun?
Yes, sir. I am.
Yeah. Multiple teeth root coverage procedures. Techniques. Are you aware about accordion and classical technique?
No, sir.
No. Okay. What is pinhole technique?
Sir? I can't audible. I can't hear you, sir.
What is pinhole technique? Can you hear me?
Yes, sir. Yes, sir. I can hear you, sir.
What is pinhole technique?
Sir, I don't know, sir.
Okay. You have any idea about palatal gingival recession?
Yes, sir. Palatal gingival recession.
Can you classify it? Okay. Ashu ma'am?
Yeah. Dr. Arun, what have you done in this this coronary advanced flap with composite?
Yes, ma'am.
Why have you done with composite?
For a proper adaptation of the suture, ma'am, and the coronary.
How have you sutured? I mean, you placed the. This is for the placement of the suture.
Ma'am, for
I just want to ask, what have you done? Coronally advanced flap with composite. This is for the placement of the suture.
Yes, ma'am. For we have to pull the tissue and then suture over the tooth with composite, ma'am. For the suture only, we have adapted.
And where have you, given the incision in this case after the tunneling?
Mesial to the recession, we give the vestibular incision.
Mesial to the?
Recession, ma'am.
Mesial to the recession. So
yes,
you have done the, covered the recession in how many teeth?
2 teeth, ma'am. 4-1 and 3-1, ma'am.
4-1 and 3-1.
Yes, ma'am.
Okay. So where did you give the incision for coronally advanced flap? I can't see the incision.
No, this is a tunnel technique. We just tunneling the tissues and the tissues should be loose, and then we just placing the sutures over the tissue, ma'am, loose tissues, and we elevate, we lift up the. There will be no incision for the coronally advanced flap.
There's no incision for this.
Yes, ma'am. We only.
You've given the only the incision in the vestibular area.
Yes, ma'am.
Okay. Okay, fine. Thank you.
Thank you.
Tarun?
Yes, sir.
What about this image in posters? That first image and other image are totally different, I think.
First pre-op and the last one, sir.
First image
Yes, sir.
with the heavy calculus and
Yes, sir. It's a pre-op pic, sir. After that, we remove the calculus. That will be seen in the last
what
column.
about the spacing in between that two
We
sentences,
closed.
sir?
Yes, sir. We closed the spacing by composite restoration, sir.
Composite restoration.
Yes, sir.
Or crown.
Composite restoration, sir.
Okay. Okay.
Thank you.
Thank you.
Thank you.
Next poster, please. Yes, you can start with your presentation, Dr. Ravinder Kaur.
Good morning, ma'am. Good morning, everyone. Ma'am, I'm audible?
Yes, you are audible. You are audible.
Okay, ma'am. Good morning, everyone. Today, I'm presenting a case report of a giant cell fibroma in a 20-year-old female patient who reported to the Department of Periodontology with a swelling in the distal third molar region and the lower right third molar region, which was present for more than a year. And it was a painless swelling, and it was non-tender on palpation. So we just clinically examined the patient. After clinical examination, we found that there is a single pedunculated swelling which was firm, non-tender on palpation, and there was no, it was not extending into any other area except the third molar region. So provisional diagnosis of pyogenic granuloma was made, and then the radiographic examination was done, and it was found that there is no signs of extension of the lesion into any of the heart tissue. So finally, we did an excisional biopsy of the area of the lesion, and it was performed under local anesthesia, and then the specimen was sent for histopathological analysis. Histopathological analysis of the excision showed a characteristic features of giant cell fibroma, that is large stellate giant cell fibroblasts with hyperchromatic multinucleated giant fibroblasts, and long and narrow retipix, and along with scanty inflammation. So we came to a conclusion that it was a giant cell fibroma. And so giant cell fibroma is a benign, localized, it is a fibrous connective tissue tumor, usually occurs in the first 3 decades of life. It has a most slight predilection for females, and most predominant location is usually mandibular gingiva. And the most important feature is that it is usually confused with some other fibroepithelial growths like irritation fibroma, papilloma, and it has some characteristic features, and it is usually diagnosed only on histopathological examination. So the important thing which I want to discuss with the case report is that whenever we encounter any gingival enlargement, histopathological analysis is a very important feature, because so many characteristic features, clinical features overlap with each other, and histopathological examination is a confirmed diagnosis of the exact of the lesion, the exact characteristics of the lesion. Because giant cell fibromas, in this case, it can continue to proliferate, so it needs to completely excised, and it should be excised with conservative surgical excision, and then there will be a recurrence is usually rare. And so early diagnosis and treatment is very necessary to avoid extensive periodontal surgical management later. Thank you.
Okay. Ravindra?
Yes, yes, sir.
Yeah. What is the differential diagnosis for this?
So it is irritation fibroma, papilloma, and pyogenic granuloma.
Okay.
Yes, sir.
Did you check for pulsating lesion there?
Yes, sir. So the lesion wasn't pulsating.
Not pulsating.
Yes, sir.
Okay. So which stains did you prefer or use for microscopic examinations?
Sir, action E stains.
Okay.
Yes, sir.
How did you get the lesion scanning done?
Yes,
or
sir.
USG or CT?
No, sir, CT wasn't performed, only radiographic examination and then microscopic examination.
No, because the differential diagnosis, hemangioma is also a reason for that.
Okay, yes, okay, sir.
If it is deeply rooted.
So it wasn't deeply rooted. It wasn't deeply rooted.
Okay.
Yes, sir.
Okay.
So after yes, so after excision biopsy, we could see the base of the lesion. It was smooth and it wasn't extending or any. It wasn't like that. So it wasn't deep rooted. Like it didn't look like deep rooted.
So post-op, how many days or weeks did you check the patient?
So the patient has been followed for more than, she came to me 2 months back. So the patient has been followed till now for 2 months.
Only 2 months.
Yes, sir.
Any probability of reoccurrence?
So yes, sir, initially the patient needs to be done follow-up, at least a follow-up for 1 or 2 years is essential. So we'll be doing the follow-up. And it is usually the other case studies which I have seen, they say that the reoccurrence is usually rare. But we need to follow up the patient essentially for the reoccurrence.
Okay, thank you. Ashu ma'am?
Yeah, Dr. Ravinder,
yes, ma'am.
What could be the probable etiology of it at this age, and especially in third molar area?
Ma'am, the etiology, the unerupted third molar, and there could be a traumatic some mutation, but we couldn't find any possible etiology according to the history of the patient.
What is it in the literature?
Ma'am, the literature says that it is usually a reactive proliferation of the fibrous connective tissue.
Yeah.
It usually occurs due to some reactive proliferation of the fibrous connective tissue. And yes, traumatic irritation, ma'am, traumatic is not usually taken the case not taken as a etiology for this case. It is usually the case of traumatic fibroma.
Okay, thank you.
Thank you, ma'am.
Can we have the next slide, please?
Should I start now?
Yes, you can start. You are audible.
Good morning, everyone. My topic for today is, does the redness say something more? Or desquamative gingivitis?
Can you remove the mask, please?
Yes, sir.
Yeah.
Desquamative basically means loss of epithelial elements in small and large amounts, peeling of skin and exfoliation. And desquamative gingivitis, it is a clinical finding that progresses with vesicular formation, atrophy, erosion, and desquamation, along with diffused erythema of marginal and keratinized gingiva. So my case report is of a 19-year-old female who came to the department with the chief complaint of bleeding gums, soreness, burning sensation in the gums since 3 months. The maxillary anterior gingiva showed linear erythema on the marginal and interdental gingiva. The mandibular anterior gingiva exhibited erythema and desquamation of the gingiva, along with involving the interdental, marginal, and attached gingiva. When I took the history of the patient also revealed the history of psoriasis, which was diagnosed by a dermatologist 5 years ago. She has been on clobetasol propionate, which is tenovate ointment, and halbetasol propionate for the same. When we took the history and the clinical signs and the symptoms into consideration, the clinical findings were diagnosed as desquamative gingivitis. So for the treatment of this patient, scaling and root planing was done. And along with this, triamcinolone ointment 0.1%, which is Kenacort, was prescribed along with 0.1% benzodiazepine hydrochloride mouthwash. The patient was asked to apply the ointment and use the mouthwash twice daily for 2 weeks. And as you can see in the post-operative 2-week follow-up, there was already a marked decrease in the linear erythema, and by a 2-month follow-up, the patient's desquamative gingivitis had completely resolved. Thank you.
How will you differentiate desquamative gingivitis with herpetic gingivitis?
So first of all, we will take a proper history of the patient, whether the patient has any history of dermatological or endocrinal disorders. So because desquamative gingivitis usually has an etiology of either an endocrinal disorder or a dermatological disorder, or sir, if there is any infection. Sir, and in the lesion as well, so desquamative gingivitis has a marked linear erythema, so which is very prominent, along with probable exfoliation of the gingiva and atrophy.
What is the other name for desquamative gingivitis?
Sir, it is also called as chronic desquamation. So I'm not sure.
Not sure. Okay. Ashu ma'am?
Yeah. Was there any role of Kinocort? Was it essential since she has been already under the treatment of dermatologist?
Ma'am, actually, the treatment that she was undergoing was for the lesions that she experienced on her skin and scalp. And ma'am, that was also topical ointment that she had been applying. So there was no effect on the gingiva, like it wasn't helping any with the desquamative gingivitis findings. So ma'am, 0.1% triamcinolone ointment was prescribed for topical application in that area, and that reduced it.
Okay, but could there be any other cause of this, or was it due to only psoriasis? Like it could be due to gingivitis as well, the complaints of hers.
Yes, ma'am, but ma'am, even after scaling, ma'am, because of the marked linear erythema and because of the patient's history of psoriasis, and because of the exfoliation of the and the fragile gingiva that was in the mandibular anterior region, ma'am, the findings were correlated with desquamative gingivitis.
Okay, thank you.
Thank you, ma'am. So,
Next slide, please. You can start with your presentation. Dr. Khushbu. Dr. Khushbu Arora, you can start with your presentation.
Good morning, everyone. Am I audible, ma'am?
Yes, you are audible. You can start.
Today, I will be presenting before you a case of a 15-year-old systemically healthy boy who was undergoing his endodontic treatment, and as he required margin for placement of the crown, so he was referred to the Department of Periodontology for opinion regarding crown lengthening. And as we got the parameters, it was estimated that surgical crown lengthening would be an overly aggressive approach. Therefore, we went for surgical extrusion technique. After preparing the patient for the surgery, the root of the permanent central right incisor was dislocated using a fine periotome under LA. After raising a full thickness mucoperiosteal flap, the tooth was extruded to around 3 mm so that the distance from the incisal edge of the right maxillary central incisor and the gingival margin was increased from 5 mm to 8 mm. Thereafter, the localized flap was closed by silk sutures, and the tooth was stabilized using a provisional splint for a period of 4 weeks. The sutures were removed after a period of 1 week. Thereafter, the patient was also prescribed antibiotics for 3 days and the analgesic for 3 days. And he was recalled on 3rd, 8th, 13th, and 20th day from the surgery for his low-level laser therapy session so that the rate of healing could be increased. And after the accomplishment of the required periodontal repair, he was referred back to the Department of Endodontics for the placement of the crown. Therefore, we also concluded that as surgical extrusion technique is a better alternative approach when compared to orthodontic extrusion technique, therefore it can be used to increase the therefore it can be used to maintain the biological width when undergoing the clinical crown lengthening procedures. Thank you, ma'am.
Okay, Khushbu. Khushbu.
Yes, sir.
What is the significance of biological width?
Sir, if the biological width is hampered, sir, it could lead to gingival inflammation, which will further lead to the loss of the periodontal tissues. So therefore, it is necessary to maintain the biological width that is 2.04 mm.
Okay. What is the effect of low laser therapy on wound healing?
Yes, sir. Sir, it accentuates the healing process as it acts on the cellular as it alters the cellular behavior by affecting the mitochondrial respiratory chain or the membrane calcium channels. Therefore, sir, it enhances the collagen synthesis, the proliferation of the fibroblasts.
Okay. Aishu, ma'am?
Yeah, Khushbu.
Yes, ma'am.
Why did you do, where did you do low level laser therapy?
Sir, on
Where
the
exactly did you do it?
Ma'am, on the labial, on the gingival surface, labial surface of the gingival. Ma'am, just adjacent to the gingival margin, and also palatally.
In the gingival sulcus area.
No, ma'am, outside.
Outside.
Yes, ma'am.
So, what was the purpose or objective of doing it?
Ma'am, so that the inflammation could be reduced and also the healing can be fastened.
But you have not done anything outside on the gingival surface.
Ma'am, but there was inflammation in the gingiva, as we can see.
Okay, just for that. And
Yes, ma'am.
how do you say that it's better in an orthodontic movement?
Ma'am, we do require a period of at least 3 weeks for the stabilization of the tooth if we go for surgical extrusion. But ma'am, as the orthodontic treatment, orthodontic extrusion requires a larger time. Therefore, we can say it is a better technique than it.
But there is bone formation as well in orthodontic. You're moving the tooth slowly, you know.
Yes, ma'am.
Here, what do you do for the bone formation epically?
Ma'am, we didn't go
bone?
for ma'am, we didn't go for any bone graft.
You didn't go for any bone graft.
No.
Are there any studies on this?
Yes, ma'am, there are many studies on this. Ma'am, but they haven't used the low level. Ma'am, low level laser therapy hasn't been used.
Okay, but otherwise on extrusion, surgical extrusion?
Yes,
Can you
ma'am.
quote any?
Ma'am, I don't remember for now.
Okay, thank you.
Thank you, ma'am.
Next slide, please. Yes, you can start with your presentation.
Good morning, respected chairperson. Am I audible, ma'am?
Yes,
Sir?
you are audible. You can start.
Good morning, respected chairperson. Today, my topic for the case report presentation is double lip correction, messy surgery to an aesthetic ease. Starting from the introduction part, double lip is one of the rarest lip abnormality, which is sorry, hello.
You continue.
You're audible. You're audible. Start.
Okay. Starting with the introduction part, double lip is one of the rarest lip abnormality, which is unusual clinical finding, considered to be a developmental anomaly and usually involves the upper lip more than the lower lip. It manifests as two masses of hyperplastic tissue on the either side of the midline. Sometimes can be asymmetrical also. Acquired deformity may be secondary to the trauma or habit, such as sucking of lip, or may be due to a part of Astor syndrome. Case report. Here, we present a case report of a 19-year-old boy came to our department with a chief complaint of large upper lip, of which he felt ashamed and wanted to get it treated. Upon examination, a thick upper lip was seen with mucosal bulges, which was even seen during the rest of the lip. There was no blepharochalasis or there is no thyroid gland enlargement. A provisional diagnosis of congenital double lip was made. Under topical anesthesia, hyperplastic upper lip tissue was demarcated and using 940 nanometer diode laser excised with a elliptical incision pattern. as shown in the picture. Medicine was prescribed and the patient was recalled after 1 month. Patient was satisfied with the appearance and with his new look. Coming to the conclusion part, the importance of treatment is highly due to the aesthetic concern of the patients. Such cases are special interest to dental clinician as they are among the first professionals to detect, diagnose, and treat this uncommon condition. Scalpel and seizure-assisted excision causes excess bleeding. Laser-assisted excision reduces surgical time, bleeding, and post-operative swelling of the lip. Thank you. Thank you, sir.
Is it associated with any syndrome?
Yes, sir. It is associated with Escher syndrome, sir.
Escher syndrome.
Yes, sir.
Any oral findings along with this?
In my case, sir?
Yeah, in your case or associated with the syndrome, Escher syndrome. Any oral findings have been noticed?
No, sir. There were no intraoral findings, sir.
What might be the reason for this double lip?
Sir, in my case, this was congenital, sir, or else it can be due to some habits like, sir, lip sucking.
Okay.
Or, sir, maybe due to the trauma, sir.
Other than lasers, any other surgical technique?
Sir, any other surgical technique, sir? With Z-plasty, we can do it. Using scalpel. Yes, sir. Using scalpel and Caesar.
Okay. Ashu ma'am.
Thank you. No questions, Abdul.
Thank you, ma'am. Thank you, sir.
Thank you.
Next poster, please. Dr. Deepika, you can start with your presentation. Dr. Deepika, are you there?
Good morning, everyone. Today, my poster presentation topic is gingival enlargement associated with psychological stress, a case report. A 38-year-old female patient reported with chief complaint of swollen gums, bleeding gums, and bad breath. On clinical examination, gingiva appeared too friable and soft with smooth
Please continue.
On clinical examination, gingiva appeared too friable and soft, with smooth and shiny surface, which is diffused and nodular, bleeding on probing on all teeth, and generalized pocket present. Investigations advised to the patient. OPG revealed no bone loss. Hematological investigations. Punch biopsy carried out, which revealed keratinized stratified squamous epithelium with long rete with basal cell hyperplasia. Endothelial cell line, blood vessels, and small capillaries can be seen suggesting histological diagnosis of inflammatory fibroepithelial hyperplasia. Treatment plan. After completion of phase 1 therapy under LA, bleeding points were marked. Quadrant-wise external bevel gingivectomy was performed with 15 number blades. Tissue excision and gingivoplasty done, followed by Copac given. Analgesic and antibiotic prescribed. 10 days post-op healing found to be satisfactory. Result and conclusion. Excision of disfiguring gingival overgrowth and counseling of patient led to marked improvement in mastication and speech, leading to improved life. Thank you.
Deepika.
Yes, sir.
How to measure stress? Scales to measure stress. Did you get them, Gaura?
Yes, sir.
How to measure stress?
Sir, perceived stress scale, most widely used psychological instrument for measuring the perception of stress. Yes, sir.
What is a Trier social stress test?
Sorry.
TSST, Trier Social Stress Test.
Sorry, sir. I don't know.
Did you
Hello.
TSST? Okay. Different models to evaluate the role of stress in periodontal diseases. Different models to evaluate the role of stress in periodontal diseases. Are you aware of this?
No, sir.
Thank you. Ashu ma'am?
Deepika, is there any relationship? Which antidepressants was she taking?
Ma'am, fluoxetine.
Fluoxetine
project.
Be a bit more louder.
Ma'am, fluoxetine.
Is there any relationship between this and the gingiva? Is there any, like, there's a direct relationship between dilantin and this? Is there any relationship?
Ma'am, it increased the resilience to stress in a small open label state. Sorry, ma'am.
Okay.
Can we have the next slide, please? Next slide, please.
Hello, good morning, respected panelists and my fellow participants. Today, I will be presenting my case report posted titled Restoring Anterior Aesthetic with Flapless Implant. To introduce, since the 1970s, modern implantology is based on a concept of surgery with flap elevation. Gradually, several clinical trials demonstrate that a mid-cristal incisions give us similar success rate compared to those obtained using the classical protocol. However, over the past decade in medicine, it has been established the concept of minimally invasive surgery, consisting in taking advantages of advancement experience in diagnostic techniques and specific surgical instrument to perform surgical procedure, infringing as less damage as possible to the patient. The present work aims to shed light on one such technique of implant placement, the flapless approach. The flapless implant referred to placement of implant through the mucosal tissue without reflecting a flap. Let's take a look at the case. A female patient, aged 26 years, reported to our department with the chief complaint of missing upper front tooth. She did not give any history of trauma or infection and said that it had been missing since birth. She had no relevant medical history. After taking informed consent, we decided to proceed with implant placement by flapless technique. In figure 1, depicted pre-op picture with missing right canine. A flapless implant surgery was planned for best aesthetic result. In figure 2 shown a placement of implant fixture. The patient was recalled after 1 month post-op for placement of healing abutment as seen in figure 3. An open tray impression was made with putty and light body as seen in figure 4. After 4 days, final prostheses were delivered to the patient and she was recalled for a checkup after 2 weeks. On further follow-up, patient presented with satisfactory healing and did not report of any complications. Flapless implant technique has various advantages over the conventional method, some of them being minimal interference on the blood supply, leading to faster healing, lower morbidity and increase on patient comfort, high survival rate of the prosthesis, reduced surgical time, and reduction of bleeding as one of the most important advantages of flapless surgery that both the clinician and patient appreciate in the significant reduction in bleeding intra and post-operative. Hence, to conclude that flapless approach is a predictable procedure when patient selection and surgical technique are indeed and has the potential to increase the patient acceptance of the procedure. Thank you.
Doctor,
yes,
how
sir?
did you assess the bone? Type of bone, how did you assess?
So OPG.
No.
So what?
How did you assess the type of bone? Which type of bone? Are you aware of D1, D2, D3, D4?
Yes, sir. It's a D3 bone.
D3. What is D3?
So in anterior, D3 in density, cortical, sir.
No, what do you mean by D3? What type of bone will be present there?
So cords and spongy.
Pardon?
Cords and spongy, sir.
Okay, which is the best type of bone? Which is the best for implant placement?
D4. D4.
What type of bone will be that?
Sir, cortical.
Cortical. Okay, Ashu ma'am.
Can you name any other minimally invasive technique?
Minimally invasive technique. Flapless.
Any other minimally invasive technique?
No, ma'am.
Sure. Okay. Thank you.
Okay, ma'am.
Next poster, please.
Good morning, everyone. Myself, Dr. Kalpana Pandey. I'm going to present a case report on immediate implant placement in fresh extraction socket. Esposito et al. Was the first to define as an implant placed in extraction socket is known as the immediate implant. The inclusion criteria and the exclusion criteria. Inclusion criteria is the patient age should be more than 18 years of age, and it should be that crown root ratio is not appropriate, or trauma to the tooth, endodontic treated tooth which is not responding, and the available bone is more than 2 mm apical to the extraction socket, and patient is able to maintain the oral hygiene. Exclusion criteria is patient is having on radiotherapy, uncontrolled diabetes, heavy smokers, or bleeding disorder patient, or where there is an anatomical close relation to the structure, and different. These are the where the available bone is less than 2 mm or 3 mm to the extraction socket are the exclusion criteria. Now I'm going to present a case of 38-year-old female patient. She has reported to the perio department of college with a chief complaint of mobility in lower anterior. On examination, there was a grade 3 mobility grade 3 mobility. The prognosis of the treatment was explained to patient, and alternate treatment plan was also discussed with the patient. Patient medical history and the past dental history was also taken. Patient was willing for the dental implant treatment, henceforth we carry out the implant treatment. In this, Covell implant system was used, and implants were used. Now we are going to discuss about the methodology that how the implants were placed. Firstly, the pre-procedure rinse 0.12% of chlorhexidine for 30 seconds was pre-rinse was done. Then the surrounding skin mouth area was rubbed with the povidone iodine, and pilot drill was used and sequential drilling was done. And with the help of the radiographic and the root length, the sequential drilling was done, and appropriate measurement of the implants were placed of 3.5 mm to 11.5 mm diameter. And then before placing it, the curettage was done, and sterilization of the socket was also done. The curette was done with the 87 Lucas instrument, and following up the placement of the implant, the suturing was done. As follow-up was done on 2nd, 8th, and 16th week for the patient. In 8th week, it was found that the gingival biotype around the implant was not sufficient, so hence it is the aesthetic zone reason. So the second stage surgery was performed, where the trapdoor flap design was taken, harvested from the implant, and it was placed in the implant bed to increase the keratinized zone. And hence, after 14 days, the suture removal was done. The post-op instructions was given to patient, and cold pack, amoxicillin, metronidazole, and painkiller paracetamol SO was given. Now we are concluding to the why we have done, what is the advantages. Although the immediate implant and the delayed implant, they have the almost same result. If it is a technique sensitive, then also if the proper case selection is done and aseptic technique is formed, the success rate is equivalent. Thank you so much.
Okay, Dr. Kalpana.
Yes, sir.
Kalpana?
Yes, sir.
Yeah, what do you mean by socket preservation?
Since socket preservation, we don't want to break the buccal wall. Actually, we don't want to crush the socket. So hence we can get the aesthetic results properly, and there is no implant failure or aesthetic reasons are affected.
So what are the methods or types of preservation of the socket?
Preservation of socket method.
Yeah.
So automatic extraction was done. I mean, the rotatory movements were and the anti-rotatory movements of the done to, so that there is no. Also, there is a buccal shield technique where the slip, the splitting of the tooth is done, and the buccal side of the tooth is retained, and implant is also given, retaining that part actually, so that there is no recession and implant exposure is not there in future.
Preservation of socket.
Preservation of socket.
Okay, Ashu ma'am.
Yeah. Did you place any bone graft also?
No, ma'am. Bone graft is not done, ma'am.
No. Okay. Thank you.
Thank you, ma'am.
Next poster, please.
A very good morning to respected judges and everyone present here. So today's case report is on salvaging a compromised molar by novel degenerative approach. Now, endodontic periodontic lesions are commonly encountered, and the prognosis and treatment may vary depending on the severity of the condition. Now, this is a case report of a 36-year-old male patient who walked into the Department of Periodontics with a chief complaint of pain at foot lodgement in the lower right back tooth region since 10 days. On intraoral examination, we found that there was deep periodontal pocket in relation to forceps, along with grade 3 furcation and grade 2 mobility. On CBCT evaluation, we found that there was radiolucency involving the mesial root of the molar and radiolucency in the furcation area. So the treatment done was as follows. So first, a scaling and root planing was done, after which a root canal treatment was done. 1 week after the root canal therapy, 3 months after the root canal therapy, open flap debridement was done and xenograft along with PRF was placed. Then the patient was kept on a follow-up and patient was followed up after 3 months period. When the patient came up after 3 months, we saw that there was bone fill on the mesial aspect of forceps, but there was mesial root recession. So to treat this mesial root recession, connective tissue graft was taken. A tunneling procedure was done and connective tissue graft along with an amnion membrane was placed into the tunnel. Sutures were placed and then the patient was recalled after 6 months. After 6 months, when the patient came, we saw that there was root coverage in relation to the mesial root of forceps. So to conclude, this two-stage procedure improved the function and the aesthetics of the involved tooth.
Different regenerative procedures.
So the different regenerative procedures can be with graft, without graft, with membrane, or there can be a combination of graft and membrane.
You use the PRF, no?
Yes, sir.
Which PRF?
So we use the plain PRF, sir. No, sir, we use plain PRF, sir.
Oh. Ashu ma'am?
Yeah. This bone fill, after how many months have you taken this X-ray?
Ma'am, the IOPA was taken after 3 months, ma'am, and some amount of bone fill was seen. However, we have put the patient on a follow-up period, and we would be taking a CBCT after 9 months of the procedure, ma'am.
Okay, thank you.
Okay, thank you.
Can we have the next poster?
Good morning, everyone. Am I audible?
Yes, you are audible.
Good morning, sir. Good morning, ma'am. I am here to present my poster on the case report on the topic platelet-rich fibrin as a regenerative material in infrabony defect. Let's start with the introduction. platelet-rich fibrin or PRF is an autogenous living biomaterial which is a second generation platelet concentrate. It accelerates soft and hard tissue healing. The difference between natural blood clot and platelet-rich fibrin or PRF is that PRF is more stable, homogeneous, easy to handle, and easy to place. In the process of PRF formation, blood sample is taken without anticoagulant in 10 ml test tubes and immediately centrifuged at 3000 rotations per minute for 10 minutes. In the case description, a 40-year male, Mr. Vijay Kumar, reported to the Department of Periodontology in our department with a chief complaint of food lodgement with respect to third quadrant posterior area. Intraoral examination reveals that there is stage 2 grade B periodontitis with vertical bone defect around mandible posterior area with respect to third quadrant. The patient is systemically healthy and was informed about the treatment. So first, the open flap debridement or the conventional flap, which was Kirkland flap, was performed in the area with respect to 3.5 to 3.7, and then PRF was placed as a regenerative material in the bony defect. A non-resolvable suture was placed following the periodontal dressing, which was POPAC, and a favorable clinical outcome was attained. So this is the procedure. In this, first the probing depth was checked and the incisions were given. Then the flap was elevated and debrided. And as we all know, the furcation grade one furcation defect cannot be seen in radiograph. So after the debridement, we see that there is grade 1 furcation involvement in this area. And then tetracycline capsule was used mixed in saline, and then root conditioning or root biomodification with the help of tetracycline was done at the root surfaces of all the 3 teeth which were catered. And then in the process of PRF formation, which was done at the centrifugation of 3000 RPM for 10 minutes, this is the PRF which was obtained. The first layer is acellular plasma, the middle layer is PRF, and the third layer is red corpuscle. This is the PRF, the membrane which we are going to place. This is the PRF in the picture where there is a gauge, and then the PRF is placed before after the pre-suturing is done. The pre-suturing is done in all the 3 areas. In this, I have done interrupted suturing. Otherwise, vertical mattress suturing is ideal for the regenerative procedures. And then the membrane PRF, which I use, is as a membrane, is placed in this area, which will act as guided tissue regeneration for this defect. And then interrupted suturing was done and periodontal dressing was placed in the area. Excellent clinical outcomes can be expected in the area using PRF due to its regenerative potential with less technique sensitivity and no manipulation. Thank you.
Dr. Arora?
Yes, sir.
Can you name some methods for treatment of infrabony defects?
So infrabony defects can be treated with the help of bone grafting or a regenerative procedures. Autogenous bone grafting can also be done, which is an ideal treatment. The bone can be taken from the symphyseal area, or we can place any regenerative material such as PRF.
PRF. So what is the difference between APRF and APRF plus?
Pardon, sir?
APRF difference, APRF and APRF plus.
Sorry, I didn't know. Sorry.
Ashu ma'am?
Yeah. What is the novelty in this procedure of yours, this case report, Khyati?
So, sorry, ma'am, I cannot hear you properly.
What is the novelty in this procedure of yours?
Ma'am, this
PRF is routinely done nowadays.
So, ma'am, PRF is routinely done in our department, and I think that this method is not technique sensitive. It is easy to do. The PRF, the fibrin is easy to handle, whereas other bone grafts, like autogenous bone graft, is not. The procedure is not patient friendly. It will cause patient a little discomfort. Whereas in this, the patient has no discomfort, and it was also easy to handle and easy to place the membrane in the defect.
Okay, after how many days you remove the sutures you recommend?
14 days, after 14 days.
After 14 days. And do you recommend periodontal dressing after this?
After 14 days?
No. Before, immediately after suturing.
Yes, ma'am.
You recommend?
Ma'am, I have done periodontal dressing after the suturing.
Thank you.
Thank you, ma'am. Thank you, sir.
Yes, you can start.
Am I audible?
You are audible.
Yeah, a very good morning to one and all present here. In accordance with the theme of this conference, that is surgical periodontics redefined, I thought of presenting this case report on periodontally accelerated osteogenic orthodontics, which is also known as velcodontics. The scope of the periodontal therapy has gone far beyond just arresting the disease and eliminating the periodontal pockets. The periodontist is now an integral member of the interdisciplinary team. The orthodontic treatment, as we all know, is much sought after for enhancing the dentofacial aesthetics. But in terms of duration, this is the longest performed dental procedure, as we all know. So in this fast-moving world, any treatment that would consume more than 1 to 2 years is unwelcome, right? So the periodontist aimed to rescue and put forward a new technique that is named as velcodontics. It is a brainchild of an orthodontist and a periodontist, Dr. William Wilco and Thomas Wilco. In this technique, the tooth movement is achieved by selective alveolar corticotomy and bone grafting, as well as application of orthodontic forces. So with these three techniques, we are achieving this velcodontics. So what is the biomechanics behind this velcodontics? The main thing which we have to go know here is the regional axillary phenomena. This was first given by Froster in the year 1983. So this regional axillary phenomena can be maximized when selective decortication is combined with tooth movement. The surgical wounding of the osseous tissues result in striking reorganizing activity adjacent to the site of injury. So the bone then goes through a phase known as osteopenia, where the mineral content is temporarily decreased during this procedure. So while the alveolar bone is in transient state of demineralization, there is accelerated tooth movement because of the bone offers less resistance to the orthodontic forces. So this regional axillary phenomena causes the bone to heal 10 to 50 times faster than the normal conventional orthodontic tooth movement. So coming on to my case report, so this is a 26-year-old male patient who reported to our department with the chief complaint of proclined upper anteriors. The patient had aesthetic concerns as his marriage was scheduled less than a year time period. On obtaining a detailed case history of the patient, power technique was planned for this patient. So all the techniques which we are going to do is explained for the patient, and we got the consent from the patient. So the orthodontic bracket was placed 1 week prior to the surgery. So on the day of surgery, following the local anesthesia, full thickness flap was raised labially and lingually in the upper anterior region from canine to the contralateral canine. So the flaps are raised beyond the apices of the teeth to avoid the damaging the neurovascular complex. So buccal corticotomy cuts and cortical bone perforations are made near the malpositioned tooth using a piece of surgery unit. So the insert number which we have used here is OT6, OT6A, and OT7AS4 were used for osteotomy procedures. So a marginal bone is preserved and the interdental cuts are made 2 mm apical to the level of the alveolar crest. This was in accordance to the author Duker. So around 0.25 to 0.5 ml of bone graft, that is DFDBA, which I have used here, is mixed with the patient's blood and it is placed per tooth. Following which the flap is repositioned using a non-resorbable suture material. So patient was prescribed antibiotics and painkillers following the surgery. The first orthodontic adjustment was performed 2 weeks after the surgery, and the aligning and leveling was achieved using upper and lower 0.016 inch nickel titanium arch wires. So the orthodontic adjustment is made every 2 weeks interval for this patient. Okay, so as we all know, the conventional orthodontic therapy takes place for 18 to 24 months. In general, this relatively new procedure called as velcodontics takes only about 3 to 6 months without compromising the treatment quality. And our patient is currently under a follow-up for 3 months, and there is satisfactory results have been achieved in terms of tooth movement. Say there is about 1.24 mm tooth movement in a month. in a month on an average. So I would like to conclude with saying that this POD technique can be an attractive treatment option, and it can be a win-win situation for both the dentist as well as the patient. Thank you.
Dr. Ahmed.
Yes, sir.
What are the other terminologies can you use for this technique?
Sir, Bilcodontics or a periodontally accelerated or osteogenic orthodontics, sir.
Can you call it as a corticotomy?
Sir?
Corticotomy.
Yes, sir. Corticotomy, it was first put forth by Arthur Byron in the year 1893. And the other one called as Heinrich Kohl has stated a bony block movement in the year 1959. It is also known as corticotomy, sir, bony block movement.
Okay, have you come across any studies where PRF have been used along with this procedure?
Yes, sir. I have came across a study done by Wilrich et al. In the year 2004, sir. He have used PRF along with this bone graft, sir.
Okay, if at all you use a burr for in this technique, so I have to what depth you prefer?
So we have used piezo surgery unit in this particular case.
See, everybody cannot possess that piezo surgery.
Yes, sir. Yes, sir.
We usually carry out with burr only.
Yes, sir.
So if at all, if you want to use burr,
yes, sir.
Then what depth, up to what depth you want to prefer?
We can use a round burr for this procedure as well, sir. But one thing we have to make sure is that the interdental cuts are made 2 mm apical to the level of the alveolar crest, sir. So that is the consideration which we have to keep in mind while performing this procedure, either with piezo or as round burr, anything, sir.
Okay. Ashu ma'am?
Yeah, are there any disadvantages of this technique?
Yes, ma'am. There are certain disadvantages with this technique, like it is more expensive than the functional braces, as we all know, and additional surgery is required, and there is increased possibility of pain, swelling, and infection following the surgery, ma'am. These are the disadvantages for this technique, ma'am.
And what about the mobility of teeth? Is there likely to be more mobility?
There was, ma'am?
Yeah.
There was mobility seen after performing this procedure, ma'am, but we are stabilizing it with titanium arch wires of 0.016, ma'am, and we are giving the functional load only after 2 weeks of this PAO technique, ma'am.
Okay, thank you.
Thank you, ma'am.
Next poster, please.
Ma'am, am I audible, ma'am?
Yes, you are audible.
Good morning to all the respected dignitaries present here. Today, I'm going to present my poster on partial root resection in a modified approach. So as we know, root resection is a process by which one or more roots of a tooth are removed at the level of furcation, leaving behind the crown and the remaining roots in function. So in the present case report, a partial root resection was done as an alternate approach to complete root resection. So coming to the history, a 38-year-old male patient came to the department with a complaint of pain in the lower right back tooth region. And on clinical examination, we observed that there was a 10 mm pocket depth, and also there was grade 2 furcation and grade 1 mobility in the same region. And the periapical radiograph showed that there was bone loss in relation to the distal part of the root, and also there was furcation involvement. So the objective of our report was to retain the complete crown with minimal alteration to the root structure, as the distal root of the molar was observed to have only minimal attachment left. So coming to the surgical procedure, on the day of examination, a thorough oral prophylaxis was done for the patient. And the patient was recalled after 2 weeks for root canal therapy. After the root canal therapy was completed, a mucoperiosteal flap was raised, following which the distobuccal root was resected, after which the area was thoroughly debrided, and bone graft mixed with PRF was placed in relation to that area, after which the sutures were placed and a periopack was placed. And after 1 week, the patient was recalled for suture removal, and 4 weeks post-surgery, a prosthesis was given to the patient. And it was also observed that there was a reduction in the probing pocket depth, and the mobility was also reduced. So to conclude, I would say that this conservative approach of root resection can be a favorable alternate to the conventional root resection procedure.
Thank you.
Dr. Pranavi,
Yes, sir.
what are the other treatment modalities?
Sir, for grade 1 furcations, for grade 2 furcations, usually root resection, hemisection can be done, sir.
Ashu ma'am?
Yeah. Okay, no questions. Thank you.
Thank you.
Next presentation, please.
Am I audible, ma'am and sir?
You are audible, ma'am.
Yes,
Can
yes.
start.
A very good morning to all the respected delegates. Today I'm going to present a case report on hereditary gingival fibromatosis. As you all know, hereditary gingival fibromatosis is a rare condition characterized as a benign, slowly progressive fibrous enlargement on gingiva covering the teeth in various degrees, leading to functional and aesthetic impairment. A 19-year-old male patient reported with chief complaint of anesthetic enlarged gingiva, which was persistent since childhood. Upon clinical examination, generalized fibrotic bulbous enlargement of the gingiva covering 1/3 of the crown structure was present clinically. Upon detailed family history, it revealed the presence of similar condition in his mother, younger twin sister, and maternal grandmother. Patient do not have any drug history or any significant medical history. In figure A, it is showing the preoperative view of the patient and the gingival growth in the patient. And in the figure B, similar gingival overgrowth was seen in patient's sibling. To address the patient aesthetic concern, external bevel gingivectomy was done using number 15 blade and a Kirkin knife. And the gross specimen of the tissue was taken and was sent for histopathological analysis. Figure D shows the immediate post-operative result. After the surgery, the bleeding was stopped and periodontal pack was placed, and patient was follow up after 1 week. And the figure E is showing the post-operative view after the 3 months. Patient was also given positive pressure appliance to prevent the recurrence of the condition. Upon microscopic examination, it was found that the epithelium was hyperplastic, hyperkeratinized with long, narrow retinal ridges, which were peripheral in arcading pattern, and the connective tissue was of densely collagenous nature with fascicles of collagen bundle and interspersed with spindle-shaped fibroblasts. Discussion. Hereditary gingival fibromatosis can occur as syndromic or as isolated disorder. The mode of genetic inheritance is usually autosomal dominant, but literature supports autosomal recessive form of the hereditary gingival fibromatosis also. In this patient, the mode of genetic transmission is consistent with autosomal dominant inheritance since both the sexes and successive generation were affected. Differential diagnoses include enlargement associated with hormonal changes, drug-induced gingival overgrowth due to inflammation, or pseudo-enlargement due to tumor and cyst. To conclude, this poster presents diagnosis and treatment plan of a patient with hereditary gingival fibromatosis. Gingivectomy followed by positive pressure appliance therapy prevented recurrence of and appreciably improved the aesthetic and masticating competence. Thank you.
Okay, what different investigations to be carried out in this case?
Okay, sir. I have read the literature. One of the study has been done by Nibai et al. In 2003. They have done the genetic linkage, and they have found that the gingival fibromatosis have a heterogeneous genetic expression. They found the trait of HGF on chromosome location 7, 10, 11, 12, and 14. And several other literature supports that after the immunohistochemical study and also cytochemical studies, they have found that epidermal growth factors and the epidermal growth factor receptors were present in higher amount in the basal cells as compared to the control group in this
hereditary gingival fibromatosis patient. So these are the other investigations that could be done, but because of its heterogeneous nature, genetic investigation is usually not suggested.
What about the prevalence of this condition?
So this HGF is have a very rare prevalence. It has 1 in 750,000 people. It occurs in 1 in 750,000.
What about its recurrence?
The recurrence rate is reported rare, but in several literature, it is found that it can recur in as soon as 6 months to up to 2 years.
Okay.
But the recurrence is rare.
Ashu ma'am?
Yeah. I can see in your picture E that there's spacing between teeth, Nasreen.
Yes, ma'am. Yes.
Yeah, and in the next picture, you are showing that there's no spacing.
Ma'am, the next picture, it is the frontal ma'am view. The spacing can be seen from the lateral side only, ma'am. There was spacing, ma'am, because preoperatively in figure A also you can see the spacing, ma'am. It is not evident in the frontal view.
Okay, and the canine has also erupted properly, the left canine, as
Ma'am,
can be
it
seen
was
in the picture B.
Ma'am, it was erupted earlier also, but because of the gingival overgrowth, the gingiva had covered it up to 1/3 of the position. It was covered up to the 1/3 of the clinical ground.
Okay, and were there any pockets in it, periodontal pockets?
Yes, ma'am. There were pseudo pockets present in the patient. Many pseudo pockets were present.
Okay, no bone loss?
No, ma'am. There was no bone loss present.
Okay, thank you.
Okay, ma'am. Thank you.
You can start with your presentation, ma'am. Poster number 88, you can start with your presentation. You're not audible.
Good morning, everyone. The title of my case report is Management of Pyogenic Granuloma with 980 nanometer diode laser. Coming to the introduction, pyogenic granuloma is a prevalent benign mucocutaneous lesion which is exhibited by an exuberant tissue caused by a local irritation or a trauma. It was first described by Hallihan in 1844, and the term pyogenic granuloma or granuloma pyogenicum was presented by Hartzell in 1904. Pregnancy tumor, which is a variant or a type of pyogenic granuloma, it occurs during pregnancy or maybe in cases of menopause. It was first described by Ponsett and Dorr in 1897. So coming to the case report, a 27-year-old female came to Department of Periodontology with the chief complaint of swelling of gums in the anterior region, which was interfering with her ability to speak, to talk, or to eat. So medical history revealed that she was a lactating mother of a 1-month-old baby, and intraoral examination revealed that there was papillary enlargement in relation to the labial aspect of the lower anteriors, and there was loss of scalloping. Stippling was also absent. The position of the gingiva was coronal to CAJ, and there was bleeding on probing present. Coming to the lingual aspect of lower anteriors, there was enlargement of triangular shape, which was pedunculated, and also bleeding on probing was present, and the contour was the scalloping contour was lost. There was loss of stippling also, and the position of the gingiva was coronal to the CJ. So based on the clinical examination, we came to the provisional diagnosis of pyogenic granuloma. So we advise the patient for a radiographic investigation, including OPG and also blood investigation. The OPG revealed slight crestal bone loss, which was generalized, and blood investigation were within the normal range. So for the case management of this lesion, we instructed the patient about the treatment plan, and informed consent was taken. Then for the treatment of this lesion, we used a diode laser of 980 nanometer wavelength of power watt of 1.5 wattage in a continuous wave mode. And we excised the lesion from the buccal aspect as well as the lingual aspect. After the excision, the tissue was approximately 20 into 12 millimeter in size, and then we sent it for histopathological examination. In 4x magnification, we observed that the epithelium was parakeratinized. It was extremely proliferative, and also we examined the retipex present. And in 10x magnification, we observed that the connective tissue stroma included of dense infiltration and also collagen fiber bundles and engorged RBCs. So, which confirms our provisional diagnosis of pyogenic granuloma. And this was the post-operative picture, which was taken after 10 days of the treatment. So hereby, I want to conclude by saying that no adverse effect from the use of laser was seen in this patient, and intraoperative bleeding was also less as compared to the conventional surgical excision. The laser-assisted surgical treatment of the lesion can be considered as a good modality for very large and vascularized lesions. Thank you.
Differential diagnosis, what was the size of this lesion?
Sir, it was approximately 20 into 12 millimeter on the lingual aspect.
20 to 12.
Yes, sir.
Did you check for pulsating of the lesion?
Yes, sir, it was
Or,
non-pulsating.
Did you subject the patient to USG and or CT for this?
No, sir. Sir, as the lesion was pedunculated, we did not advise her for those investigations, sir. And
No,
she was
since
also, yes, sir.
How about the lesion, whether it was fibrosed?
Yes, sir, it was fibrosed.
So in fibrosed case, it will be difficult for to observe pulsation, no?
Yes.
So is it fair to go for USG or CT?
Okay, sir.
What are the disadvantages of using lasers in this case? Are there any disadvantages?
So with the usage of lasers, sir, we did not had any complications, sir.
Okay. Ashu ma'am?
Yeah, I just wanted to clarify this statement, no adverse effect from the use of laser.
Yes,
so how did you check the adverse effect?
Ma'am, post-operative pain was not there, and also minimal bleeding and patient discomfort was very minimal, ma'am.
No, that is the usual advantages of laser.
Yes,
but what
ma'am.
was the adverse effect that was affected? I mean, expected.
Ma'am, if we do a conventional surgical excision, ma'am, there may be post-operative bleeding and there may
That
be
is usual.
discomfort to
Thank
the
you.
patient.
Thank you.
Thank you.
Next slide, please. Can we have the next presentation? You can start with your presentation, ma'am. You can start with your presentation. You are not audible. No. Hello. You can start with your presentation, please.
Hello.
Yes, now you're audible.
Good morning, everyone. So the aim of my present case report is to evaluate the use of free gingival graft to increase the width of attached gingiva. So the patient reported to the Department of Periodontology with a chief complaint in difficulty in maintaining oral hygiene. On examination, we observed that there is a shallow vestibule with a frenum full. We opted for a pre-gingival graft procedure in the lower anteriors, canine to canine. The recipient site was prepared using a scalpel, and then a donor site at the palate was prepared. The measurement was taken using a foil, and the graft was obtained from the pre-gingival graft was obtained from the palate. Vestibuloplasty was done in the lower anterior region, and then the graft was placed. Suturing was done, and suturing was done 14 days, and 6 months post-operative photograph has been given here, concluding that the 6-month follow-up case shows a significant increase in the width of attached gingiva, indicating that FGG is a suitable mucogingival surgery which can be used to increase the width of the attached gingiva. Thank you.
What do you mean by pink and white aesthetic scores?
Hello, sir.
What do you mean by pink and white aesthetic scores? Have you heard about it? Can you listen me?
Hello, can you hear me, sir?
What do you mean by pink and white aesthetic scores? Scores.
Hello. I can't hear you, sir.
We can hear you. You are audible, ma'am.
Pink and white aesthetic scores. Thank you. Ashu ma'am.
Yeah, she can't hear and she's muted. So let's go to the next.
Can we have the next slide, please? After, just a minute. Ma'am and sir, we have one more poster which was missed in the first round. That is poster number 68. So he will be presenting after this.
Yes, ma'am.
Okay. Yeah, you can start with your presentation. Ashita, you can start.
Thank you. Am I audible, ma'am?
Yes, you are audible.
Good afternoon, sir. Good afternoon, ma'am. My poster presentation is on the title Occurrence and Removal of Pseudoepitheliomatous Hyperplasia using 980 nanometer diode laser, a case report. Introduction. Pseudoepitheliomatous hyperplasia is a reactive proliferation of epithelium, and it is characterized by hyperplasia of the epidermis and ethnic cell epithelia. It mimics squamous cell carcinoma, and its etiology includes inflammation, infection, trauma, and neoplasia. To prevent the functional disorders and any other complications associated with this, it is necessary to remove it, which is conventionally done using scalpel surgical technique. But this technique has various complications such as intraoperative bleeding and wound healing. So laser have been used to overcome these complications in various maxillofacial surgeries. Diode laser have been proven to be an efficient tool for such procedures. Case report: a 18-year-old female patient came with chief complaint of overgrowth on the back region of her upper tooth, and on intraoral examination, the lesion seems to be exophytic, well-defined, pedunculated with regular margins. The surface was erythematous, smooth, warty, dome-shaped. With consent of the patient, informed consent of the patient, case management was done by excising the lesion from its base using 980 nanometer diode laser from in continuous wave mode, and the tip was moved in sweeping motion. The tip was fiber optic tip of 400 micrometer diameter, and the power output setting was of 1 watt. The lesion was
measured to be 6 into 8.5 mm, and the hemostasis was achieved, and the lesion was sent for histopathological examination. Histopathological examination revealed increased epithelial squamous cell epithelium thickness with acanthosis, and hence suggesting of pseudoepitheliomatous hyperplasia. Patient reported uneventful healing, and the clinical examination also showed that successful healing when evaluated in the first week and the second week of follow-ups. Hence, we can conclude that use of diode laser is a successful alternative for the removal of pseudoepitheliomatous hyperplasia, and it causes less post-operative complications and less recurrence. Thank you.
Okay. What are the other different treatment approaches other than lasers for this?
So most commonly scalpel method is used.
Pardon?
Most commonly scalpel method is used.
Okay.
And
what are the newer advancements in lasers? Newer advancements in lasers.
So various types of lasers are now being used, which includes hard tissue cutting lasers are now used, and twin laser, RPM laser is newly used lasers.
Okay, Ashu ma'am.
It's okay. Thank you.
Thank you, sir. Thank you.
Last poster by Dr. Shaurya. Dr. Upadhyay, poster number 68. You can start presenting. Dr. Upadhyay. Dr. Shaurya Upadhyay, you can start presenting.
Hello.
Yes, you are audible.
Yes, ma'am. A very good afternoon to one and all. Today I'll be presenting my poster on the topic, a unique suturing technique in the management of vestibular depth. Coming on to the introduction, vestibular deepening is a procedure for gaining adequate depth of vestibule and attached gingiva to prevent the recession of attached gingiva. The objectives of vestibular deepening being it is done to increase the depth of attached gingiva, to facilitate the self-cleansing activity, and to prevent the traction of gingiva produced by muscular and fibrous attachment that lead to progression of gingival recession. Years reported to the department. On clinical examination, patients showed to have high female attachment vestibule, as it can be appreciated in the picture. Based on clinical features, investigation, treatment, vestibular deepening, and then suturing was planned. Subsequently, the free edges of the label side to flap to fold it inwardly, and then interrupted sutures were given, starting from the distal to the mesial direction by passing the suture through the buccal surface of the wound, inverting the epithelial margin of the wound inward. The periosteum was left exposed in the area between initial horizontal incision and coronal margin flap. And then periosteal sutures were placed at the depth of the vestibule, and patient was assessed at baseline and 1 month follow-up was done. The coming to the healing process took an uneventful pathway. The sutures were removed, and which allowed the epithelium to proliferate and approximate with the opposite side, and adequate vestibular depth was achieved. And patient was able to maintain oral hygiene easily after the healing period was over. Coming on to the conclusion, vestibular deepening offers as a successful and viable treatment for giving the width of adult gingiva and prevents the recession. Now, I would also like to add that in the suturing procedure, one of the limitations is that I used two different color sutures to demarcate one in which I folded the epithelium inwards and then taken interrupted sutures, but that has not been done in this. So, I mean, the differentiation is difficult. And for post-operative photograph, after 1 month follow-up, my patient was not able to show up for the because of she was not well. She was not able to show up for the photograph. So this is a photograph she sent because of which it is unclear. Thank you.
What are the different techniques to increase vestibular depth?
Sir, there's Clark's technique. There's periostal fenestration technique, and there's neighbors reposition flap with minimal post-operative exposure.
Okay. Ashu ma'am?
How much was the reattachment after healing as compared to the conventional vestibular deepening using your sutures and the conventional vestibular deepening? How much was the reattachment? Was there any difference?
Ma'am, not as such. Like I tried this technique because I read it somewhere saying that because conventional technique usually there is loss of a little bit loss of the vestibular depth due to faster reepithelialization, but this does not do faster reepithelialization.
You didn't check basically.
No.
Okay, thank you.
Thank you, ma'am.
So I guess all the poster in this session of case reports are over, sir and ma'am. I would like to.
Rashmi ma'am?
Yes, sir.
1 second, can I speak?
Yes, sir.
Ma'am, thank you for providing us an opportunity. I thank Dr. Gopal Krishnan, Dr. Nitin Dani, Dr. Sangeeta Mugulekar, Dr. Anita madam, and especially you, and for conducting a wonderful. Yesterday I observed whole day, and today also I was involved in this. It was a wonderful, really wonderful.
Pleasure, sir. Our pleasure.
Okay. Thank you very much, ma'am. We will upload our marks also. Okay, ma'am.
Thank you. Thank you, sir.
Thank
you for your valuable support and time, sir and ma'am.
Thank you so much, Dr.
It was
Rashmi,
really great pleasure
for
working with you.
coordinating, and thank you, Dr. Nagaraj. It was wonderful working with you. And thank you. We'll upload the thing.
Thank you. Thank you, ma'am. Thank you. I hand over to Dr. Shituja for the next session.
Yeah, thank you, Rashmi ma'am.
Yeah.
Very good afternoon to one and all. I would like to welcome everyone on behalf of 45th ISP Virtual National Conference. I would like to introduce our judges, Dr. Padmakant Manava. He's a professor and head of department, Gitanjali Dental College and Research Institute, Udaipur, Rajasthan. He has completed an BDS in 2007 and MDS in 2010. He's awarded for Clinical Excellence in Periodontics in 2019, Best Researcher Award by International Scientist Award on Engineering, Science and Medicine, August 2021, and a member of editorial board of multiple journals. Welcome. Welcome, sir. And our second judge is Professor N.D. Gupta. He's a professor in periodontics of Aligarh Muslim University, Aligarh. Done BDS in 1987 and MDS in 1992. Professor at AMU Aligarh. Has teaching experience for more than 28 years and 19 years as a professor. Has 123 publications with total citations 774 and H index of 13. He's been an examiner of multiple MDS, BDS, and PhD universities. Welcome. We can begin with a session. We have 3 minutes for the presenter and 2 minutes for the judges to ask questions. Let's stick to the timing so that we can follow the schedule. Can we have the first slide, please? Janvi? Yeah, thank you. Dr. Himanshi? Dr. Himanshi? Dr. Himanshi, can you hear us? Yeah, can you begin with your presentation?
Sorry, ma'am.
Dr. Himanshi? Yeah, can you begin with your presentation?
Yes, ma'am. Good afternoon, everyone. Implanters does not just repair teeth to make them better for chewing. Nowadays, patient demand increased aesthetic for treatment outcome. So, we should be familiar with multidisciplinary approach, such as periodontics treatment involving orthodontics, prosthodontics, endodontics, and maxillofacial surgery. With this, I'm here to present poster on the topic multidisciplinary aesthetic rehabilitation in a patient with enamel hyperplasia post for fixed orthodontic treatment, a case report. A 24-year-old female patient, uneven gingival contour, was referred from the Department of Orthodontics for gingivoplasty. On intraoral examination, we show inflamed margin gingiva and tension test positive. For this case, gingivoplasty and phenectomy was planned. So case was started with after administration of local anesthesia, and then marking was done with the hematoxylin pencil at the level of gingival jana. Then gingivoplasty was done using electrosurgery unit. The next procedure was done phenectomy. Frenum was hauled with a hemostat inserted to the depth of the vestibule, and frenum was inside with 15 number blade. After triangular resected portion of the frenum was removed and muscle fibers were relieved. 5-0 silk suture was given at the wound site and medication was prescribed to the patient. And patient recall after he refers to the Department of Prosthodontics, the aesthetic results were obtained after the treatment. And finally, to conclude, the integrated multidisciplinary planning allow for the success of aesthetic and functional rehabilitation. Thank you.
So, could we have the questions, please?
Dr. Himanshi, you have done the gingivoplasty. What
Yes,
was the
sir.
rationale behind gingivoplasty?
Yes, sir.
You have done the phenectomy along with the gingivoplasty.
Yes,
what was
sir.
the rationale behind your treatment modality?
Yes, sir. Rational.
Yes. You have done the gingivoplasty. In this case, no, you said that I have done the
Yes, sir.
phenectomy along with the gingivoplasty. What was the rationale behind your treatment procedure?
Inflamed marginal gingiva. No? Sir, because inflamed marginal gingiva. This is positive. Hello?
Whenever you proceed, Dr. Himanshi, whenever you give any perform any procedure, there should be a clear concept why you are performing this procedure and what was the objective behind it. That is the rationale. Why you have performed this gingivoplasty? My question is this.
Because, sir, marginal gingiva, inflamed marginal gingiva, and tension test is positive. That's why we perform the gingivoplasty and phenectomy.
No. That is not a thing. Gingivoplasty, when the tension test is positive, you will not perform any gingivoplasty or gingivectomy procedure. The treatment procedure will be together different.
Marginal and interdental gingiva
I think your purpose is to have the proper crown lengthening in this and gingival contour, not the tension test. Tension test is, if it is possible, you cannot perform the gingivectomy or gingivoplasty.
Yes, sir.
That is why you must have a clear treatment modality, basic of the treatment modality. Okay, fine.
Sir, I cannot hear you.
Sir, you are not audible.
Sir, you are not audible.
Dr. Padmakant, you can ask the question for the candidates.
Sir, you are not audible.
Dr. Padmakant, sir, are you here? Dr. Padmakant? Can we proceed with the poster? I can't get in touch with Dr. Padmakant. I'll just try again. Can you have the next slide, please?
Hello?
Hello? Yeah, you can begin. Dr. Gupta, are you here? Sir?
I am here.
Yes, sir. So I'm trying to get in touch with Dr. Padmakant too. Should we begin with the second slide?
You can proceed for the next one because
yes.
Time will be over there.
Yes, yes. You can begin. I'll try to get in touch with Dr. Padmakant sir again. Who's supposed to present is kindly begin. Dr. Ashna.
A very good afternoon to everyone present. I'm here today to present a case report of a metastatic breast carcinoma, which manifested as a solitary gingival enlargement. Tumors can metastasize to the oral cavity, though it is considered very rare and it represents only approximately 1% of all oral malignancies. The gingiva represents the most common site of localization of metastasis, followed by the tongue. I present here a case of a 37-year-old female patient who reported to the department with the chief complaint of swelling in the upper front tooth region. She had a history of pain, an increase in space in between the upper anteriors, and also reported a rapid increase in the size of the swelling over a span of 2 weeks. The patient had a history of radical mastectomy done for metastatic breast carcinoma 9 months ago. She had undergone radiotherapy of 30 gray 4 months ago, and she was currently undergoing chemotherapy. The clinical examination revealed a dumbbell-shaped swelling involving the buccal and the palatal aspect, and the swelling was approximately 1.3 into 1.1 centimeters in dimension on both aspects. The radiographic analysis using an IOPA and a CBCT revealed extensive bone loss in the mid-alveolar region in relation to 1.1 and 1.2. Excision of the lesion was done, which resembled a very large bony defect, and the bony defect resembled a moth-eaten appearance. The defect was closed with Abgel and sutures were placed. The 3-week post-operative review showed satisfactory healing of the wound, and the excised tissue was sent for histopathological investigation. The histopathology revealed dysplastic epithelial cells and nuclear pleomorphism, which gave a confirmatory diagnosis of metastatic carcinoma of the gingiva. In the literature, there have not been any studies that had reported metastatic breast carcinoma, which were presented as a solitary gingival enlargement, especially of this big in size. But there were studies by Nadia in 2020 and Polios in 2011 where breast carcinoma had presented as a gingival thickening or a periodontal abscess, respectively. So in our case, initially the lesion was confused with a pyogenic granuloma, but the rapid growth in the size of the swelling and with bony involvement pointed towards malignancy. PET scan was later done for this patient, which revealed multiple metastases in the brain, liver, and all other intramuscular soft tissues. To conclude, the importance of this case report highlights the high level of suspicion a clinician should maintain while examining a patient with history of cancer to detect any evidence of oral metastatic tumors. So these are my references, and thank you.
Okay, doctor. You have said that there is a rare case report. What is the prevalence rate of the breast cancer metastating to the oral cavity?
Sir, it is very rare. I read a review where it was 65.4%.
60.5. This is too much. Rare is very small proportion. Second thing is, what about the patient is, you said that there's an extensive metastasis in brain, lung.
Yes, sir.
Liver,
yes, sir.
but you have taken the medical treatment, the history of medical treatment.
Yes, sir. She is undergoing chemotherapy with carboplatin.
Yeah. Then what will be your treatment? Should be a treatment protocol in that cases? There's a definite protocol for the dentist giving the dental management.
We excised and we are planning to do a review.
And you have to follow the certain protocol for that such cases. Otherwise, it has some severe effect afterwards. That is
I'm sorry, sir. I don't.
Okay, fine. That is okay. Dr. Padmakar, you may please ask.
Sir, we can't hear you, sir. So we can't hear you. So we can't hear you. There is some issue from sir's side, so we can't hear him. So he's texting in the chat box the question. You can answer him. He can hear you. Ashna?
Yes, ma'am. Yes, ma'am. 1 second.
Yeah, so sir will type immediately.
Okay, ma'am. Okay. I'm in the chat box, ma'am.
Yeah, so sir will ask and you can reply verbally, so we can hear you.
Okay, ma'am. Namchin syndrome is causes paresthesia of the cheeks and lips because of invasion of tumor cells. No, sir, it was not present in my case. The only difficulty the patient had was pain in the site of the swelling. She had extreme pain and she was unable to consume food. That is why we plan to do an excision. Thank you, sir.
Okay, thank you. Could we go to the next slide, please? Yeah. Dr. Shramika, can you please start with the presentation?
Yeah, good afternoon, everyone. My poster presentation is on transpositional autogenous bone block for vertical and horizontal ridge augmentation, a case report. Introduction. Bone block grafting is a technique that has been used for many years for implant treatment and also rehabilitation of partially or fully edentulous patients. For this procedure, various types of bone grafts are available, such as autologous bone grafts, heterologous or synthetic or alloplastic materials. But among these various materials, autologous bone grafts have found to be gold standard because they have shown the various properties such as osteogenic, osteoinductive, and the osteoconductive properties. So the best technique is still considered the autograft. So the purpose of this case report is to report a case where transpositional autogenous bone block procedure was performed for vertical and horizontal ridge augmentation. For the materials and the methods used for this purpose are osteosynthesis screws and the fixation plate, and the piezoelectric device was used. Coming to the case report, a 32-year-old male patient was referred from the Department of Prosthodontics to Department of Periodontics with the complaint of insufficient vertical and the horizontal ridge for the placement of the implants. So this is a clinical picture, and this is a preoperative radiograph where the vertical and the horizontal insufficiency of the bone was evident for the placement of the implants. So a transpositional autogenous bone block was planned in this patient. Surgical protocol involves administration of local anesthesia followed by crestal incision with the vertical releasing incision at the mesial line angle of 1-1 and also the 2-3. Followed with the reflection of the flap, reflection of the full thickness mucoperiosteal flap, and the piezoelectric device was used, which was used for the giving the cuts and the bony block harvested. After the harvesting the bony block, this was stabilized with the help of the titanium fixation plate and the osteosynthesis screw. And the gap which was present between the bony plate and the palatal bony wall was filled with the hydroxyapatite graft, covered with the collagen membrane, and it was further stabilized with the figure of 8 suture with the help of resorbable sutures. And the flap is repositioned back, ensuring that the primary closure has been achieved with the interrupted sutures. This is a post-operative image after 1 month, and this is the post-operative radiograph after 1 month showing the substantial bony fill. This can be concluded that this technique was found to be effective in vertical and horizontal bone augmentation, and it further reduces the surgical site morbidity and obviates the need to procure bony block from the other sites. Thank you, everyone.
Dr. Nandini?
Yes.
How much gain in vertical and horizontal bone level is achieved?
Sir, actually, there was the two extraction sockets here, sir. So we have achieved almost the entire fill of this bony sockets, this empty sockets, sir, with the bone. Approximately 5 mm to 6 mm we have achieved, sir. Further, we are planning for the implant placement, sir. Till now, it was the 3 months was completed, sir. It was recently done in our department, sir.
Okay, fine. What about the, you have said that transpositional. What are the advantages of transpositional block graft over conventional grafts?
Usually in the conventional graft, we will select the other donor sites, sir. Example like mandibular ramus region or symphysis region. Here we are using the same bony block region which was present at the recipient site itself, sir. So we can further reduce the morbidity and the discomfort to the patient post-operatively it was performed, sir. And we can also achieve the thin laminates. It is an alternative technique to the Coris technique, sir.
What is the completion of the healing in the bone? You said that post-operative after 1 month.
Yes, sir.
1 month, I think you cannot predict that this much bone is achieved.
Yes, the bone rate was better, sir, because
no better. The complete healing of the bone is not by the 1 month.
Okay.
Only the soft tissue healing is complete by 1 month.
Yes, sir.
Not the bony healing.
Okay,
Dr. Nandini, you have a question from Dr. Padmakant sir in the chat box.
Yes, sir. We can't evaluate within the 1 month because 3 months and the 6 months is the correct post-operative radiograph. But I can't able to place the 3 months post-operative radiograph, sir. It was taken recently, right 2 days back, sir. But it was better, sir. It was 5 to 6 mm, sir, and there is no post-operative complications and the discomfort also, sir. Sir, BBS suture.
The reason for selecting the BBS suture, so I was asking.
BBS. Sorry, sir, I don't know what is BBS, sir. I have used only silk suture, sir. And it was the 30 resorbable suture, sir. And over that, I have used the silk suture, sir, normal silk suture.
Black braided suture instead of monofilament.
Sir, the collagen membrane was already stabilized, sir. Only 30 resorbable suture was used, sir, for the extra stabilization in order to provide the primary stability for the graft, sir. And this was the normal silk suture, sir, using silk suture.
Okay, thank you. Could you go to the next slide, please? Yeah. Dr. Praveen, could you begin with your presentation? Dr. Praveen?
Yes, ma'am. Yes, ma'am.
Yeah. Could you just on your video and begin the presentation?
Good afternoon, everyone. My topic is step-by-step management of gingival reactive lesion and associated residual soft tissue defect in posterior teeth through single-stage surgery, a rare case report. Introduction. Mild chronic irritation adjacent to the gingival tissue may induce gingival enlargement of different form and consistency known as gingival reactive lesion, inflammatory fibrous hyperplasia, pyogenic granuloma, peripheral ossifying fibroma, irritation fibroma, peripheral gyres, and granuloma are the different type of reactive gingival lesion of oral cavity. Gingival irritation fibroma is one of the most common reactive lesion, and its size is usually not more than 1.5 centimeter. Complete surgical excision along with the elimination of the aggravating factor is treatment of choice generally adopted by the general dentist without giving due consideration to its size, location, and post-operative scale. Case report. A 50-year-old otherwise healthy female patient was reported to the institutional outpatient department of parodontology with chief complaint of swelling of gums in the left upper back teeth and difficulty in brushing for past 1.5 year and 3 months respectively. History disclosed that the lesion was small. Gradually it gained the present size. On clinical examination, generalized mild papillary inflammation with bleeding on probing and generalized normal gingival sulcus depth on periodontal probing were observed. This is the preoperative surgical procedure and postoperative use. Discussion. It is always a prodigious task for the periodontist while treating recurrent large gingival reactive lesion, as extensive surgical excision might include large residual soft tissue defects, which may provoke post-operative discomfort, sensitivity, difficulty in maintaining oral hygiene, etc. Literally, a displaced flap is difficult to execute in such location, whereas subepithelial connective tissue graft harvesting for the management of the residual soft tissue defect is technique sensitive procedure too. Therefore, looking after the same concurrent repair of the anticipated residual soft tissue by coronally reposition flap was planned and implemented in this case. CRF was planned on the basis of its primary requisite of the band of attached gingiva apical to the soft tissue defect and deep vestibule, which was well observed in the present case too. Secondly, CRF is less time consuming, simple to learn and execute. Conclusion. CRF was an effective treatment modality for preventing the functional difficulties that might be associated with the residual soft tissue defect following through surgical removal of a recurrent irritation fibroma. Complete residual soft tissue defect coverage was obtained without any ill effects in the present case. Thank you.
Dr. Parveen, in the case, in the title of the your presentation, you said it is a rare case report. But in introduction, it is you have said that it is a very common, most common reactive lesions. You can justify the two statements.
Sir, because commonly is around mostly less than 1.5 centimeter, but this is around 2 centimeter.
That is 1.5 and 2 centimeter, they hardly make any difference. But you should see the things that if the title, if you have written the rare case report, and in the introduction, it should not be there, right? Second thing.
Hello, hello.
In the histopathology, you have made as one piece picture of that. What is the histopathology picture of this case? You have shown a picture, a histopathological picture, but photo. What is the picture of the histopathological picture of the lesion? You should justify those things on the basis of which you have made your diagnosis. You have drawn shown the photograph of the histopathology. Can you describe this photograph, histopathological picture? Okay, fine. What is the prevalence rate, recurrence rate of this lesion?
Rarely reoccur.
No. Recurrence rate is, what is the recurrence rate?
Hello.
Okay,
hello.
fine.
You have questions in the chat box too. Dr. Padmakant sir has said. Praveen?
Hello.
Yeah, you can check your chat box. Etiology of this reactive lesion and recurrence rate. What did you do to address the etiology? Praveen? Dr. Praveen?
Hello.
Can you hear me? Dr. Praveen? I don't think he can hear us. So should we proceed to the next slide?
Yes, surely.
Hello.
Yeah. Thank you. Can you have the next slide, please? Dr. Surbhi, can you begin?
Yes, ma'am. Good afternoon, everyone. The topic of today's poster presentation is aesthetic treatment of gingival melanin hyperpigmentation with electrosurgery and with scalpel technique, a comparative case report. So to begin with, excessive gingival pigmentation is a major aesthetic concern these days. Here, one thing which needs to be emphasized is that the pigmented gingiva is neither a clinical condition nor a disease which necessarily needs any treatment. Rather, here the patient walks into a clinic only to seek for the aesthetic concern. So for this, various treatment modalities have been reported for the depigmentation, and in this the poster describes two simple yet very effective surgical depigmentation techniques. So in this, the two patients reported in outpatient department of periodontology with the chief complaint of black gums with an aesthetic concern. So the treatment plan goes like this. First, the non-surgical therapy was followed by the surgical therapy. In both the cases, the oral prophylaxis and the oral hygiene instructions were given to the patient. So in the first case, the pigmentation of the gingiva was treated with the help of the electrosurgery. It was first followed by the topical anesthetic spray, and then the local anesthetic infiltration was given to the patient. And with the help of the electrosurgical tip, that is the straight tip, was used to remove the superficial layer of the pigmented tissue, and that is the layer of the epithelium was removed, keeping in mind that the bone needs to be protected. Exposure of the bone was avoided. And then the char layer was formed, and the patient was followed for after a week, and a 1-month follow-up was done. Similarly, another case was done with the help of the scalpel technique. Similar procedure was non-surgical therapy was delivered to the patient, but in the scalpel technique, 15-number blade, surgical blade, with the help of that blade, the pigmented tissue, the superficial layer of the epithelium was removed, and then a 1 week follow-up and a month follow-up was done. So to conclude, both the surgical modalities, they were able and they were successful in delivering the basic minimum and the satisfactory results to both the patients. But in the electrosurgery, it was reported that there was a minimal bleeding and patient discomfort was seen while using the electrosurgery. Thank you.
Dr. Surbi?
Yes, sir.
What is the long-term effect of difference in both the treatment modalities?
So in both the treatment modalities, the results were satisfactory, but the patient discomfort, the patient was very much convenient,
long-term means you have to see the recurrence rate of both the things.
So in both the cases, there was no such recurrence. So no repigmentation of the gingiva. And
recurrence rate means always it recurs. What is the recurrence rate mean? How much time it takes to recur again? It's not a permanent solution.
So recurrence rate of so it is very limited and is
silver nanoparticles.
Unmute. Can you please?
Nanoparticles could be made. Secondly, how uniform size of nanoparticles.
Excuse me.
Some questions.
Can you please unmute yourself?
Silver nanoparticles.
Apart from Surbi and sir, can others please unmute? Mute yourself. Sorry. Yes, Surbi, continue.
So the recurrence rate, so in the studies also it was seen that the recurrence rate is very limited and varied in both the surgical techniques. And in my case report, there was no, when I followed up, there was no recurrence as such.
You have only studied this case for the follow-up that case for a very limited time. That is why you don't know this thing. Okay, fine?
Yes, sir.
You have a question in your chat box from Padmanakant sir. Padmakant sir.
Compare the immediate post-op healing between two. So the post-op healing, so in the electrosurgery, we have got the charred layer. So the healing was very much better in the electrosurgery. But in scalpel, since there was no charred layer also, so the bleeding was a bit there, which was in the scalpel technique. So the patient was given the co-pack also, so just to avoid the excessive bleeding. And a pressure pack was also given to the patient with a sterile gauge. So in the electrosurgery, the results were much better because of the charred layer formation in the electrosurgical technique. So according to Oringer, there was an explosion cell theory. So this is the one theory which I remember. So only the one theory which I know as of now.
Okay.
So the electrosurgery, it has got a stronger influence also in terms of removing the melanin granules and the situated cells over there. And that is according to the cell explosion theory, which was quoted by Oringer in the year 2003.
Okay, thank you.
Thank you.
Could you go to the next slide, please? Yeah. Doctor, could you begin the presentation?
Yes, ma'am. I'm audible?
Yes, you are. You can proceed.
Good afternoon, Jesus. Today topic of my poster presentation is buccal bone morphologic changes in corticotomy and microosteoperforation assisted orthoparodontally accelerated osteogenic orthodontics. Suppose the use of osteotomy to aid a tooth movement. It also aids a rapid dissection of the periodontal ligament by utilizing a tissue engineering principle based on to the original acceleratory phenomenon. To aim to evaluate and compare the rate of tooth movement and associated buccal bone morphologic changes between a corticotomy and flapless microosteoperforation. A case report of 18-year-old female with angles class 1 malocclusion with DAY type 1 and type 2 modification. Patient underwent a premolar extraction. This was followed by leveling and alignment of consolidation of spaces. In this, at the corticotomy site, full thickness mucoperiosteal flap is elevated starting from the 3 to 4 mm from the alveolar crease extending to the apices of the roots, after which corticotomy cuts were given and a demineralized freeze-dried bone allograft is placed over the site, and after placing a PRF membrane, sutures were given. At the microosteoperforation site, 3 microosteoperforation is done at the distance of 5 mm, 8 mm, and 11 mm from the alveolar crest, and after which pre and post of CBCT analysis were done to check the change in the buccal bone thickness and a tooth movement. From this, we can see that there is increase in the buccal bone thickness at both corticotomy as well as flapless microosteoperforation site, but the thickness is more at the corticotomy side as compared to the microosteoperforation side, but the difference is not significant at both sides. Hence, to conclude that both techniques causes increase in canine retraction in short period of time without gingival recession, root resorption, fenestration, and increased buccal bone plate thickness. Hello.
Hello, Dr. Mukesh.
Yes, sir.
Tell me about what is the rationale behind this corticotomy and microosteoperforation?
Yes, ma'am. Yes, sir. Sorry. Basically, what happens when at the corticotomy site, when you injured the tooth, when you injured the bone, then bone try to remodel itself, and there is a regional osteopenia. Hence, the opposite forces which is acted by the bone to compromise or to oppose the tooth movement is get decreased. At that time, the rapid tooth movement take place. There is increase in osteoclastic activity due to changes in interleukin 6 and 12 levels, and it lasts for the 4 to 6 months.
Okay,
that is
fine.
also known as.
What kind of anti-inflammatory drugs you have given after the your treatment, after surgery?
Ma'am, hello, sir. Sir, we have tried to less avoid we just try to give a paracetamol 650 as anti-inflammatory.
Why you have not given the non-steroidal anti-inflammatory drug or not given?
Ma'am, sir, actually this process is based on to the inflammatory process. Inflammatory drugs inhibit the regional accelerative phenomenon. Hence, the anti-inflammatory drugs are not given too much. If pain is severe, then for that particular to stop the pain for that particular duration you can give, but it is given.
Okay, fine. That's okay. Okay. Dr. Padmanath. Yes.
Okay, sir, should we proceed? Padmakant, sir, should we proceed? Okay. Sir, I'll ask to proceed with the next poster because the questions were similar which you would like to ask. So can you have the next poster, please? Yeah, could you start with the presentation?
Good afternoon, everyone. Today I'm presenting a case report on socket shield technique. Now, as we know, the dimension of the residual alveolar it changes following the extraction, which has a direct effect on the future implant placement and its emergent profile, especially in the interior regions. Many techniques were introduced to prevent the resorption of the alveolar wound caused by trauma during extraction and loss of periodontal ligament. A traumatic extraction, socket preservation, grafting, and immediate implant placement prevents alveolar resorptions and maintains the dimension by preventing the collapse of cortical plates. In 2010, Herzler et al. Introduced a new method, the socket shield technique, to avoid tissue alterations and bone resorption after tooth extraction, in which a partial root fragment was retained around an immediately placed implant. In the present case, a 50-year-old male patient presented in our outpatient department with a upper broken tooth due to trauma. It was earlier treated with the root canal treatment, and clinically it was grossly decayed, and the periodontium was healthy. Now, the treatment that we did is a socket shield with simultaneous placement of the implant. The tooth 2-1 was decoronated first, and the sectioning of the root was done, followed by extraction of the palatal portion. The buccal portion was trimmed, and only 2 mm of the shield was left behind, and the osteotomy was followed after that. And after the osteotomy, implant was placed, and post-operative medications and instructions were given to the patient. In this, there is no uneventful thing that happens, and no post-operative complications were seen. Now, the advantage of this is the buccal bone architecture of bone height was preserved, and the complication rates are low. Conclusion: case of immediate implant placement with socket shield technique shows successful preservation of post-extraction tissues and thin buccal bone with successful restoration of the implant. Thank you.
Dr. Fahim?
Yes, sir.
Who has given this socket shield technique? The
Pardon,
concept
sir?
of it. Who has given this concept of socket shield technique concept?
Sir, Herzler in 2010.
Okay, fine. What is the difference between this technique and the conventional techniques?
Sir, in conventional technique, the whole tooth is extracted, and in this, a buccal fragment of the tooth is left behind to maintain the buccal architecture.
And what is the rationale behind this?
So the rationale is to preserve the buccal bone architecture because to leave the buccal bone so that the to leave the fragment of the tooth so that the blood supply to the buccal bone is proper from both the sides, from the buccal side also and from the socket side also, and it enhances the aesthetic results overall.
Okay, fine.
You have a question in the chat box. Can you please read it and answer? Indications of this technique, and was the thickness fragment of tooth which should be left behind?
Ma'am, the thickness should be 1.5 to 2 mm, and indications are healthy, periodontally healthy tooth, non-mobile tooth, and which fracture tooth can also be done in this.
Okay, so should we proceed? Yeah. Can we go to the next slide, please?
Yes, you go. Surely go to the next slide.
Thank you. Thank you, sir.
Yeah. Dr. Rijwana, could you begin your presentation?
Yes, ma'am. Good afternoon, everyone. Today I'm going to present my poster presentation on periodontal regeneration of intrabony defect with novo collagen scaffold. To introduce, intrabony periodontal defect presents a clinical challenge in the treatment of periodontal diseases and maintenance of compromised teeth. So the case report, which aims to investigate the clinical and radiological effectiveness of Oxys Volumax membrane in the treatment of intrabony defect. Coming to the case report, a 38-year-old male patient reported to the department with a probing depth of 12 mm, and on clinical examination, the teeth is supraerupted as well as there is a gingival cleft present, and there is aberrant frenum attachment also is seen. As well as despite the depth of the intrabony defect, the tooth is vital. Then the next picture, which shows the pre-operative radiograph, which shows a horizontal bone loss, which is seen. Then followed by the surgical procedure. First, a intracircular incision is given. Then the full thickness flap is elevated. Root planing and degranulation is done, followed by placement of Oxys Volumax membrane. Then vestibuloplasty and suturing is done and pack is placed. So the post-operative radiograph, in which the periapical radiograph, which reveals there is a bone fill of the defect, and in clinical examination, there is reduction of probing depth as well as the teeth maintained its vitality. Thus, to conclude, the severe periodontal intrabony defect of single-rooted teeth can be treated using Oxys Volumax membrane with improvement of periodontal parameters and radiographic bone fill. Thank you.
Dr. Ranjana?
Yes, sir.
I think there's only localized defect in one region, right?
Yes, sir. There is a localized defect, sir.
What was the reason behind this defect?
Sir, because of the poor maintenance, sir, mainly. There was subgingival calculus was there, sir.
I think poor maintenance is everywhere will be there. But why it is localized to the one only, 2 teeth?
Sir, and there is a cleft, gingival Stillman cleft is present, sir. And there is aberrant frenum attachment also, sir.
Yes, that is why I asked you this question.
Yes, sir.
Have you taken care of this? There is a Stillman cleft. What was the reason behind this Stillman cleft, and what was your treatment planning before giving this regenerative procedure? Have you taken care of this high frenal attachment? And
yes, second, the Stillman cleft is caused because of the aberrant frenum attachment, sir. So because of that, the frenum was released, and then the barrier membrane was placed.
Okay,
so
fine.
the result was
what about the Stillman cleft? What was the reason behind the Stillman cleft? You have mentioned that Stillman cleft is there. What was the reason behind it?
Sir, basically the causes of Stillman cleft are because of TFO, sir, and because
check the frequentist test. Is it positive?
It was positive, sir, with respect to anterior teeth, sir.
You should tell that in your case also. That there's a positive trauma from occlusion was positive, and how you have managed that.
So coronoplasty was done, sir.
Yes, you have both things you have mentioned. You should have mentioned before giving this treatment. Otherwise, the success rate will be in question.
Okay, sir.
Okay, fine.
Thank you, sir.
Okay, no question from sir, but no answer. So can you go to the next slide?
You can go.
Okay, thank you, sir. Thank you. Can we have the next slide, please? Yeah.
Ma'am, good afternoon. Can I start, ma'am?
Yes, you can start.
Yeah. Good afternoon. The topic for my poster presentation today is bone morphogenic protein 2 and beta tricalcium phosphate in conjunction with NIPSA in the treatment of horizontal alveolar bone defects, a case report. Periodontal disease progression can be determined by the underlying osseous defects. Non-incised papillae surgical approach, shortly called NIPSA, is proposed by Rodriguez in the year 2018, which was mainly designed to maintain the integrity of interdental soft tissues covering the alveolar defects and to prevent the exposure of biomaterial due to the loss of papillary height and to minimize gingival recession. The basic principle is to provide access to the bony defect with a single horizontal or oblique incision in the buccal aspect as apical as possible in order and simultaneously maintain the integrity of marginal tissues. The aim of this case report was to clinically evaluate the efficacy of BMP2 and beta TCP in conjunction with NIPSA in the treatment of horizontal alveolar bone defects. Before surgical intervention, the patient was treated with scaling and a customized acrylic stent was prepared to fit the area of interest, and the probing depth and clinical attachment level were obtained using UNC15 probe. Further clinical parameters including plaque index, sulcular bleeding index, wound healing index, tip of the papilla, and the gingival recession were recorded. During the surgery, LA was administered and a single horizontal incision was given apical to the defect using a microsurgical blade. This was followed by the reflection of the flap apicocoronally till the crest of the defect was visualized. Then the defect debridement, degranulation and root planing was performed under copious saline irrigation, and this was followed by graft placement, which is a combination of BMP2 and beta TCP. Primary wound closure was obtained with the help of 40 non-resorbable silk suture, and the patients were recalled at 6 months and 9 months interval to evaluate the clinical and radiological changes. 9 months post-operatively, there was a significant improvement in the plaque index, bleeding index, and there was a significant, highly significant reduction in the probing depth, which was about 8 mm at baseline, and it improved to 3 mm during the 9-month post-operative period. The tip of the papilla remained the same, and radiographically, the alveolar crest level decreased from 7.24 millimeters to 6.38 mm. Also, bone fill, area of bone fill also increased during the 9-month post-operative period. Hereby, I conclude that NIPSA is a promisingly minimally invasive technique with consistent clinical results and with limited morbidity to the patient, both during and after the surgical procedure. Thank you.
Dr. Manu, you have given the incision in apical to the defect and raise the flap apicocoronally. My question arises here. One, how you have ensured the complete removal of the degranulated tissue, removal of the granulation tissue, and secondly, if you have given the graft, definitely the mass will increase. How you have ensured the primary closure?
Sir, by the wound healing index, we ensured the primary closure, sir.
Hey, primary closure means that both the cut margins, they meet.
Yes, sir. And there was no presence of fibrin line.
You have given the graft here.
Yes, sir.
Graft without reflecting it. Open debridement. Right? Sir? How, if you have given the graft here, place the graft, how you have ensured that there is a primary closure? Definitely the volume of the bone margin, bone particle will be increased. How you have ensured that there is a complete primary closure?
So there was no fibrin line in the interproximal area of the suture line.
Okay, fine. Have you checked the trauma from occlusion? The X-ray radiograph shows that there is a signs of trauma in relation.
Yes,
Have
sir.
you checked the Flipatus test? Perform the Flipatus test.
No, sir.
Okay, fine. That's
fine, sir. We'll proceed with the next.
Is it audible now?
Yes, you are audible.
Very good afternoon, sir. It's been a long since
Yes, sir.
you have been waiting to hear me.
Good to hear you, sir. So should we proceed or you have any questions for all?
No, we'll proceed with the next. We'll finish off.
Okay.
The same set of questions.
Can
So,
you have, yes. Can we have the next slide, please? Yeah, great. Can you begin with the presentation?
Okay, ma'am.
Dr. Khila? Yeah.
Good afternoon, ma'am. Today, the topic for my poster presentation is treatment of angular alveolar bone defects with interpapillar preservation technique using demineralized freeze-dried bone allograft and platelet-rich fibrin, a case report. The successful periodontal regeneration mainly depends upon the primary wound closure and acceptable wound stability. The surgical elevation of the interdental papilla access the angular alveolar bone defects, which impairs the papillary blood supply. Hence, the interpapillar preservation mainly helps in the preservation of the interdental papilla and enhances the regenerative potential and also prevents the interdental papillary recession. The main objective of this case report is to discuss the interpapillar preservation technique in the treatment of angular alveolar bone defects using demineralized freeze-dried bone allografts and platelet-rich fibrin. A 29-year-old female patient came to the Department of Periodontology with a chief complaint of foot lodgement in the upper left back tooth region. Upon clinical examination, a 12 mm periodontal probing pocket depth was recorded, and upon his radiographic examination, a deep alveolar angular bone defect was recorded in the region of 2.6. Hence, a interpapillar preservation technique was performed by giving an intracircular incision followed by vertical releasing incision, and the flap is elevated. Based upon the tunnel approach, the interdental area is relieved and root debridement was done, and DFDBA material was placed, and over that a PRF membrane was placed, which is extracted from the antecubital vein of the patient, and at a rate of 2800 rpm with 15 minutes a PRF membrane was extracted, and over the DFDBA material the PRF membrane was placed, and after 9 months there is a significant reduction in the probing pocket depth and the interdental papillar recession was not observed. And I hereby conclude that the interpapillar preservation technique provides mechanical access to the interproximal deep and wide intrabony defects, demonstrating uneventful postoperative healing.
so what was the etiology for this isolated intrabony defect?
Foot lodgement, sir.
Was there any trauma from occlusion?
No, sir.
Did you check?
Yes, sir. Fremetus test was negative.
Okay. What is sticky bone?
A combination of two graft materials, sir. Either DFDBA combined with PRF or.
Then what is sticky bone? There is another thing called sticky bone. Who has given it? Sir?
So, have you checked the vitality of the tooth?
No, sir.
Hmm?
No, sir.
Why? Why not? You have checked. The radiograph clearly shows that vitality has to be checked for the long-term prognosis of the tooth. In such cases, definitely the vitality has to be checked, and we have to go for the endodontic opinion also, along with the periodontal management. Okay, fine.
Thank you. Could we go to the next presentation?
Okay, fine. You can go. Proceed ahead.
Can we have the next slide, please? Janvi? Can we have the next slide? Yeah, thank you.
Good afternoon, everyone.
You
Can I start, ma'am?
Yes, yes.
The topic for my poster presentation is titled Endoperio Lesion Management Redefined with Autologous Stem Cell Assistance in Periodontal Regeneration Technique, a case report. Talking about the interaction between the pulpal and periodontal system, the both components are known to be interconnected by various anatomical and non-physiological pathways. These pathways are known to contribute towards the initiation and progression of endoperio lesion. And also, literature has depicted various treatment modalities for the management of this endoperio lesion. Talking about stem cell therapy, because the human tooth is known to be a potential reservoir for various subcategory of stem cells, these stem cells, in combination with their associated growth factors and scaffold, have known to establish the basis for the tissue engineering trial. Hence, considering these factors as a background, the aim for the present case report was to evaluate the utilization of autologous stem cell niche component from dental pulp stem cell and periodontal ligament tissue in the management of an endoperio lesion. The most common approach for management in terms of stem cell therapy is utilization of a ex vivo culture stem cell transplant. However, it is known to be associated with various disadvantages, such as the risk of genetic mutation, there is a risk of tumorigenic potential, and it is known to be very expensive. Hence, describing the case, it was a 28-year-old female patient who was diagnosed as a case of endoperio lesion. The figure 7 and 8 are demonstrating the clinical and radiographic photographs at baseline. It was designated to go ahead with the treatment plan of intentional endodontic treatment, followed by open flap debridement and regeneration using the PSI-PRT principle. Initially, incisions were placed and a mucoperiosteal flap was deflected, followed by which the stem cell niche transplant was prepared from an extracted third molar teeth from the same patient in combination with Abgel. And a stem cell niche transplant was prepared and transplanted into the surgical site, followed by which primary closure was achieved. And it was seen that in terms of the clinical and radiographic parameters at a 12-month follow-up period, successful improvement was noted. Hence, this basis of stem cell assisted regeneration technique formed by a combination of dental pulp stem cell, periodontal ligament stem cell niche, growth factors, and scaffold should be implemented in the management of endoperio lesion. To conclude, the clinical utility of novel PSI-PRT technique is indicated owing to its clinical feasibility, success, and cost effectiveness over other available techniques, because this forms the basis for a best of base source for dental pulp stem cell and periodontal ligament stem cell without any need for ex vivo culture. Thank you.
You said you had the main aim is to regenerate. So how did you check whether there is new attachment that is formed?
Sorry, sir.
How did you check for the new attachment? Any new periodontal ligament fibers were formed? How did you check? Did you?
So the clinical parameters were evaluated, sir, at a 12-month post-op period, which showed decline in the probing depth and also improvement in the cal levels.
So that cannot be the sole basis where you can say there is a new attachment. It could be a reattachment as well, right?
Yes, sir. So, but the radiographic evaluation was performed by MHJ software, which showed satisfactory radiographic bone fill and radiodensity, simulating a regenerative process there.
Okay. Sir, Gupta sir.
Tell me about how you have procured the stem cell from the extracted third molar.
So the procurement here is in terms of the niche and not individually the stem cell. We have procured the stem cell niche from the dental pulp component and the periodontal ligament tissue.
Now, how you have procured it?
Pulp extirpation was performed with the help of endodontic files. And in terms of the periodontal ligament tissue, which is adhered to the root surface, was scraped with the help of a curette. And this was combined with a scaffold. In this case, Abgel was utilized.
Okay, fine. As per your photograph, this one, there's I think there's a mobility issue will be there during healing. And complete healing cannot be ensured until you immobilize the tooth by some splinting devices.
There was
thing. If the tooth is movable in the socket,
there was no
will ensure the complete healing. How you have ensured the healing in such case? This is your photograph clearly shows that the tooth might will be having some grade 3 or grade 2 mobility. How you are?
However, clinically that was not the case, sir. At baseline, there was
your
no
radiograph
mobility
clearly shows that there's a severe bone loss.
So clinically, upon evaluation, there was no mobility. Also, an occlusal evaluation was performed, which did not show any signs of trauma from occlusion.
I am not asking you about the trauma from occlusion. I am asking you how you have ensured that the healing will be complete only when the tooth is stable in the arch. If it is movable, the healing will not be complete.
Yes, sir. We could have gone ahead with a.
You should have done the further splitting of that tooth.
Yes.
Stabilize the tooth in the socket.
Yes.
So that if it is the same thing, if that, okay, fine.
So was there any pathology in that egg which was extracted, or it was just because of this niche you wanted to take that you have extracted it?
Sir, it was a partially impacted third molar, and since the patient's chief complaint was a cheek bite, a chronic cheek bite, it was indicated for extraction.
So the contralateral was also extracted?
No, sir.
Then there could be an extrusion, right? Later on.
The contralateral tooth, sir, the same arch, the upper 8 was extracted, sir. Okay, but on a different visit.
Fine.
Okay, thank you. Could you go to the next presentation, please? Yeah, thank you.
Good afternoon, everybody. Today's case presentation is to compare the efficacy of local delivery of curcumin and ornidazole gel in chronic periodontitis patient case series. Localized antimicrobial therapy has aroused considerable interest because of the site-specific nature of periodontal infection. The higher concentration of antimicrobial agent subgingivally, lesser the side effect of systemic antibiotic use. So in case of 3 individual patients come to the department with chronic periodontitis having probing depth greater than 5 mm bilaterally were selected for the study. Split mouth design was prepared. Examination of plaque index, probing pocket depth and clinical attachment level was measured for each patient. In group A, we use curcumin gel, and in group B, we use ornidazole gel. In group A, the figure 1 showing the periodontal pocket depth, which was 5 to 6 mm. And in second, there is the application of curcumin gel. In third, after the 1 month, we can clinically there is the attachment probing pocket depth reduction, which was first at baseline it was 7 mm, so it is reduced to 5. In group B, we use ornidazole gel. In second quadrant, there is the probing depth of 6 mm. The second figure showing the applications of the ornidazole gel. And after the 1 month follow-up clinical photo, the probing pocket depth reduced to 4 mm. So the curcumin show anti-inflammatory effect by alternating inflammatory response of TNF alpha, stimulating human endothelial cells by interfering with NK body. It blocks the nuclear factor, that is kappa B activation. There is 3 types of curcumin, that is tetrahydrocurcumin, dexamethasone curcumin, and alpha-met hormone curcumin. So in tetramethasone curcumin, it acts as an antioxidant, anti-inflammatory, antimicrobial. Whereas the pH of this was variant, that is range from 8 to 8.5 mm. That exists in 3 equilibrium, that is H3A, H2A, and HA2. Where it acts as a 4,000 to 8,000 milligram per day, and the biodegradability is 12 to 18 hours. Whereas ornidazole gel, it acts as an antibiotic used to treat protozoal infections. It commercially obtained from acid carboxyl group. It acts as an antimicrobial spectrum that is similar to that of metronidazole. So of this, we result that after 1 month evolution, curcumin group show 9 to 10% reduction in pocket depth, plaque index, and clinical attachment loss when compared to ornidazole gel group. So we conclude that the results show more favorable outcome with curcumin than ornidazole gel. Thus, local delivery of curcumin can be used as an adjuvant to non-surgical periodontal therapy.
Can you stress on the mechanism of action of curcumin?
Sir, curcumin, it blocks the nuclear factor kappa B alpha, which inhibits the endothelial cells, and it degrades, stimulates the human endothelial cells. Sir.
Sir Gupta, sir.
Fine. Dr. Zubair,
Yes, sir.
you have assessed in terms of the inflammatory action of the curcumin.
Yes,
but
sir.
what about the, you have not in the, by evaluating the inflammatory response of any drug or any medicament, you have to record the bleeding on probe.
Yes, sir.
Bleeding, you have
Bleeding
not
on
recorded any bleeding index.
Sorry, sir.
Bleeding on probing is a sensitive indicator for the gingival inflammation.
Yes, sir.
Have you recorded
From bleeding on probing, we will conclude that how much infection is there.
Bleeding on, yeah.
The main significance of bleeding on probing is that we conclude that how much infection that the gingiva have.
Okay, fine. Okay.
Okay, thank you. Should we go to the next presentation, please?
Thank you.
Proceed.
Thank you. Dr. Sushmitha?
Yes, ma'am.
Yeah, could you start the
Can I start?
presentation?
Good morning, everyone. My case report is on efficacy of nano-silver membrane in the periodontal regeneration, a case report. Coming to the introduction, the periodontal regeneration necessitates the exclusion of the epithelial and the connective tissue cells of the gingiva from the wound site, which has led to the development and application of GTR membranes. However, bacterial contamination of the wound site and the GTR membranes has significantly compromised the desired outcomes. So compared to the conventional antibiotics, these silver nanoparticles can exert superior activity by better contact with the microorganisms, higher interaction with the bacterial membranes and DNA. So the inhibitory effects of this respiratory chain in the bacterial mitochondria and genesis of free radicals enhancing their bactericidal activity, which was given by Locke et al. In the 2005. So the aim of this present study was to evaluate the efficacy of the impregnated membranes in the periodontal regeneration. This is a case report where we have used a silver nanomembrane in the intrabony defects, where a 40-year-old female patient has come to the department with a chief complaint of food lodgement in between the 3.5 and 3.6. After initial therapy, the probing depths were 7 mm on the mesiobuccal surface and 12 mm on the mid-buccal surface of 3.6. Radiographically, bone loss was observed between 3.5, 3.6 and 3.7. After initial therapy, flap surgery was planned, where a clavicular incision was given on the distobuccal line angle of 3.4 to distal line angle of 3.7 on both buccal and the lingual surface sides. So full thickness mucoperiosteal flap was raised, followed by degranulation of the site. Before grafting, the site was where pre-suturing was done. Then the defect was filled with the hydroxyapatite graft and stabilized with the nano-silver membrane. Then the flaps were repositioned back and sutures were placed. These are the post-operative 3 months pictures. Coming to the conclusion, the incorporation of the silver nanoparticles may be effective in controlling the membrane-associated infection and also helpful in the periodontal regeneration of the intrabony defects. So, further studies are needed as with a large sample size for the evaluation and efficacy. Thank you.
Coming to the physical properties, did you see any variation from the other GTR membranes?
Sir, as it is dipped in the impregnated in the nanosilver membranes, the membrane will be somewhat thick, sir, than the GTR plain collagen membranes.
So you find it no, it will not collapse.
Yes, sir.
Okay. Any commercial name for this? Commercially available name? Okay. Sir Gupta, sir.
Dr. Sushmitha, you said
Yes,
that in the conclusion that silver incorporation of silver nanoparticles, they are effective in controlling the membrane associated infection. Can you justify the mechanism or the mechanism? Tell me the mechanism of this.
these silver ions interact with the sulfur containing proteins, sir, on the bacterial membrane, and with phosphorus containing compounds to inhibit their function, sir. And this silver can attack the respiratory chain in the bacterial mitochondria and lead to the cell death, sir.
One thing. Second is normal membrane. What do you mean by normal membrane?
Normal membrane is a plain collagen membrane, sir, which is
Plain collagen membrane. That is why sir also tell that the plain the collagen membrane it is cholesterol. Membrane should be rigid so that it provides a space for this undifferentiated cell to move here. That is why this is definitely better rather than how do you have. This is might be a reason for that. Okay, fine.
Nano is usually used to target specific bacteria, so could have included the bacterial culture. You could have assessed even that could have been done actually in us.
That is why she should have mentioned that bacterial culture before and after that.
Yeah, yes, sir. I think we can proceed with it.
Yeah, okay. Thank you. Can we go to the next presentation, please? Thank you.
Good afternoon, sir.
Yeah, you can begin with your presentation.
Okay. Good afternoon. My poster depicts a case report where my objective is to compare the efficacy of microsurgical and conventional coronally advanced flap procedure for localized gingival resistance. The case report is as follows. A 35-year-old male reported to the Department of Periodontics presenting with a chief complaint of sensitivity and anesthetic appearance in his upper anterior teeth. On clinical examination, it was found that there were Miller's class 1 gingival recession lesions in relation to 1-4 and 2-3 respectively. After routine oral prophylaxis, the patient is scheduled for the root coverage procedure appointment, and the treatment of choice was coronally advanced flap procedure. Why? Because the patient has adequate amount of attached gingiva along with thick gingival biota. Under local anesthesia, intracircular incisions were given along the buccal aspect of the involved tooth that are 1-4 and 2-3 respectively. But for the tooth 1-4, Bart Parker blade number 15 is used for the incisions, whereas for the tooth 2-3, microsurgical blade BW003 was used for the incision along with the use of compound loops. After incision, a split thickness flap was elevated, leaving the periosteum intact. The interdental papilla was deepalized and primary closure was achieved with 5-0 absorbable vitral suture. Then the patient was prescribed with systemic antibiotics, pain relieving medication, along with 0.12% of chlorhexidine mouth rinse according to their standardized regimens. After 10 days of surgical procedure, sutures were removed and the patient was instructed to continue his mechanical cleaning habit on the surgical site areas with a soft brush and rolling over technique. The follow-up appointments were fixed consecutively for 4 weeks, and later the follow-up appointments were given at 3 months and 6 months respectively. Here, during the first follow-up visit, the subjective perception like patient's discomfort and pain perception in the surgical area were recorded using visual analog scale, and higher score was assigned for the surgical area where I have used Bart Parker blade, and also early wound index was also recorded. And for the surgical site area where I have used microsurgical blade, the early wound index was 5, whereas for the surgical site where I have used Bart Parker blade number 15, the early wound index was 4. By this, I can conclude that both the procedures are effective and achieved 100% of root coverage, along with reduction in the sensitivity issue and meeting the patient's aesthetic concerns. However, the procedure which was done using compound loops and microsurgical blade might be clinically better in terms of less post-operative pain, better wound healing, and discomfort to the patient.
As per your photographs, Even in the microsurgical, this thing, I find the elevation and the suturing not proper up to, could have been much better. It's similar to the one which on the left side. Okay. So microsurgery, when you are employing it, should be conservative in approach, right? And what loops did you use?
Compound loops, sir.
Okay. Sir, Gupta, sir.
Tell me about what was the reason for these recessions?
Sir, the patient's brushing habits, sir. He gave an history of horizontal brushing techniques. And
have
also,
you that this brushing method? Have you demonstrated the brushing methods, correct brushing methods to the patients?
Yes, sir.
Which brushing method you have advised to the patients?
I have described him and told to rollover technique. I have.
These things should be taken care first, the etiological factors. Yes. Only then you should go for the surgical interventions. Right? About the treatment, okay, fine. What about the root prominence? Is there any root prominence?
No, sir. There is no root prominence in both the cases.
Okay, fine. That's.
Thank you. Can we go to the next slide, please?
Yes, sure.
Thank you.
Good afternoon, everyone. Yes, ma'am.
Yeah,
Good afternoon, everyone. My case report is on management of an angular defect with an alloplast. Now, the regeneration of lost periodontal tissue due to the disease is the ultimate objective for the periodontal therapy. The treatment includes the various techniques such as open flap debridement, GTR, and etc. with bone replacement graft, which are autografts, allografts, xenograft, and alloplast. One such alloplast is a porous hydroxyapatite beta tricalcium phosphate, which has been used and has shown great results, which has been clinically applied. Therefore, the aim of this was to evaluate clinical and radiographic changes using hydroxyapatite beta tricalcium phosphate as a regenerative material in treatment of an angular defect. A 47-year-old female patient reported with a chief complaint of bleeding gums while brushing. On examination, there was a periodontal pocket of 8 mm was seen, and clinical presentation included there was swollen gingiva with bleeding on probing. There was an angular defect which was confirmed clinically by probing, by transgingival probing, and it was confirmed radiographically also. The treatment included open flap debridement in the region 35236 with alloplast placement, and the patient was evaluated after 2 months. Results showed that the clinical presentation showed no signs of inflammation, and there was minor radiographic bone growth which was observed. Therefore, in conclusion, hydroxyapatite beta tricalcium phosphate is efficacious clinically and radiographically in the treatment of angular defects. However, in this case, a 6-month follow-up is required for assessment of the bone regeneration. Thank you.
Dr. Basant, actually nothing new in your study. And what was the reason to select alloplast? You could have gone for allograft as well.
Yes, sir.
Any particular reason that you stick to alloplast?
No particular reason, sir.
Sir?
Yes, in your radiograph, there's an angular. What is the reason for those this defect in one tooth only?
So the reason can be accumulation of plaque, calculus, food lodgement can be there.
That is always, if patient is not maintaining plaque oral hygiene, the plaque calculus will be all in all the entire dentition. But why it is localized to one tooth only? This bone loss, so much bone losses. Yeah.
So trauma from occlusion
How you have
can
checked
be
it?
a reason.
How you have
Yes.
checked it?
So Prometheus test is done. So we place the
test coming here. How you check the occlusal prematurities? This is the posterior teeth. How do you check the occlusal prematurities?
Sir, with the articulating paper, we ask the patient to bite, and if the points are coming,
I think one more thing is that there might be might be a food lodgement because of the open the loss of contact in the two teeth, 4, 5. In the radiography, there's a clear picture that there's a open loss of the contacts between the two teeth.
Yes, sir.
Okay, fine. That you should take care of these things also before giving any treatment, because if the etiology is there, your treatment will not be successful in any case.
Okay, sir.
Dr. Basant,
Yes, sir.
you said that there was a food lodgement. Was there a plunger cusp present?
Sorry, sir.
Was there a plunger cusp present? If yes, did you do anything intervention? Did any intervention you have regarding that?
So there was no intervention done regarding it, sir.
Okay, first of all, was it there or not?
So, I didn't check for the plunger cusp, sir.
I think we can move on.
Okay,
to the
thank
next.
you. Sure, sir. Thank you. Can we have the next slide, please? Yeah.
Ma'am, I'm audible?
Yes, you are. You can proceed.
Yes, ma'am. Good afternoon, respected judges, ma'am. Today, I'm going to present my poster on the topic, the single-step root coverage with modified bridge flap technique. Now, gingival recession is now coming to its introduction. Gingival recession is defined as exposure of the root surface due to displacement of the gingival margin apical to the cement enamel junction. Now, this is commonly encountered condition in clinical practice. To overcome the limitations of the original bridge flap technique, which demands adequate attached gingiva apical to recession, a modification of this technique was introduced to cover the denuded root surface with insufficient attached gingiva. Now, the aim was to assess a new modified bridge flap technique for the root coverage of unfavorable gingival phenotype. Now, in our this case series, 2 male patients aged 18 and 24 years reported with chief complaint of receding gums in the lower front tooth region. In patient 1 was having Miller's class 1 recession with 2 mm of gingival recession, and in case 2, the patient was having a recession of Miller's class 2 with 4 mm of gingival recession. Now, coming to the procedure, after achieving the adequate local anesthesia, an arc-shaped incision was made in the vestibule from 3T to 4-3 into the periosteum at its base. Now, after that, split thickness flap was elevated in the apicocoronal direction by making a sulcular incision connecting it with the first incision. So, and after that, the root conditioning was done with 24% EDTA. Now, in this case series, we used diode laser for achieving the chemostasis and also for the pocket elimination. Now, the flap was repositioned coronally with independent sling sutures. After the suturing, the periodontal dressing was given. Now, the results were favorable with no recurrence, recession reduction up to 79%, and clinical attachment gain was also seen, and patient had also reduced sensitivity. Now, the discussion. The bridge flap technique includes 2 surgical techniques simultaneously. In this technique, the flap which covers a denuded root surface, is supplied by a plasmatic circulation from capillaries in the adjacent portion of the gingiva, allowing it to survive. The flap creates a healthy, functional, and aesthetic results that appears to be resistant to further recurrence. The post-operative aesthetic results were satisfactory for the patient. The results of our case series were inconsistent with previous studies done by Romanos et al. And Margraf et al., who found 70% root coverage even after a follow-up period of 5 to 8 years. Now, to conclude, the present technique reported an excellent post-operative outcome showing great coverage of exposed root surface with vestibular deepening in single step and can be performed in areas with inadequate attached gingiva apical to recession defect. It also offers additional advantages like less surgical trauma, less less post-operative complications, and better patient satisfaction. Thank you.
Sir Gupta, sir.
So, what was the reason for this, and how you said that there's an additional advantage?
Yes, sir. Sir,
What do you mean by additional advantage?
sir, like additional mucogingival problems were also there, such as inadequate attached gingiva and the aberrant frenum. By using this technique, those concerns were also.
It does not increase the attached gingiva; it increases the vestibular depth.
Yes, sir, and
There are two
also
different terms.
yes, sir. Sorry, sir. The vestibular depth was vestibuloplasty was done in this procedure, sir. And the aberrant frenum was also there, so sir, frenectomy was also performed.
Thing is that it offers a increase in vestibular depth, but it has been seen that the muscle reattachment occurs again, right? How you have ensured that there's these additional advantages has been met for a pretty long time.
Sir, in this case, we have followed this case for 1 year, sir, post-operatively, and sir, no difference was there till 1 year. And
okay, fine, that's okay.
Okay, thank you. Can we go to the next slide, please?
Okay,
thank
sure.
you, sir. Thank you.
Thank you. Yeah, could you begin with your presentation, Dr. Sharma?
Yes, ma'am. Good afternoon, everybody. My topic for the case report is evaluation. Replacement of missing teeth is mainly for the aesthetics and the functions, and hence immediate are a better option for the replacement of missing teeth, because it helps in the maintenance of the osseointegration, better oral hygiene, and also there will be no need of an adjacent tooth preparation in case of an big prosthetic processes. The objective of my case report is to evaluate the effectiveness of the recombinant bone morphogenic protein, which is combined with a beta tricalcium phosphate in the healing of an immediate implant with a jumping distance greater than 2 mm. Although, even though the implants are placed, there is a incongruency space which is present around the implant and the surrounding bone. This distance is called as the jumping distance. Distance is less than 2 mm, then there is no additional requirement of any bone fill. But if this jumping distance is greater than 2 mm, then a bone fill is required, which should be a biocompatible membrane in a in the 3-dimension measure. In 2 cases have reported to our department. The first case, both the patients are male of 32 and 34 years, and the patient's chief complaint was an grossly decayed tooth. The atraumatic flapless extraction was done, and after that, osteogenic preparation was done with the drills, and the constituent drills were performed. And after that, around the implant periphery and the surrounding bone, the graft material which placed and the suturing was done. After the 3-month post-operative period, a gingival form or a healing collar was given, and final restoration was done after 6 months. In both the cases, the results have showed that radiographically 94.6% jumping distance fill was seen with no crest and bone loss was observed at 9-month period. Both the implants were stable and with an implant stability quotient value of greater than 75%. I hereby conclude that the use of recombinant bone morphogenic protein along with the beta tricalcium phosphate as a graft demonstrated a significant bone fill and a 100% success rate of an immediate implant with a jumping distance of greater than 2 mm. Thank you.
Questions, sir?
Sir. Shama, what was the reason for the extraction of the tooth? So, was it endodontically involved or?
No, sir, it was a grossly decayed tooth, sir.
So that is endodontically involved, right?
Sir.
Yeah. So only 2 cases have been done, or?
Sir?
Only 2 cases have been done?
Yes,
or
sir.
in your
Yes, sir.
department
Yes, sir.
there's a... Fine, sir.
2 cases have been done, sir.
Sir Gupta, sir.
You had said that you have given the restoration after 6 months, right?
Yes, sir.
And
yes, sir.
And the crestal bone, there is you have evaluated the result for only 9 months. That means for the after giving restorations, you have evaluated the
Yes, sir.
loss for next 3 months.
Yes, sir.
What is
Sir,
the... Yes, yes.
I have evaluated for 6 months and 9 month period, sir. It is compared with the baseline period, sir.
From the baseline to 9 months, right?
Yes, sir. Yes, sir.
What is the period for which the bone healing is complete?
The 3 to 6 months.
3 to 6 months. No?
Yes, sir.
And why you have evaluated for 9 months if it is completed by 3 to 6 months?
Radiographically, there should be a bone fill, no, sir. So I waited for 9 month period, sir.
Fine. Bone fill, complete bone healing means it's calcifications. It's ossification.
Yes. Okay, sir.
Okay, thank you. Can you go to the next presentation, please? Can we have the next slide, please? Yeah, doctor, can you begin with your presentation immediately?
Yes, good afternoon, the respected judges, whole team or there. Am I audible, ma'am?
Yes, you're audible. Continue.
Okay, I'm going to present my poster on the periodontal manifestations, a key for the diagnosis of systemic disease. As a periodontology is the amazing branch of dentistry which helps us to save what we can't in other branches, like we go for regeneration of the tooth which have poor prognosis. We go for regeneration for that, and it gives us immense pleasure when we use our branch for the diagnosis of the undiagnosed cases. So my poster is on the same topic. There's the periodontal manifestations. These patients came to our department with their chief complaint, like the gingival growth in some patients, like missing teeth in some patients, and with necrotic gingiva in other cases. And when we evaluated the patients, they were treated for the phased periodontal treatment, for the phased periodontal therapy. And we have done biopsy of these cases, and which came out to be true for the complex systemic diseases, which was like sarcoidosis, first case of sarcoidosis, and second case of ectodermal dysplasia, and third one Wilson's disease. He was a child of 7 to 8 years of age, with acute onset of mental retardation and all. And after diagnosed for the Wilson's disease, he was planned for further treatment. And also the fourth case with the acute myeloid leukemia of the patient, who suffered from acute necrotizing ulcerative periodontitis. Then these patients were treated. First patient, she was the biopsy was done for the same patient, and was sent for the respected physician for further consultation, and we did our part to our best. And second case in ectodermal dysplasia, these all patients are on our follow-up, and we are doing them the periodontal therapy time by time. As sarcoidosis, it's a granulomatous disease, mainly affecting the pulmonary hilar lymph adenopathy occurs in this case, and also involves in gingiva. It's a systemic granulomatous disease which involves the gingiva. Okay, the patient was having granulomatous enlargement of the anterior of the gingiva and the upper lip swelling. And when we sent for the biopsy, and it came out to be sarcoidosis. And we are doing our part, and physician is doing his part for the basic etiology of the disease. And the second case, ectodermal dysplasia, as these patients have don't have so much, they have abnormal tooth forms. So this patient is on follow-up. Third case, Wilson's disease. This patient is sent for the further treatment, and he's coming department for after every 3 months for the periodontal management.
Excuse me,
And
sorry, the time is over. Could we have the question answer session, please?
You have clubbed so many diseases here. Instead, you have discussed only one or two diseases. And the sarcoidosis, what is the histopathological of the sarcoidosis?
Sir, in histopathology of sarcoidosis, these as shown in the fifth picture of the first line, is this histopathological microscopic view?
No, you explain the histopathology of this. You have given the slide. But
yes,
you
sir.
have not discussed what is a characteristic feature of
So
this.
these patients have non-caseating granulomas.
And what is the differential diagnosis with other diseases?
So it can be it can be differential diagnosis can be leukemia. It can be
no,
like tuberculosis.
This picture is completely different from the leukemia. That is why
it can be tuberculosis. It can be tuberculoid.
You are not clear, very much clear in your. Dr. Padmanath, you please ask.
It can be Crohn's, also Crohn's disease, like Wagner's granulomatosis.
Dr. Padmakant, any question? Okay, then thank you. Should we go to the next presentation, please?
Thank you.
Next slide, please. Can you begin with the presentation?
Ma'am, shall I start? Am I audible?
Yes, you're audible. You can begin.
Okay. Good afternoon, everyone. Today I will be presenting my poster as a case report on the topic clinical and microbiological evaluation of oxygen releasing gel as an adjunct to mechanotherapy in chronic periodontitis patient, a case report. A patient was reported to our department complaining about food lodgement and bleeding from gums. On oral examination, we saw that gingival bleeding on probing was seen with 4 to 5 mm of clinically evident pocket depth on both the sides. Parameters were recorded were periodontal pocket depth, cal, gingival index, and plaque index. In the first visit, what we did was these subgingival plaque samples were collected and sent for microbiological analysis. Both the microbiological analysis involved the bacterial culture involving the analysis of P. gingivalis for the colony test and the PCR for the confirmation of the P. gingivalis. Then on the one side, only scaling and root planning was done, and on the other side, local drug delivery with the oxygen releasing gel along with scaling and root planning was done, and the patient was recalled after 1 and 3 months for the follow-up. As we can see, culture showed pure reduction in the P. gingivalis colonies where we used oxygen releasing gel as compared to where only scaling was done, and also significant reduction of the periodontal pocket depth was also visible. So as we say, golden weapons of diagnostic wars, culture and PCR, which are very important. And for the oxygen releasing gel that we use as an adjunct to the surgical therapy, we say inject with ease, stop the progression of disease. Thank you.
You said that, is there any commercially available such local
yes,
gel?
sir. I use this Blue M gel for my case report.
Is it commercially available?
Yes, sir.
What is the name of that?
Blue M gel.
Okay, fine. But in the photograph post-operative,
Yes.
You have not performed any local debridement. It appears in your photographs.
No, sir. Again, the plaque accumulation was very much there because the patient did not maintain the oral hygiene very properly.
And then your entire procedure is a failure, I think so. If patient is not maintaining, the period treatment will be a failure. Whatever you perform, it is a failure. Okay,
Can you
fine.
stress on this? Can you stress on this mechanism of action of this gel?
Sir, in this mechanism of action, it was to deliver active oxygen, which was delivered in a controlled manner at the treatment site, which helps prevent inflammation, and also oxygen prevents the growth of the anaerobic bacteria, that P. gingivalis, what we detected in our bacterial culture.
So what's the difference between controlled release and a sustained release?
Yes, sir.
Controlled release and a sustained release. Is it the same or different?
So you are not audible.
Controlled release and sustained release. Is it the same or different?
So the voice is breaking.
Sir is asking whether it is controlled release or sustained release. The difference.
So it is a controlled release. Controlled release.
Difference.
So the first who was to show this was Dr. Max Goodson in 1979, who first showed this controlled delivery of the local drug delivery agent.
Okay. Thank you. Could we go to the next slide, please? Yeah. Could we start your presentation?
Good afternoon, everyone. Today, my case report poster presentation topic is platelet-rich fibrin, a boon for the pink aesthetic. A facial and dental aesthetic play an important role in a facial and dental aesthetic play important role in the person's life for the upliftment of confidence and moral. The periodontal aesthetic has been considered to a major role in the overall aesthetic. It's determined not only by the shape and color of the tooth, but also include the shape and dimension of the gingiva. The aesthetic problem affecting the gingiva include gingival recession, gingival overgrowth, and gingival hyperpigmentation. My case report is the treatment of gingival hyperpigmentation with the PRF membrane, platelet-rich fibrin membrane. The depigmentation procedure is carried out by the help of surgical scalpel with the help of blade number 15. The exposed connective tissue is sutured with the PRF membrane. PRF membrane is made up by the Chakron protocol, 3000 RPM for 10 minutes. The surgical site is covered with the periodontal dressing, and the follow-up is taken for after 1 month and 3 months and 6 months. Here the photograph of the 3-month follow-up, which show the excellent healing and increase the gingival thickness. To conclude, the PRF increase the time of reoccurrence of the melanin pigmentation and increase the gingival health also. Thank you, sir.
Was there any increase in the formation of epithelium? Did it accelerate formation of epithelium?
Sorry, sir, I cannot hear you properly.
The epithelial formation, did it accelerate? The use of PRF, did it?
So your voice is. Hello, sir.
Gupta sir, can you ask then?
You gave a statement that PRF gives excellent result in recurrence, in preventing recurrence. Can you justify this statement? Your statement.
PRF has a enumeration of fibrin structure and a lot of growth factor like the endothelial growth factor, vascular endothelial growth factor, tumor necro factor, which enhance the healing and which increase.
You said that it prevents the recurrence of the
yes, sir. Yes, sir.
This is a very big statement. In all the conditions, there is a recurrence sooner or later. But you have given a very good statement that you have to justify this. So what is the mechanism of healing following this procedure?
It's a healing is a secondary intention by the secondary intention.
How reepithelialization occurs? Okay, fine.
Occur in the three phases: the activation of the melanin, synthesis of melanin, and the expression of the melanin.
Okay, fine. Thank you.
Thank you,
Dr.
sir.
Padmakant has asked, did the PRF accelerate the epithelialization?
Yes, sir. Yes, sir. PRF accelerates the epithelialization. Hello.
How did you assess?
Ma'am, you're not audible.
Sir is asking, how did you assess it?
Visual analog scale, by using the visual analog scale and healing index the Dermate index, we can analyze the healing after the procedure.
Okay, can we go to the next presentation? Yeah. Thank you.
Thank you.
Can I have the next slide, please? Janani, Dr. Janani, you can start your presentation.
A pleasant good afternoon to everybody gathered here. So I am here to present on the topic minimally invasive implant placement using socket preservation, which is basically a case report. Moving on to introduction, osseous abnormalities such as bony defects, fenestration, dehiscence could arise from a traumatic extraction, making the future implant placement or the prosthesis much difficult. Thus, socket preservation, which is a localized ridge preservation technique, has further advantages to overcome the disadvantages of crestal bone loss. Conventional implant approach has various disadvantages that include longer surgical time, traumatic soft tissue inflammation at the site of implant placement, and it offers a compromised mucosal effect around the implants, thus offering a compromised aesthetic result. Hence, clinicians are in constant search for an alternative technique to overcome these advantages. Minimally invasive implant approach offers an excellent technique for aesthetic and mucosal effects with shorter surgical duration. One such technique is the flapless soft tissue punch technique, which is currently described in the case report. Moving on to the clinical presentation, a 45-year-old female reported to the Department of Periodontics with a chief complaint of Rossi decade 1-3. On clinical history examination, the patient was found to be systemically healthy. On clinical examination, 1-3 was found to have hopeless prognosis, and hence it was advised for extraction process. Following a traumatic extraction of 1-3 teeth, a socket preservation technique was planned using a bovine xenograft material along with the placement of APRF membrane to achieve adequate bone height and width. Following this, a CBCT image was procured and then placement of an implant with a dimension of 4.2 into 10 was placed after 3 months of socket preservation technique. So, during the placement of implant, a 3 mm soft tissue punch was placed, which was followed by the preparation of the osteotomy site, which was basically done initially with a round burr and a 2 mm twist drill with copious saline irrigation. followed by which subsequent drills of different height and width were placed to achieve parallelism, and implant placement was completed with the immediate post-operative radiograph, which is basically depicted in the poster. The post-operative instructions and antibiotics were given to the patient, and patient was reviewed at a time period of 1 week, 2 weeks, 4 weeks, and 4 months post-operatively. The healing was found to be uneventful, hence the final processes was given at 4 months. Thus, to conclude, a flapless soft tissue punch technique is an innovative, minimally invasive method for the management of edentulous ridge with sufficient bone height and width, and the height of the keratinized gingiva could be attributed with higher patient compliance. Thank you.
This you have said that atraumatic extraction. How you have ensured atraumatic?
So atraumatic extraction could be attributed by the use of periotome, sir. But in this technique, since it was a periodontally compromised teeth, the teeth was actually mobile, sir. So through those techniques, we achieved an atraumatic extraction. Sir?
So we can't hear you.
In the socket preservation, which type of bone graft you have used?
In this current case report, we have used an bovine bone graft material, sir, which was basically mixed with an APRF membrane, after which the material was placed into the socket and the figure of 8 suture was placed.
Figure of 8 suture was given.
Yes, sir.
Why you have given figure of 8? There is certain disadvantages with the figure of 8 suturing. What are those disadvantages?
I'm not sure of the disadvantages, sir. We have given figure of 8 here because to achieve a complete closure of the
Complete
socket,
closure
sir,
cannot be possible with the figure of 8. It is possible with the direct loop sutures. Because in figure of 8, the two sutures come between the suture thread come in between the two flap margins.
Okay. Okay.
Dr. Padmakant sir has asked you the full form of APRF.
APRF is the advanced platelet-rich fibrin, ma'am.
Okay, should we proceed to the next slide?
Yes.
Yeah. Yeah, this is the last presentation.
Good afternoon, everyone here. I'm going to present my poster on split, rescue, and restore, a conservative approach to save a tooth. So vertical root fractures, these are commonly associated with unrestored endodontically treated teeth. It is often difficult to diagnose, especially when it is also associated with periodontal involvement. And in literature, we see that these vertical root fractures, these are the third most common reason for the extraction of endodontically treated teeth. And preserving these fractured tooth, they help in improving the function, the aesthetics, maintain the arch integrity, and also preserve the alveolar bone height. And one such surgical procedure is the bicuspidization. It's a procedure which is performed on the mandibular molars for the partition of the mesial and distal roots with their individual crowns. Coming to the present case, a 39-year-old female patient had been referred to us from the Department of Endodontics with an incomplete vertical fracture involving the left mandibular first molar. On clinical examination, we noticed that there was a swelling involving the marginal gingiva, and the patient also complained of spontaneous mild pain. And on radiographic examination, we could see a radiolucent line, and there was also a radiolucency involving the interradicular area. So we decided to go ahead with the surgical exposure and then go ahead with the bicuspidization. So what we did was a full thickness flap was elevated from 3.5 to 3.7 region. And then after the site was surgically exposed, we could see the fracture line. And then the tooth was split into 2 halves following the line of the fracture. And the flap was sutured back, and the 2 newly created bicuspids, they were left alone on the day of the procedure. Later, they received temporary crowns, and after 2 months, they received their permanent crowns. At the end of 2 months, these newly created bicuspids, they were healthy, and there was no bone loss. To conclude, this bicuspidization, this comes as a successful alternative in cases of vertical fractures where the tooth is periodontally healthy. Thank you.
So questions, please. Gupta sir, questions?
Yes. What is the reason for fracture, vertical fracture?
So basically, the patient had not received the prosthesis, sir. After her endodontic treatment was done, she had failed to receive the prosthesis, sir. So we are thinking, because there was already excessive tooth structure that was removed during the endodontic therapy, it might have weakened, and when there was a heavy occlusal load, this might have resulted in a fracture, sir.
Okay, fine. What can be the disadvantages with these procedures? Every procedure has advantages and disadvantages. What are the disadvantages with these procedures?
So long term, this might
Long-term disadvantages.
Yes, sir. So it might cause periodontal problems, sir. There might be bone loss if occlusal harmony is not maintained. And if the roots are too close together, sir, like in cases of fused roots, then proper oral hygiene maintenance will become a problem, sir.
Yes, there's certain indication also in cases of the bicuspidization.
Yes, sir.
One is a root proximity.
Yes, sir.
That is other this things that you should consider while performing the bicuspidization.
Yes, sir.
But other factors you should consider.
There has to be sufficient separation of the
Beside
roots, sir.
divergence.
There also has to be adequate bone support on the mesial and distal roots, sir.
On further more. Okay, fine. That's okay.
So Padmakant, any question?
No, no questions.
Okay, thank you. Then we are at the end of the session. I would like to thank Dr. Gupta and Dr. Padmakant. And sir has shared the email addresses. Could you please forward evaluated sheets to those?
Okay.
Thank you all the participants. Thank you everyone.
Thank you.
Yeah, thank you.
Thank you, sir.
14 నాకు 1490 వచ్చింది.
And he's gone 2 years.
Almost 1500. What is for 1200? My seniors got for 800. Mitali ma'am. Got for 800. నువ్వు మళ్ళీ చెప్పిస్తున్నావు ఏమన్నా? ఇక్కడ you are ordering just tell me no name clinics consultations
Good afternoon. Good afternoon and a very warm and hearty decades on behalf of 45th ISP National Conference. So this session will be from the category Case Report Session 10. For the session, I would like to welcome two eminent judges, Dr. Mejo Ambuken. Sir is currently the professor and head of Department of Periodontics and PG Guide at Mar Basilisius Dental College, Kodamangalam. Sir has a number of publications to his credit in various national and international journals and is a PG examiner for various universities in India. Sir was a past president of Cochin Periodontic Society and is an active member of Indian Society of Periodontology, Indian Society of Prosthodontics, Restorative Periodontics, Society of Periodontics and Implantologists of India. Sir has been into practice for more than 2 decades with special focus on interdisciplinary periodontics. Next judge for the day, we have Dr. Deepa Dhruva Kumar. Good afternoon, ma'am. Ma'am is a professor and head of Department of Periodontology at Tirthangar Mahavir Dental College and Research Center, UP. Ma'am has around 107 scientific publications in national and international journals, including 5 ebooks. She has guided more than 23 research projects and has been the guest speaker at various national and international platforms. Ma'am is a DCI inspector for dental institutions in India since 2016. Ma'am has also authored and edited the Handbook of Bone Regeneration, which is published in July 2019. She was an organizing committee member for 2nd World Conference on Dental Research, Kuala Lumpur, Malaysia in the year 2016. It is our pleasure to have you both here as a judge for the session. Deepa ma'am, Dr. Meju sir will be joining a little late for the session. So shall we proceed with the session?
Okay. First of all, thank you very much for your kind introduction. And it's been a pleasure to be part of this wonderfully organized 45 ISP conference. Okay, without wasting much time, let us start with the session. Yes, sir can join in between. Okay.
Thank you, ma'am. Thank you, ma'am. So participants, kindly note, you will be given 5 minutes of time, where 3 minutes will be for the presentation, 2 minutes for the question and answer session. So kindly please do stick to the time frame. So the first poster is will be by Dr. Sonal. So we can proceed. Can we have the next first poster, please?
Number 204.
Yes, CRPO 204. Dr. Sonal, you can start with the presentation.
Yes, ma'am. Good afternoon, ma'am. Good afternoon, everyone. I'll be presenting a case series, which is basically comparing frenectomy with vestibuloplasty, a case series comparing diode laser and scalpel. So a brief introduction. The term mucogingival surgery was introduced by Friedman to describe surgical procedures for correction of relationship between gingiva and oral mucous membrane with reference to 3 specific areas, that is the attached gingiva, the shallow vestibule, and the frenum interfering with the marginal gingiva. So coming to the first case report, a 20-year-old female patient reported to the Department of Periodontology with a chief complaint of spacing between her maxillary anterior teeth with high frenum attachment in her maxillary and her mandibular arch. So this is a picture of maxillary high frenum attachment, mandibular high frenum attachment, and shallow with a shallow vestibule. So we went after an LA application, a diode laser application was done with the wavelength of 980 nanometers. It was used for soft tissue incision. After this was her post laser assisted frenectomy. This is post laser assisted frenectomy with vestibuloplasty. Her healing index and visual analog scale for both the patients were compared, and this is a post-op photos after 7 days when she came to the clinic. The second case is also of a high frenum attachment with shallow vestibule. This was a 34-year-old female patient. She came with the chief complaint of recession in a lower anterior teeth with a shallow vestibular depth. So this is a pre-operative view with the mandibular high frenum attachment and a vestibule was short. So we planned a frenectomy with the vestibuloplasty. It was done with incision. It was done with the conventional scalpel method. Fibers were broken, sutures were placed, periodontal pack was placed after the scalpel surgery. This was the post-operative view. So the result of both the cases, the case report demonstrated that both the surgical blade and diode laser, they showed significant results. Obviously laser, it resulted in better wound healing. Patient satisfaction rate was also better. There was no bleeding.
we compared the visual analog scale both for the pain analog scale with the scalpel and laser. With the laser, it was much better. Patients' pain was also decreased. There was decreased post-operative pain. There was minimum swelling and scarring as compared with scalpel, and patients' acceptance was also better. So the conclusion was that though both techniques are useful for increasing the vestibular depth and for treatment for abnormal frenum attachment, we can always plan a lasers in cases where surgery is contraindicated or where patients have some systemic problems where there can be a blood loss can be a concern to the patient. Thank you.
Okay, just two questions.
Yes, ma'am.
What are the benefits of using laser? Can you just in a nutshell tell us?
Yes, ma'am. First of all, ma'am, laser, there is a bloodless, there is a greater precision, there is relatively bloodless surgical field. Ma'am, there is minimum swelling and scar formation is less because there is protein coagulation that occurs. Laser healing occurs by protein coagulation. Therefore, ma'am, patient post-operative pain gets reduced. That fear of suturing that is there with the conventional scalpel, that is also reduced.
Okay. Yeah, we can proceed to the next.
Can we have the next poster, please? CRPO 205, Dr. Vinita. Can we have the next poster, please? Janvi ma'am, can we have the next poster, please?
Yeah, if next presenter is not ready, we can go to the next one. One.
Yeah, ma'am.
Dr. Vinita, you can proceed.
Yeah, okay. Good afternoon, ma'am, and good afternoon, sir, and good afternoon to all the participants here. My case report is actually not a single case report. It's a series of 3 cases where we are talking about root coverage using subepithelial connective tissue graft. As we all know, gingival recession is a very, very common finding among our patients, whether it could be related to gingival recession or some iatrogenic reasons. Now, there are many treatment modalities available like double papilla flap, laterally positioned flap, coronal advanced flap, 3 gingival grafts. And among this, the gold standard could be considered as a subepithelial connective tissue graft. Basically, because it is high predictability for root coverage because of its superior aesthetics and also the good blood supply which it gets from the surrounding papillary areas as well as the coronal advanced flap, which is normally done along with this procedure. Now, as we can see, there are 3 case reports. First one is a 29-year-old male patient who complained of sensitivity in the anterior front tooth. The second is 23-year-old patient which also complains of the sensitivity in the upper anterior region. And the third is a 24-year-old male patient who had sensitivity post ortho because of the placement of an implant. So in all the three cases, we took a subepithelial connective tissue graft from the palatal areas as is seen in the second column of treatment plan. And the cases were all treated by harvesting this connective tissue graft. In the canine area, we used an envelope flap to cover the area along with the connective tissue, and the lower anterior we used a pouch and tunnel technique. And in the area where there was a recession due to implant placement, improper implant placement, we used also a pouch and tunnel technique to place the connective tissue graft. And as we can see in the third column, that is the post-treatment. Post-treatment is only for 10 days with respect to lower anteriors. Patient with the upper canine did not come back for a post-operative picture. But in the anterior canine areas, we have a 6-month follow-up, which almost shows almost 100% recovery. Connective tissue is, like I said, it's one of the most predictive methods to session. Am I audible?
Yes, doctor, you can proceed.
Yeah. So it also helps in increasing the width of keratinized gingiva, and the most common advantage is because since we're using it with envelope flap and other pouch and tunnel techniques, very good blood supply and aesthetics is there with this type of procedure. So considering the flap design, both envelope and modified tunnel technique both have given good root coverage and a good outcome for the surgical procedure. Thank you.
Can you just tell us what are the biological advantages of connective tissue graft?
And first and foremost is the color nudging of the tissue. And other than that, a good blood supply, because always a connective tissue is placed either with a pouch or an envelope technique. So good blood supply is available to that area. So healing is much better and better aesthetics. That's the most major advantage as compared to the free gingival graft.
Okay, how do you compensate for the shrinkage?
Some amount of creeping attachment would be there, ma'am. Normally, class 1 and class 2 recessions, you can almost achieve more than 90% root coverage, sometimes even 100%. So if it is more advanced type of recession, class 3, class 4, we may not achieve 100% root coverage in such cases.
Okay. So from my side, it's done. Can we go to the next?
Can we have the next poster? CRPO-206. You can proceed. Aina, CRPO-206. Are you there? I think we'll go to the next poster, which is CRPO-207, Dr. Susan. CRPO-207, Dr. Susan. Yeah. Dr. Susan, are you there? Dr. Susan? We'll go to the next poster. CRPO-208, Dr. Naveen. CRPO-208, Dr. Naveen.
Good afternoon, ma'am. Am I audible?
Yes, you are audible. You can
at the outset, I must thank the organizing committee for providing me an opportunity to present my poster titled Primary Closure in Socket Preservation, Exploring the Possibility. Now, as we know that implant dentistry has evolved over a period of time from surgically driven to the present day aesthetic driven concepts. And the soft tissue, it plays a very important role in maintaining the aesthetics. This soft tissue is position of soft tissue is dictated by the hard tissue. Now, in sync with the theme of this conference, the surgical periodontitis refined, this poster presents 4 cases wherein aim to achieve the primary closure after socket preservation or immediate implantment procedure was done. These 4 cases depict 2 different types of pedicle closure. One, a free mucosal graft, and one a local flap management technique. So the case one is a pedicle flap, pedicle palatal flap, wherein the socket preservation procedure in respect of 1-3 was done, which was an Elian's class 2C, and a pedicle palatal flap was rotated from anterior to posterior direction for an anterior aesthetic site closure. Post atraumatic extraction of 1-3 and using a periotome and the socket preservation. Now, as we know, this flap is based upon random vascular pattern blood supply, which maintain its own blood supply, facilitating a fast revascularization. And this post-op image shows uneventful healing of the complete soft tissue and complete soft tissue regeneration of the site. Second case is a vascular interpositional connective tissue flap, wherein the socket preservation procedure in 1-5, which was an Elian's class 1 in defect, after atraumatic extraction, a Lewis class 1 was incision, 1A incision was made in the palate, and pedicle connective tissue flap was elevated and rotated underneath the palatal margin and gingiva at the socket preservation site. Now, this pedicle connective tissue also maintains its own blood supply based upon the random vascular pattern, and hence the name vascular interpositional connective tissue flap. Now, the post-op image shows complete soft tissue closure of the bone regeneration site in respect of 1-5. Now, the case 3 is a case of fractured 1-1, which was an Elian's class 2B with a lack of label plate. Now, the post-socket preservation, a free mucosal graft was harvested from the palate, which was of the size slightly larger than the socket orifice, and it was secured with 2 horizontal sutures which going through and through the graft. Now, the primary closure in this case was achieved at the recipient site, and hemostasis at the donor site was achieved. Now, the graft has healed uneventfully and completely revascularized within a period of 4 weeks, as can be appreciated in the clinical pictures. Now, the case 4 is a buccal flap with a vertical release, wherein it was a 3-6 fractured clinical crown with the Elian's 3-6 Elian's class 1 case. Post extraction was performed following atraumatic extraction of the root stems, and an immediate implantment placement was done in respect of 3-6. Socket preservation was done for both mesial as well as distal sockets. Now, the primary closure in this case was achieved by mobilizing the buccal flap locally with 2 vertical incisions, as can be evident in the clinical pictures. Now, within a period of 2 weeks, as we can see, there is a complete soft tissue healing. All these 4 cases, they represent 4 basic biological principles of bone regeneration. There's the past principle which was introduced by Wang and Bayapati in 2006.
Sorry, doctor, your time is up. So
the importance of the primary closure and socket preservation procedure is for successful bone regeneration has been highlighted. Thank you.
Good collection of cases and good attempt to explore this new possibility. You were explaining about the past principle, that is PASS. Could you just elaborate that?
The P is for primary closure, A is for angiogenesis, S is for stability of the wound, and S is for the space maintenance, and the last S is for the wound stability of the blood clot.
Good. Can we go ahead with the next one?
Can we have the next poster, CRPO 209, Dr. Vaibhav?
Am I audible, ma'am?
Yes, you can proceed.
Okay. Good afternoon, respected judges. The title for my poster presentation today is Immediate Extraction Socket Grafting with an Indigenous Chairside Dentin Autograft, a case report. Coming to the introduction, tooth extraction remains as one of the most commonly undertaken procedures in dentistry till this date. Ridge resorption, being an unavoidable consequence of exodontia, can impair phonetics, aesthetics, and function as well. Freshly extracted teeth can then be utilized for immediate grafting procedures in order to avoid the obvious pitfalls of the current gold standard of autogenous bone. The objective of the current case report was to demonstrate an immediate autogenous socket grafting procedure utilizing an indigenously developed chairside dentin autograft workflow. The first diagram, the first color plate, shows an indigenously developed dentin grinder, which we developed at our department. The second shows in-house reagent preparation, which we again fabricated and did in our department itself. The next photo shows a preoperative view of a hopeless prognosis 4-6, which was subsequently extracted, as is visible in the next picture. These were subjected to a dentin grinding stage and a sorting stage, which we did in our developed grinder, and then subjected the product to our in-house reagent preparation. The first one of which was a basic alcohol cleanser for the dentinal defatting and removal of organic and bacterial toxin stage. The next step was to subject them to a PBS wash for 2 minutes. The first step was for 5 minutes, the second was for 2 minutes, and the third was 10% EDTA solution subjection for another 2 minutes. So the final product was an autogenous tooth graft, as is evident, and the intraop picture shows the immediate placement of this graft along with socket closure, and we can see the preoperative radiograph and the intra and immediate post-op radiographs. The results were that the graft site exhibited no post-op sequelae of concern and exhibited satisfactory radiographic appearance of the graft material at 1 week and 3 weeks post-operatively. The patient is also currently undergoing further follow-up and is planned for another similar procedure in the maxillary arch. So the tooth extraction, coming to discussion, is followed by changes in the internal anatomy of the socket, which entails bone fill and alterations in the dimensions of the socket walls. The most significant changes occur during the first 1 year of extraction to the tune of 50% loss of the alveolar ridge, 2/3 of which occur generally within the first 3 months of the extraction itself. Ridge preservation is indicated for early implant placement and other rehabilitative paradigms. The current case report evidences the reutilization of an indigenously produced dentin grinder along with an in-house reagent preparation to simplify the process of autogenous grafting at the chair site to eventually accomplish ridge preservation in a predictable manner. Concluding, the immediate grafting of an extraction site, the dentin autograft utilizing an indigenously developed chair site methodology, exhibits a predictably favorable alveolar ridge preservation in the early healing period of the extraction socket. Thank you. Thank you, sir.
During the course of preparation of this new thing, could you elaborate about what are the drawbacks you have encountered, or you can say the limitations?
Ma'am, when we did a review of literature, we found that there are a number of similar devices which are available in the market by the name of Vacuosonic, one device by Cometa Biomed, and another device called Tooth Transformer. And first drawback we found in the currently available devices was firstly the cost. They range from ranging from 1,200 euros to 20,000 euros. We developed an indigenously developed product. Another problem with the current devices, ma'am, is that the containers for the grinder and the sorters, they are single use, and we need to buy them again and again from the company. Also, the reagents have to be bought from the company itself. Here, our developed device has autoclavable containers, so that further reduces the cost and the sustainability of the workflow. And with the reagent preparation which we have followed, we have done this ourselves in our department itself in the dental college without any kind of input from other departments. So this we have shown an at cost demonstrable workflow which can be done economically and can be reproduced within a particular time frame at the chair side itself. And speaking of time frame, ma'am, we accomplished this entire procedure within a span of 15 to 20 minutes. So this can now be translated into a more practical kind of way, wherein we can foresee in the future every dental clinic could have something of this sort.
Yes. Yes. Thank you.
Thank you. Thank you, sir.
The next poster, CRPO-210, Mrinalini.
Good morning, ma'am. The topic for my poster is a case report which shows enhancing gingival dimensions with the alternate gingival grafting technique. The introduction is the importance of keratinized tissue around teeth has long been debated, although even the complete absence of attached gingiva is compatible with oral health. Certain clinical situations require definitive gingival augmentations. The case report is a patient with Miller class 3 Miller class 3 gingival resection reported to our OPD with a narrow keratinized width in mandibular anterior region. The chief complaint of the patient was the difficulty in brushing and the receding gums. The treatment plan which we have planned was we will augment the width of attached gingiva with donor side being the maxillary buccal marginal gingiva. On examination, the tension test was positive and the attached gingiva width was found to be 0. The management we done was firstly the phase 1 therapy sessions, then oral hygiene instructions were given, and then the surgical procedure. In surgical procedure, the recipient bed was formed with the horizontal incision by the 15-number blade apical to the available keratinized tissue. The scraping of the muscle and the loose connective tissue fibers was done. Then the donor side is the bleeding points marked with the pocket marker. The tissue measuring 3 mm into 8 mm was taken apical to the marking. And then the graft harvested in the sutured and then the covered with the periodontal pack. The post-op outcomes was after 3-month follow-up, the graft blended well. The gingival width was increased without any thick or patchy whitish appearance and also improved the oral hygiene. Gingiva at donor side regained its normal form and contour. On discussion, the advantages of this is no tire patch appearance in the mandibular anterior region, good color match, less post-op discomfort at both sides, and less post-op complications. The indications are the narrow keratinized field, local plaque deposition, shallow palatal wall, anipalatal abnormality. The limitations of this procedure are the limited availability of harvestable tissue at the buccal site and the tissue biotype. If it is thin, it will be complicated. Conclusion: the buccal gingiva may provide a useful substitute to other donor tissues to augment gingiva. As you can see the pictures, the first two pictures are showing the radiograph and the clear picture of the gingival recession, class 3 Miller recession, and the third picture is the donor site, which we have selected, and the fourth picture is the incision. Fifth is the donor site incision. The sixth is the harvesting of the graft, and the eighth picture is the suturing. The ninth and 10th picture are the blending of the graft, and 10th picture is of the donor site, which is healed and regained its normal form and contour. Thank you.
Can you just emphasize on the alternate use?
Sorry, ma'am.
You have used the word alternate gingival grafting.
Hanji.
So, could you just emphasize on that?
Ma'am, we have used the buccal marginal gingival tissue. Normally, we use the palatal or an edentulous site or a maxillary tuberosity. But we face the whitish thickened appearance of the graft blending at the recipient side with the palatal graft, the palatal gingival graft. That's why we have used this buccal marginal tissue, which shows the good color match and not that whitish tire-tack appearance which occurred in the palatal grafting.
Any references you can quote?
Yes, ma'am. This is also a 3-year report was done in the 2016. In that also the author has taken the gingival tissue as a donor tissue, gingival buccal tissue, and from this I have taken the idea of doing this.
Thank you.
Can we have the next poster? CRPO 211 by Ramakant. Ramakant, you can proceed.
Hello.
Yes, hello.
Hello. Yeah, good afternoon, ma'am. I'm audible?
Yes, you're audible.
Yeah, good afternoon, ma'am. Today I'm going to present a poster on mucormycosis of mandible in a diabetic patient. It's a case report. Coming to introduction, fungal infections are opportunistic and highly contagious. They spread from an infected person or an animal and can be fatal. Mucormycosis is one such opportunistic fungal infection. It is resulted from the ingestion of contaminated food, inhalation of spores into the nerves of or lungs, or inoculation into disrupt skin or wounds. The aim of the case is to describe a case of mucormycosis in a diabetic patient associated with chronic periodontitis. The chief complaint of the patient was there was a pain in the lower front tooth region and loss of gums in the lower front and back tooth region since 1 month. And the clinical features was patient was apparently asymptomatic, gradually developed pain over a month. Medical history shows HbA1c of 7.1 and was medicated since 5 years. An extraoral examination, bilateral facial symmetry was observed. Intraoral examination, mild swelling with first discharge, roughly obliterated vestibule in relation to 3637 region. In following weeks, patient reported with tooth loss and denuded gingiva in relation to 31, 32, 36, and 41. Histopath feature shows chronic inflammatory cell infiltration within the connective tissue, stroma, and numerous non-septae hyphae with branching, seen at 90 degrees. The CBCT shows osteolytic lesion involving buccal and lingual cortices with loss of trabeculae pattern indicating mucormycosis of mandible. The treatment was oral prophylaxis and oral hygiene instructions were given. Systemic antifungal were prescribed, that is amphotericin B, and HBO therapy, that is hyperbaric oxygen therapy, was done, followed by mandibulectomy. Coming to conclusion, in a diabetic patient, the absence of aseptic environment or poor oral hygiene by patients can aggravate the spread of mucormycosis. Early detection and successful management are key goals to prevent morbidity and mortality. In recent times, it has been documented in post-COVID recovered patients as a complications. Thank you. The first picture shows the patient with denuded gingiva, and the second picture shows the OPG of the patient when reported to the department for the first visit, and third picture shows denuded exfoliation of tooth and denuded of the gingiva in relation to 3.6 area and 3.1, 3.2, 3.3 area after this third week. And next is CBCT showing the bone trabecular loss, and the last picture was the histopath features, which show the septate hyphae with blanching.
Okay. Patient was immunocompromised.
Yeah, ma'am.
You mentioned he's diabetic, so obviously fungal infections are opportunistic infections when they invade when the immunosuppression or immunocompromised status is there. So, how is it related to periodontist? Like, what is the role of periodontist rather in such cases?
First patient came to the department with a complaint of food lodgement, and there was a slight mobility of the tooth. So we just suggested that the case has a CGP, chronic general periodontitis. Later, further investigations, we came to the conclusion that it was a mucormycosis. After taking a biopsy of the tissue and as bone soft tissue as well as hard tissue.
So it's very important and crucial. That is, you have mentioned about early diagnosis. So there comes the role, because if this early diagnosis and prompt treatment will go a long way in patients' well-being. Okay.
Yeah.
Okay. Thank you.
Thank you, ma'am.
Can we have the next poster? CRPO 212, Sandeep.
Good afternoon, ma'am. Am I audible?
Yes, you're audible.
Good afternoon, respected judges and audience. Today I will present a case report titled Combined Endoperial Lesion, a Sequential Treatment Approach. Here we all know endoperial lesion is one of the most challenging situation in our day-to-day practice. Here I present a case. Before that, I will just tell about the prevalence rate. It's according to our 2017 workshop result. They shows the endoperial lesions prevalence is 4.9% related to patient and 0.4% tooth related. So it is not. So it is quite common case that we got in our day-to-day practice. In our case, a 34 years female patient reported to our OPD with the chief complaint of pain and swelling of our 4-7 region. As per the protocol on emergency phase, we prescribe the patient's antibiotic, analgesic, and we go for the access preparation and debridement. After that, we will go for the RCT treatment. If we see the picture clockwise on the 12 o'clock position, this is the first day when the patient came to our department, and after that access preparation and healing of that abscess, we measured the probing pocket depth is 11 millimeter. We go for a root canal treatment. After that, we go for regenerative treatment. We follow the 2018 Rodriguez protocol, the non-incised papilla surgical approach or NIPSA. We give a single horizontal incision at the base of the bony defect on a healthy bone. We debride the bony defect, remove the granulation tissue with the curettes. After that, we place the beta TCP bone graft along with guided tissue regenerative membrane. After that, we suture the surgical site we follow the NIPSA protocol, and we go for a restorative. We go for a crown or ceramic crown, and if we measure the probing pocket depth again after 6 months, it shows very significant reduction of pocket depth, and in a radiograph it also shows the significant reduction of radiolucency. Also means they have shown the presence of results of regeneration both clinically and radiographically. We can say if we followed the protocol, that first endodontic treatment, then the periodontal regenerative treatment. Thank you, ma'am.
Okay. What is the time span after your endodontic treatment before periodontal surgical procedure?
We are 3 months, ma'am.
Why?
As per the literature, they advise that after root canal treatment, in some cases, even with the endodontic treatment, the radiolucency or the bone defect that can be healed up even just after the root canal treatment. But in our cases, even after 3 months, there was more than 10 millimeter pocket depth. That's why we go for regenerative therapy.
Okay. Thank you.
Thank you, ma'am.
Next poster, please. CRPO 213, Dr. Divya.
Am I audible, ma'am?
Yes, yes, you are audible.
Good afternoon. My poster is on Smile Makeover with Implants and Interdisciplinary Management of Hyperdentia, a case report. This is a case of a 24-year-old male patient with unpleasing appearance due to congenitally missing maxillary laterals and dystemia. This was treated by a multidisciplinary approach involving periodontal maintenance, orthodontic, and prosthetic rehabilitation. First of all, the patient is systemically healthy, and we did the phase 1 therapy with oral prophylaxis and orthodontic space creation done in this congenitally missing tooth in the relation of the two laterals. And the space is created for implants. After 6 months, the first implant is placed, and there is a after 6 months, the second stage of implant is placed by removing the orthodontic appliances, and the prosthetic rehabilitation done, and the impression is taken, and there is a jig trial was done, and the closed tray impression is followed by a closed tray impression taken, and the final implant is placed. So hypothesis, the most common dentofacial malformation humans refers to development failure of the 6 or fewer teeth is present. And this it is congenital missing tooth hypodontia is a highly prevalent dental anomaly. Besides an unpleasing appearance, patient gives with the missing tooth may suffer from malocclusion, periodontal damage, insufficient alveolar bone growth, reduced chewing ability, inadequate pronunciation, and other problems. So treatment might usually involve a multidisciplinary approach. Hypodontia may be associated with the microdontia as well as tooth agenesis. Other clinical findings such as enamel hyperplasia, diminutive or pec lateral incisors, primary molar infraocclusion, and palatal inclined or impacted maxillary canines are also be noticed. And the impact of this hypodontia is microdontia, palatal displacement of canines, deep bite and malocclusion, ectopic eruptions, as well as delayed eruptions. The first poster gives the initial treatment condition. The first picture shows, and there is a CBCT analysis done, and then the orthodontic phase, and there's a space is created, and the implant installation is done using Adin storage device of there is two given, that is of diameter 2.75 mm as well as 11.5 mm length and later we again take the radiographs, and in between after 6 months the second stage implant placement is given, and at that time there is even Holy appliance for the rehabilitation also, and finally the procedure rehabilitation done, and the patient is satisfied with this current treatment. And missing lateral. Hello, am I audible?
Yes, you're audible.
And the missing lateral incisors are the second most common dental after the mandibular second premolars. according to Brian J. Jackson, 2013, and the main consideration for replacement including the available space, rigid quality, and balance profile and occlusion, and adjacent tooth color. So the orthodontic space creation followed by implant restoration.
Dr. Divya, sorry, your time is up, so we have to proceed to the question answer session.
Okay.
So what was the time duration of this complete treatment?
Complete treatment takes 2 years.
Thank you.
Okay.
Any other questions? If there aren't any questions, shall we move to the next?
Can we have the next poster, please? CRPO 214, Safia.
Good afternoon. I'll be presenting my poster on vestibular incision subperiosteal tunnel access vista approach technique, the novel approach for management of multiple gingival a novel minimally invasive approach applicable for both isolated recession defects as well as multiple contiguous defects. Access to the surgical site is obtained by means of an approach referred to as VISTA. This technique allows for both access as well as opportunity to coronally repositioning the gingival margins of all involved teeth. In this case report, we evaluated the effect of VISTA with platelet-rich fibrin matrix membrane for the treatment of class 1 multiple recession defects. Preoperative view of recession defects at 131415 measured as 2 mm. Now coming to the surgical procedure, under local anesthesia, full thickness 8 to 10 mm vertical incision was given in the vestibule, mesial or distal to the surgical site treated. This incision was extended up to the gingival margin and served as door for extension of subperiosteal tunnel. This tunnel exposes the osseous plate and extending by Orban's knife up to 1 or 2 teeth beyond the recession site, undergoing surgical correction. Moreover, the subperiosteal tunnel was extended into interpapillary region without piercing the papillary tip. Slow apical movement of knife through papillary region commute to the vestibular tunnel and allow the coronal movement of mucogingival complex covering the MRDs. This subperiosteal tunnel was repositioned coronally and adaptive passively to CEJ covering the recession defects. Coronal anchored sutures will be placed engaging 2 to 3 mm apical gingival margin of individual tooth using non-absorbable sutures. The suture will be secured with the help of composite resin button to prevent apical relapse of the gingival margin at the mid-coronal point of the facial aspect of each tooth. Once coronal stabilization achieved, freshly prepared PRFM membrane will be inserted through the tunnel using the small periosteal elevator and spread it uniformly on recession defects. After complete and proper adaptation of the membrane, this vertical incision was sutured for the primary closure and complete surgical site was covered with periodontal pack. Clinical parameters including recession depth, width, pocket probing depth, gingival thickness, and clinical attachment level were evaluated at baseline and 3 months post-operatively. Complete root coverage was achieved with VISTA technique and PRFM membrane with improvement in all clinical parameters with remarkable improvement in gingival thickness. VISTA with PRFM membrane is a predictable technique for complete root coverage in MRDs. Also, platelet-rich fibrin matrix is used here because it has an arrangement of thick, non-porous areas, long strands and bundles with pores composed of amorphous fibrin and fused strands. Thank you.
Can you quote some references? The latest ones?
The VISTA technique was given by Zade et al. In 2011, and also by the Surgi Garg has given in 2018.
Okay, thank you.
Thank you.
Can we have the next poster? CRPO 215, Megha. Hello. Could you please talk a little louder? You are audible, but your voice is very low. Talk a little louder if possible.
Good afternoon, everyone present here. Today I am here to present my case report titled Deep Frozen Bone Allograft in combination with RH-PDGF-BB for horizontal bone augmentation. Coming to introduction, bone resorption after tooth loss is usually progressive and irreversible and is more important in the first year. It contributes to the reduction of bone volume and unfavorable maxillomandibular relation. Reliable reduction in the bone volume, bone rehabilitation of the alveolar ridge with endogenous implants quantity of the alveolar bone to achieve rehabilitation. This can be overcome by existing literature. However, the present case report is to assess the efficacy of frozen allogenic block graft infused with recombinant platelet-derived growth factor in horizontal ridge augmentation clinically and radiographically. Coming to the methodology, a patient came to our department of implantology with the chief complaint of missing teeth in the upper front tooth region and wanted to get it replaced. After the detailed medical history on oral examination, the patient is presented with horizontally deficient ridge. The data obtained from the CBCT was used to make a stereolithographic model for pre-surgical planning. On the day of surgery, under sterile conditions, after administration of local anesthesia, full thickness flaps were reflected and the ridge width measured using UNC12 probe was 1.9 mm. And the ridge was augmented using deep frozen allogenic block graft soaked in RH-PDGF-BB for 15 minutes. Later, it was trimmed and fixed to the recipient site with the titanium screws, and the flap and the space between the block allograft and host bone is filled with the particulate allograft. And the flaps were approximated and sutured using 5-0 sutures. The clinical and CBCT measurements of the ridge width were done at baseline and 4 months post-operatively. At 4 months post-surgery, the clinical ridge width was significantly increased to 4.9 mm and the radiologically it was increased to 5.2 mm. Coming to the conclusion, from the result of the present case report, it was evident that combination of frozen block allograft and RH-PDGF-BB is an effective means of horizontal ridge augmentation and leads to good amount of bone regeneration. Thank you.
Actually, the photographs which you have put up here are a little blurred. I'm unable to exactly appreciate, but still the procedure is pretty clear and the steps are also clear. So what are the drawbacks? Can you just let us know about the limitations?
Ma'am, limitations of using an allogenic bone graft, it is it is obtained from a cadaver and it has less viable cells. And here, the block graft, we have to trim it properly before augmenting it, ma'am. Or one more is that exposure of the block graft can happen after the surgery, ma'am, when they come for suture removal.
Okay, thank you.
Hello. Hello.
Yeah,
Meg yeah, Megha, I've just joined in Dr. Deepa.
Yes,
just ask Megha a few questions. Megha, you are using an allograft, no? So how do you check whether this graft has been taken up properly before you place an implant there?
Sir, we obtain it from Tata Memorial, sir.
No, that's fine. I'm telling clinically, you know, what are the complications you can face with using a block allogenic graft for vertical or horizontal bone regeneration?
Yes, sir. One is the exposure may happen.
Yeah.
Other is while placing the screws, while fixing the block graft to the host bone, it would be difficult, sir. Here
Yeah.
we are using 2 screws for the placement,
Okay.
and we have to make like a box type drilling in the host bone, so that the block can be properly placed in the place.
So do you remove the screws before you place the implant?
After
So
4
at
months,
that point of time, yeah.
4 months
after 4 months.
after the augmentation, we remove the titanium screws placed, sir.
Okay. Okay. Thank you.
Next poster, please. CRPO 216. Dr. Mayur.
Good afternoon, ma'am. Am I audible?
Yes, you are audible. You can proceed.
My title is the entire papilla preservation technique, redefining aesthetic zone intravone defect regeneration. Introduction: regeneration of lost periodontal tissue is the ultimate target of periodontal treatment. Different surgical procedures have been proposed to preserve the interdental papillary structure. All the techniques, however, entail an incision of defect associated interdental papilla that may compromise the volume and integrity of interdental tissue. This clinical report is a reproduction of a novel tunnel-like surgical approach for the entire papilla preservation for regenerative surgery. The surgical procedure, the first picture shows the intrabony defect, and the second, the incision and reflection. The intracircular incision start from the intrabony defect to the adjacent interdental space, and this is the intravonic defect. After the incision and reflection, the curettage and the granulation tissue was curettage is done and the granulation tissue is removed, and after that the root biomodification is done and the bone graft is placed and the suture are done. This is the post-operative RVG after the 6 months, and which shows the bone formation, and the last picture is follow-up after the 6 months. And the advantages of this technique are: this prevent the exposure of regenerative biomaterial, and also favor the primary healing over the biomaterial and maintain vascular integrity of the interdental papilla. Limitations: the depends on defect configuration and papilla morphology, and this is limited use on a lingual or palatal side. Discussion: the technique provide adequate mechanical access to the interproximal deep and wide intraponic defect and uneventful post-operative healing. It also papilla preservation technique have reduced membrane exposure to 30%, while it is in 10% of cases in a minimal invasive surgery. This technique further aim to improve the numbers. And the conclusion: although only few cases have been treated using this technique, but the outcome seems to be encouraging. Thank you.
So, would you like to start with the questions?
Okay. Mayur, can you hear me?
Yes.
Hello. Mayur,
Hello,
can
sir.
you hear me?
Yes, sir.
Mayur, you have tried regeneration here, right? Regeneration of an intrabony defect.
Yes, sir.
So you have only used a bone graft
Yes.
here. We not used any membrane.
Bone graft and membrane.
Membrane you have used. What membrane have you used?
Resorbable perioheal membrane.
What's that? Resorbable?
The brand name collagen membrane.
Collagen membrane. Okay. No, I have not seen that here in your discussion. That's why I asked. Because okay, we can treat with grafting alone, but to some extent, when you take a limited access opening, you should have shown the placement of the membrane also there. You know, that would have been good. Anyway, otherwise, The suturing, everything is very nice. And
Thank you, sir.
where is the vertical incision placed?
Sir, the adjacent to interdental space.
Okay. Now the defect is also in the same area, or distal to the defect it is?
The vertical incision is given to the distal or depends upon the.
Hello, sir.
No,
This
here.
is Dr. Hello, sir.
Yeah.
This is Dr. Soham. I'm the co-author for the poster.
Yeah. Tell me.
Yes, sir. Sir, the incision is designed in such a way that the incision starts on the distal side. In the second photo, we can see the defect is on the mesial side. So the incision starts on the distal aspect and vertical incision is given. The flap is reflected in such a way so that a tunnel is created inside the mesial papilla. So the papilla itself is not incised or not reflected, but just the periosteum is reflected above the mesial side. So we get a tunnel and we can approach the defect from that side.
Yeah, only problem is placing a membrane here becomes a little bit tricky.
Yes,
there.
sir. This procedure is too much technique sensitive and also consumes a lot of time.
Okay, Mayur, and thank you, madam. You can.
Yeah. I will just. My question was on the same thing on the vertical incision that they have given, and also the only disadvantage I can say is that it is okay in the narrow defects, but in a wider defects that
Yes,
might be
ma'am.
an issue.
Yes, ma'am.
Otherwise, good efforts. Thank you.
Yes. Thank you, ma'am.
Next poster, CRPO-217, Dr. Vaibhavi.
Audible?
Yes, you are audible.
Very good afternoon to everyone. My topic for today's poster presentation is splenectomy, releasing the pill. So, a good smile always boosts the confidence in one's personality, and dentistry plays a very major role in it. Midnight diastema is very common aesthetic problem, and it has multiple pathological causes, one of which is the aberrant frenal attachment. The frenum is basically a thin fold of mucous membrane. According to Plastic et al. In 1974, he said that there are 4 types of frenal attachments. First is mucosal, gingival, papillary, and papilla penetrating. Among which papillary and papilla penetrating are the pathological ones, hence they should be treated by doing frenectomy, and followed by prosthodontic or orthodontic treatment can be done to close the midline diastema. So there are various techniques of frenectomy, starting with the conventional one, also called as classical frenectomy technique, given by Archer in 1961 and Kruger in 1964. This is basically an excision type of frenectomy technique in which the frenum is engaged by using a hemostat. 2 incisions are performed on the upper and the undersurface of the hemostat, and the frenal tissue is removed. After that, blunt dissection is performed by using the hemostat, and the diamond edge of the wound is sutured back. Second technique is the Miller's technique, given by P.D. Miller in 1985, which is performed in post-orthodontic cases. It is performed once the orthodontic movement is completed, just 6 weeks before the removal of the appliance. In this, the 2 incisions are performed after excising the frenum. One is the vertical incision, 2 to 3 mm apically into the depth of the vestibule, and one is the horizontal incision, which is performed 1 to 2 mm apically into the zone of the attached gingiva, connecting the vertical incisions. Then the flap is mobilized and sutured across the midline. Third is a parallel technique, in which 2 parallel incisions are performed along the side of the frenum, and the frenal tissue is excised. In this, there is no complete removal of the frenum. The frenum is just relocated apically. Then the Z-plasty, which is done in cases of hypertrophic frenal attachment when there is lower insertion of the frenum and shallow vestibule. In this, a single vertical incision is performed along the length of the frenum, and 2 horizontal incisions are performed at an angle of 60 to 90 degrees, connecting the vertical incision. And then the submucosal tissue is dissected, and the flaps are transposed 90 degree and then sutured along the vertical incision. Then last technique is vivaplasty, which is performed in cases of papillary attachment of the frenum, in which the frenum is again engaged into the hemostat. A V-shaped incision is performed under the surface of the hemostat. Then the V-shaped incision is converted to a Y-shaped incision by pulling the frenum apically, and then the sutures are placed. So in this technique also there is relocation of the frenum. So I would like to conclude by saying the conventional technique, Miller's technique, and Z-plasty technique are the one which completely remove the frenum, while the other two just relocate the frenum apically. Thank you so much.
Madam?
So you can proceed. You can proceed with the questions.
Okay. Gopika, can you hear me?
Yes, sir.
Yeah. Gopika, in these are cases which you have done yourself?
No, sir. Dr. Vaibhavi.
Vaibhavi, sorry. Vaibhavi, these are cases which you have done?
Yes, sir. Yes.
Yeah, in the VY-plasty,
Yes,
when you're doing this VY-plasty, now in the center of the midline, you see a bunch of tissue there, you know.
Yeah.
So what do you do with this tissue? Do you remove it during a frenectomy or keep it there like that?
So in the conventional technique, we remove the palatal papilla also and the interdental tissue. But this is the major drawback of the VY-plasty is that it is not the complete. The frenal tissue is not completely removed in this technique. We are just relocating the frenum apically. So the tissue which is seen in the photo also, it is not removed in the technique which is VY-plasty.
Yeah, so it may not serve the exact purpose for what we were
Yes.
doing this procedure, you know. So that is what is more important, you know, whenever we do a procedure,
yeah,
rather than doing it for the sake of the procedure, we should serve the purpose also, right?
Yes.
Okay, thank you, madam.
Yeah, only one question. What's the difference between frenectomy and frenotomy?
Ma'am, in frenectomy, there is a complete removal of the frenal tissue, whereas in frenotomy, there is only relocation of the frenum. There is no, the frenal tissue is not completely removed.
Yeah, then can you correlate them with the other two techniques you have done?
Yes, ma'am. In VY-plasty and according to this case report, which I have observed is parallel technique, and in VY-plasty technique, there is only relocation of the frenal tissue. The frenal tissue is not completely removed.
Thank you.
Thank you.
Next poster, please.
Thank you.
CRPO 218, Dr. Ravi Pati.
Shamni, ma'am. Am I audible, ma'am?
Yeah.
Yes, yes, you are audible.
Yeah.
Okay, very good afternoon, everyone. This is a single case report on periodontal disease in rheumatoid arthritis patient. Coming to introduction, rheumatoid arthritis and periodontal disease are two common chronic inflammatory diseases which share common mechanism of producing peptidyl arginine deaminases, which have impact on the development and progression of rheumatoid arthritis. Coming to the details of the case report, a 22-year-old male patient reported to the outpatient department of periodontics with the chief complaint of swollen and bleeding gums. His previous medical history revealed the diagnosis of rheumatoid arthritis, and he is under medication since 6 years. Past dental history revealed the patient underwent full mouth gingivectomy 3 years back, and he came to our department with the same recurrence. So he had signs and symptoms of joint pain and joint stiffness and recurrent fever, fatigue. Coming to the clinical features, the gingiva is a diffuse, soft, and edematous enlargement. It is involving up to the middle third of the crowns in both the arches with spontaneous bleeding on probing. And generalized pseudo pockets of 4 to 5 mm are seen in both the arches. And also horizontal bone loss is also present, but which is very minimal. And we have concluded that this is a rheumatoid arthritis case by investigations of RH factor value. It is 22.5 international units per ml. And with a doubt, as we have seen the clinical pictures showing enlargement, if there might be a vitamin C deficiency, in a doubt, we have done the vitamin C levels also. So the level is normal. And finally, we concluded that this is a case of rheumatoid arthritis and periodontal disease. This is a picture, a pre-operative picture showing the complete gingival enlargement involving all the 4 quadrants. And this is the radiographic features, that is OPG of the patient. And after treating with the laser gingivectomy, healing showed up at the 1 month. Coming to the discussion, As a part of initial periodontal therapy, scaling and root planing was performed, followed by laser gingivectomy procedure in both the arches. Wound healing is satisfactory and evaluation of periodontal status was done at 1 month. Patient showed improved gingival health and systemic health. Aberas et al. In the year 2008 and Kobayashi et al. In the 2010 have reported that this periodontal severity tracks with the rheumatoid arthritis disease activity. Coming to the conclusion, bacterium known to cause chronic inflammatory gum infections also triggers the inflammatory autoimmune response, which is also found in the joints of the patients with RA. Thank you, sir.
Okay.
Thank you.
Sir, please proceed with the question, sir.
Yeah. Vaibhavi, right?
Shravani, sir.
Shravani, okay. Shravani, there are many patients with rheumatoid arthritis, but all of them don't get rheumatoid arthritis patients report with periodontitis?
Not all, sir, but there is an increased risk, sir. Periodontal disease, that is twofold risk, sir.
Twofold risk is there, okay.
Yes, sir.
Yeah. So there are high chances that these patients can have periodontal problems also.
Yes, sir. Yes, sir. Because
yeah, tell me.
Because in periodontal disease, we know that red complex bacteria, that is Porphyromonas gingivalis, will cause the periodontal disease. And whereas in rheumatoid arthritis patients and in periodontal disease, we will see the common mechanism, sir, that is expression of the peptidyl arginine deaminases, sir. These will lead to the development of anti-citrullinated peptide antibodies, sir.
Okay. And you have checked for vitamin C, right? Did you check for vitamin D also?
Yeah.
Actually, we have checked for vitamin D, iron, calcium also, sir. There are all are in normal range, sir. Only this rheumatoid factor value.
No, no. I just want to know: is there any relationship between vitamin D deficiency and periodontal disease?
Yes, sir. Yes,
okay.
Sir. There is.
Okay, ma'am.
Okay. I just want to know what is the reason for gingival enlargement? Okay, you understood attachment loss, bone loss is related to rheumatoid arthritis, but here we are seeing more of gingival enlargement. So what's
Yes,
the
ma'am.
reason for gingival enlargement?
Not only rheumatoid arthritis, ma'am, he is also having the local factors, ma'am.
Yes.
So that is the reason might have enlargement, and he neglected showing to the approaching any dental clinics, ma'am, for 2 years.
So you had also mentioned patient had earlier got the gingivectomy done.
Yes, yes, ma'am. I already mentioned in dental history, ma'am.
Okay. So this again gingival enlargement is because of the local factors and improper maintenance of the oral hygiene by the patient.
Yes, ma'am. Yes, ma'am.
So patient came with a history of rheumatoid arthritis.
Yes, ma'am.
Okay. Thank you.
Thank you, ma'am.
Thank you.
Next poster, CRPO-219, Dr. Yamini.
Good afternoon, ma'am. Good afternoon, sir. So I would like to start my poster with now. So currently co-infections and opportunistic infections during and post-COVID are an emerging concern. So in this case, I would like to present a case report of a 52-year-old female patient who came to the department with the chief complaint of multiple gingival abscess and also with the tooth mobility. And she also had a medical history of diabetes. And then she revealed on clinical examination, it was seen that all the teeth were in the first quadrant were grade 2 mobile with all the teeth being vital. And also after that, the patient was sent for laboratory investigation of blood sugar level, where we saw that the HbA1c level was around 16%. And after which she was confirmed that she was an uncontrolled diabetic. Then later, she was referred to ENT department for histopathological examination of KOH smear for fungal in which it revealed a fungal hyphae. And then they also she was additionally referred for a confirmatory test of CECT of orbital and PNS sections, orbital and PNS view of axial section, where it was confirmed as invasive fungal sinusitis. Then the patient was advised with antifungal drugs, and also surgical debridement was advised. So here the patient first, she reported to the dental department only without knowing any prior medical condition that she was having, just with the gingival inflammation and a gingival abscess, and also the tooth mobility, which here we can conclude that just because of the adequate knowledge from the dental part, we were that the medical, even though from the medical side they were not able to diagnose, without the dental intervention, medically it was not able, they were not able to diagnose the conditions. So thank you.
Hello.
Yes, sir. Is it?
Yeah. This patient came to the dental clinic first, or went to the medical side and came to the dental side?
So first she went to medical. From there, they just referred for, they didn't say anything. They just referred that she is having tooth mobility and tooth problem. Then again we refer the patient to ENT, and again they sent the patient that the patient is not having any medical condition. Then again we sent for, from here, from the dental wing, we sent for the KOH swab to be done in the medical side, sir. Then after doing the KOH swab, they came into a conclusion that okay, it was not a dental problem, it was a medical, she was having. Then they sent for CECT examination, where they came into a conclusion that it was invasive fungal sinusitis. So since the patient was diagnosed earlier, they were able to advise her antifungal medication, and earlier a surgical debridement was possible, sir.
So nothing from our side was done?
So our side, we only mouthwash, Chlorhex mouthwash was advised, sir. Since during the course of the disease, we cannot do any prophylaxis also. So in such patients, it is better not to do any prophylaxis in that case.
So what is the medical management that they have done for this antifungal infection?
So they have given posaconazole TDS 100 mg for 1 month, and with a loading dose of 600 mg. They have started, and also they are planning. They have planned for surgical debridement. But since the patient had a very low HB of around 4 mg, she has been currently waiting for her HB level to increase, and then the final diagnosis after the biopsy is still awaited. So because of the delay, little bit delay, sir.
What are the major problems associated with this mucormycosis infections?
Major problems in relation to dental or in general, sir?
Say now this is involving the maxillary anterior region, no?
Yes.
So yes. Yeah, so with the dental and with the mucoalveolar complex, what can be the complications which can happen?
So the bone will get necrosed, and entire bone has to be removed. So there will be a defect formed, which she will again have to undergo prosthetic replacement. The entire bone segment will be removed, since the bone gets necrosed and sequestrized because of the infections.
So it usually requires a wider excision, right?
Yes. Yes.
Yeah.
Sir.
Okay. Thank you.
Thank
Madam.
you, sir.
Yeah, good presentation. Most of the questions sir has asked. Yeah, definitely patient will end up with having maxilla removed. Maxillectomy would be done, and it's quite an extensive rehabilitation also. But again, early diagnosis and prompt treatment will definitely yield better results. Okay, thank you. Thank you so much.
Thank you, ma'am. Thank you, sir. Thank you.
Next presentation, CRPO-220, Dr. Akshay.
Good afternoon, everyone. Am I audible? Hello.
Yes, you're audible.
Yeah, you're audible.
Yeah, this is a reed split technique by Simoni in 1992. It is given by Simoni. In this technique, the split reed technique, we can increase the width of reed using a bone expander or a motor driven bone expander. In this technique, maxillary crestal ridge augmentation is an alternative bone expansion technique. In this method, we can this is the viable option for horizontal defect ranging from 3 to 5 mm of the bone ridge, and we can simply increase the width with the bone expanders for implant placement for dental implant. The advantages are that can be simultaneous implant placement and minimally invasive, and disadvantages are maybe a risk of buccal fracture, and this is very effective and mainly minimum invasive technique.
Okay, you are done with the presentation?
Yes, ma'am.
Okay, so please proceed, sir.
What have you done exactly, Doctor?
With this maxillary width, maxillary ridge, I have mainly done the increase the width of maxillary ridge using bone expander.
Yeah, that I understood. Do you have see split
the
ridge
ridge
technique?
For implant placement.
You used. Hello.
Hello.
Yeah. What type of expanders have you used?
Motor driven piezoelectric motor driven expander.
Have you done a ridge split here?
Yes, sir. First technique in third, fourth photo, there is a split ridge.
So
in third photo, there is a pre-operative ridge. Then for the fourth photo, there is a split.
What I
made
feel,
by
Doctor, what I feel is,
yes.
you have in the heading you have written bone expander, right? But you have used a ridge split technique here for gaining width of
width of ridge.
bone. Yeah. So there are a set of instruments called as bone expanders where you can expand the buccolingual width of the bone, and ridge split is another technique.
Okay.
So what have you have used a ridge split technique? Yeah, right.
Both. I have used both the.
Both you have used together.
Yes.
That's you have used both together.
For implant, simultaneous implant.
Okay, then after you have split the ridge, what have you done?
I have placed the implant, and with the graft, with the help of graft and membrane, I have closed the site by suturing.
Okay.
Okay.
Hello.
Any drawbacks you have found in due course of this treatment?
Yeah, this is a quite expensive, and buccal bone maybe get sometime fracture in the surgical procedure.
Okay. Okay, you could change your title considering the procedure and the steps you have followed. Okay.
Okay, ma'am. Okay.
Split ridge and bone expansion for whatever next procedure. What was your objective that you can mention?
Okay.
Yeah. Thank you.
Can we have the next poster, CRPO-221? Dr. Komal?
Yes, ma'am.
Dr. Komal, you can proceed with the presentation.
Yes. Ma'am, a poster is not visible on.
Yeah, it is.
It's visible for us.
It is visible. We can see it. Komal? Hello.
Am I audible, ma'am? Am I
Yes,
audible, ma'am?
Yes, you're audible. You can start
Yeah,
your presentation.
you are.
Okay. A very good afternoon, judges. The topic of my today's presentation is on the modality for a modality for alveolar bone preservation, that is root submergence. So to introduce, the aesthetic rehabilitation of missing teeth, especially in the maxillary anterior region, is often plagued with issues such as uneven tooth recovery and issues related to the gingiva of the adjacent teeth, which leads to black triangle formation. Alveolar ridge resorption following the tooth extraction is inevitable and continues throughout the patient's lifetime. And eventually papilla loss, atrophy of the residual ridge, and compromises the aesthetic outcomes of the treatments. These undesirable consequences present challenges the anterior region with conventional processes, when there is no other option than conventional processes. The pink porcelain restoration surgical socket preservation techniques have been used to compensate for such compromises. However, neither technique solved the problem of compromised aesthetic outcomes by ensuring the predictable results. Hence, to preserve the alveolar bone resorption by retaining the natural tooth, a concept of root submergence technique emerged. It is a procedure where the tooth is surgically decoronated and the root is submerged at the level or below the alveolar crest instead of extraction. In 1961, John was first to establish or introduce this technique in his report of root submergence, and this technique was later used after 1960s to prevent residual ridge resorption in complete denture patients. So the advantage of RST is that it preserves alveolar bone resorption and thereby maintaining soft tissue profile, and thus gives aesthetically more favorable results. It is relatively simple, and there is a good proprioception, perception, and physiological response from the patient. So coming to the case, a 57-year-old patient reported to the outpatient department of periodontics in our college, that is Sharad Pawar Dental College. On clinical and radiographic examination, tooth showed no sign of restorable vertical fracture with 1-1, non-restorable fracture, and it was indicated for extraction. So in view of patient's bone condition and the region of the extraction, patient was advised for implant treatment, which he refused. And as the patient was not willing for any advised treatment, based on his patient's complaint, existing oral and periodontal condition, and his desire, RST was planned in relation to endodontically treated maxillary right central incisor. For surgical treatment, a full thickness mucoperiosteal flap was raised with 1-1. Flap reflection and decoronation of the remaining crown structure was performed. Flap approximation was done to check the primary closure, and to compensate for this soft tissue, PRF placement was done. After which PRF placement and suturing was done with prosthetic rehabilitation. For result and conclusion, the submerged root preserved the surrounding periodontium without any periapical pathology, and the gingival contour at the pontic site was maintained in harmony with those of the adjacent teeth.
Okay. So,
You're not audible.
Hello, can you hear me?
Yes.
Yeah.
Yes, sir.
Yeah, Komal, you told that the patient was not ready for implants, right?
Yes, sir.
What was the other rationale for going in for root submergence here? Do you have any other rationale other than the patient's denial of an implant?
Sir, in this particular case, the other rationale was all the other tooth adjacent to the site that was in concern were already root canal treated and were already having crown placements. Okay. So it was a good option that we continued that same procedure for the patient and gave a bridge to him instead of an implant placement.
So this is the picture of the final bridge which you have given?
Yes, sir. Yes, sir.
Now, if you compare the first picture and the sixth picture, the canines.
Yes, sir. Yes, sir.
Aesthetically, I think you could have gone in for a little more coverage of the roots and all those things with the crown, you know.
Right, sir.
Right?
Yes. Yes, sir.
You're definite, no, you have done, this is the final restoration which you are given.
Yes, sir.
Yeah, it's not a temporary one, no?
No, sir, no temporary.
You have replaced all the teeth from canine to canine.
Yes, sir.
Okay. Any other complications that can happen? What all factors would you consider in submerging roots for such treatment?
Usually, sir, the single tooth with the single rooted teeth shows best results for this, as the canals are all sealed, and therefore there cannot be any secondary infection in the tooth. So the best results are from the single rooted teeth. Multiple rooted teeth show some amount of complications with periapical infections, as well as then canals, missing of the canals.
How do you see? You're going to give a 6-unit bridge for this patient, and this patient
Yes,
has to. The patient will be investing quite some money on this, right?
Yes,
on a practical
yes.
point of view. So how do you
Yeah.
clearly evaluate this submerged root? You should be very sure that this root should not go in for any infection in the near future. But with the latest techniques which are available, how do you evaluate this root?
So we can do this CBCT for the patient to evaluate it three-dimensionally.
Yeah. So what do you do in 3D evaluation?
So we can properly evaluate the adjacent teeth and the particular teeth.
No, I'm talking
distance
about the root.
from the vital structures.
No,
distance from the structures.
No, I'm talking about this particular root stem which you're going to submerge. The
Okay,
evaluation
sir.
of that root stem only. What all would you like to evaluate?
So first of all, if it is endodontically treated, then there should not be any extension of the endodontic material in the surrounding structures.
Is it only the extension?
Sir, any reaction to the materials as well?
No. Endodontic fill is very important for us.
Yeah.
For a successful periodontal management, or for submerging a root. So in the endodontic fill part, what do you evaluate? Extension is fine. Anything else? Because many times when you take 2-dimensional radiographs, you see that the root canal is filled properly, but still it might have an infection. So what matters is the three-dimensional fill of the canal, right?
Okay,
which can be clearly evaluated with a
CBCT.
CBCT. You understood? Otherwise, when you just take a radiograph, you may not be able to evaluate it completely. So you should have included a radiographic picture also in this.
Yes, sir.
Or
I have two
CBCT.
limitations for my study, that I have not included any radiographic picture and a healing site picture as well.
Yeah. Okay.
Yes.
Thank you.
Yeah. Thank you so much.
Madam.
Yeah. Good attempt. Thank you.
Thank you so much.
Covered most of the questions. Thank you.
Next poster, please. CRPO 222, Dr. Farheen.
Good afternoon, respected judges. Am I audible?
Yeah, you are.
So I'll be presenting a case of frenectomy for improvement of problematic implant prosthesis in a young patient. Missing teeth are of great concern, especially in aesthetic zone. Implants have been widely used to replace missing teeth with overall patient satisfaction. However, presence of an aberrant labial or buccal frenum may jeopardize the functional as well as aesthetic success of implant-supported restorations. Therefore, frenectomy or frenotomy may sometimes be needed to overcome these problems. A female patient, 28 years old, reported to the Department of Periodontics with the chief complaint of missing tooth. After proper local anesthesia, full thickness flap was elevated and implant was secured in place. 2-month post-operative view shows the presence of a papillary type of aberrant frenum. And after achieving a proper local anesthesia with 2% lidocaine with 1:80,000 adrenaline, the frenum was excised using conventional frenectomy technique. And after the complete removal of the frenal tissue, the diamond-shaped edges were sutured using 4-0 silk sutures using interrupted sutures. And this is a 6 months post-operative picture after the placement of the ceramic crown. Coming on to discussion, in recent years, implant dentistry has undergone a
profound shift in the emphasis. The focus has evolved from a surgical driven approach to a prosthetically driven approach, and now to more of a biologically driven approach. Then high frenal attachment has been found to be associated with malalignment of teeth, loss of interdental papilla, and also a gingival recession around the natural teeth as well as dental implant. And various frenectomy techniques have been proposed for removal of aberrant frenum, which includes the conventional technique, the Miller's technique, the VY plastic technique, Z-plasty technique, and frenectomy using electrocautery. And among these, the Miller's technique is the best technique, resulting in no loss of interdental papilla and no scar tissue formation. However, the conventional technique is still the most widely used technique. And concluding, an aberrant frenum can be removed by any of these modifications. However, a functional and aesthetic outcome can be achieved by a proper technique selection based on the type of frenum attachment. Thank you.
So,
hello, yeah.
Yeah.
So basically, it is replacement of a central incisor and
Yes,
management
right.
of the frenum, right?
Yes.
So what type of frenum this was?
This was papillary type of.
Papillary penetrating?
Yes. No, sir. Not papillary penetrating. Papillary. It was not extending to the palatal papilla. It was extending to the. It was the fibers were inserting in the interdental papilla between the central incisors.
And you have done a Miller's technique, right? Okay, thank you. Madam, any questions?
So can you just tell us if there could be any chances of reattachment? What are the reasons, if any?
Ma'am, we have followed this case for 1 year, and there is no reattachment. Actually, we have performed the blunt dissection in that blunt dissection of the bone there. All the fibrous attachment were broken, so we are not expecting any recurrence, but we are still following up this patient.
So we consider this as a part of pre-prosthetic surgery, right?
Yes.
Ideally, you think it should have been done before? Because there could have been problem in maintaining the oral hygiene also for the patient, considering the high frenal attachment there.
Actually, ma'am, when the patient reported for the stage 2 step for the after the implant placement, then we did this frenectomy procedure.
Okay, thank you.
What madam was asking, whether you could have done it at stage 1 only.
Yeah.
Yes, ma'am. Yes, sir, we could have.
Thank
Right?
you.
Okay.
Can we have the next poster, please? CRPO 223. Dr. Vishruta.
Sir, I'm audible.
Yeah.
Good afternoon, everyone. Regeneration is the new redemption. Yes, it's true. There are various materials and techniques included in periodontal regeneration. In this case report, I'm going to discuss about one of the material which gave the promising results for the future implant placement. A 28-year female patient who was referred for a periodontal evaluation with respect to 3-6 was presented with a chief complaint of swelling in the lower left side of side. So on examination, the prognosis of particular tooth determined to be hopeless. So the patient scheduled for the extraction of the tooth along with the socket preservation. After socket curettage, the socket was grafted using combination of PRF and the bioactive glass. This bioactive glass has an important property, that is, it interacts with the biologic environment and elicit the response by formation of a hydroxyapatite layer, which bonds between the tissue and the material. At the time of implant placement, a core of bone was harvested from the socket preservation site by using the refined core burr and analyzed histologically for graft maturation and the stability. On microscopic examination of H and E stain section shows a mature laminar bone with the osteoblastic rimming and the osteocytes within the lacuna. Areas of fibrosis and areas of fibrosis are present, mild inflammation, predominantly of lymphocytes present, and few foci of hemoxyphilic dystrophic calcification, which deposits the residual graft particles. So coming to results, Novobone putty belongs to the class of bioactive regenerative material that not only acts as an osteoconductive scaffold as other graft materials, but also it imparts an osteostimulatory effect. Osteostimulation is the physiological action that stimulates, enhances, or accelerates the formation of bone at the host site or healing endosteocyte. So release of silica, which is the one of the composition of the putty particle, it is a key in signaling and recruitment of bone precursor cells, that is osteoblast, osteocytes, to the defect site and stimulate the osteoblastic differentiation, proliferation, which is the basis for the new bone formation. So I conclude that the effort to regenerate vital hard tissue is necessary to rehabilitate the partially edentulous areas, has led us to evolve simple, cost-effective and protective regenerative material, which can give adequate primary stability for implant placement and eventually prosthetic rehabilitation. So in this picture, I mentioned the pictures like pre-operative and post-operative. This is the hopeless tooth with respect to 3-6 in IOPA I mentioned, and the 6 months healing pattern of the bioactive glass pictorially I represented. And after 6 months, we took a CBCT. In this, we got dimensions which is adequate for the implant placement. And we open the site and implant is placed, and the refined core burrs are used for the harvesting bone for the histopathological examination. And histopathologically, we found the properties which is very similar to the natural bone, that is mature bone which formed in the site is similar properties, that is laminar bone with the osteoblastic rimming, osteocyte with the lacunae and the fibrosis. That's it.
Thank you. What type of a graft is this bioactive glass?
Sir, it is an alloplast that is synthetically prepared. Yes, sir.
Anything more about the graft here?
It is osteostimulating effect. So it is.
So what do you mean by osteostimulating?
So basically, it's a physiological action that stimulates and enhances or accelerates the formation of the bone from the host site, sir.
Okay. So once you put this bioactive glass into a defect site, what happens to this graft? What happens to this bioactive glass?
Sir, basically it releases the silica when it exposes to biologic environment. It releases the silica, and we know that calcium and the phosphate, these are the constituents of the bone. So it interacts with these, and it results in the formation of the hydroxyapatite layer, which is the main bond between the tissue and the material. Hence, it forms the formation of new bone formation occurs like this in procedure.
So considering the resorptive rate of bioactive glass, what type of graft it is? It is slowly resorbing, fast resorbing, or when was the...
Yes, the resorption in this, it considered to be less when compared to other. This is also one of the advantage.
Like your re-entry was at 6 months?
Yes, sir. Re-entry was after 6 months.
After 6 months. So at 6 months, you have seen that there is no graft particles there, right?
Means dystrophic calcification, like residual graft material was there, so not much evident, but there was there.
Okay, thank you, madam.
Yeah, thank you, sir. So we can proceed to the next.
Yeah.
Can we have the next poster? CRPO 224. Dr. Devang.
Yes, ma'am. Good afternoon, ma'am. Good afternoon, sir. So my case report is on management of endoperio lesion using bone graft and barrier membrane, a case report. So, starting with an introduction, the endoperio lesion primarily occur by the way of the intimate anatomic and vascular connection between the pulp and the periodontium. It is caused due to the cross infection between the root canal and the periodontal ligament. And so the etiologic factors are from the anatomic perspective, accessory canal or palato-gingival groove or kind of developmental grooves. Then the goal of the endodontic and the periodontal therapy is to maintain the natural dentition and also restore the lost periodontium. So here the objective was to determine the efficacy of cancellous bone allograft material with the chorionic membrane. Um, Starting with the case, so a 62-year-old male patient with a complaint of pain in the lower left central incisor in the department. So it was clinically and radiographically, it was diagnosed as a perioendo lesion due to the presence of the developmental groove on the labial side of the 2-1. And then first of all, the endodontic treatment was done, and then the periodontic treatment was done. So you can see in the first image, there was a pre-operative probing, which was in the 2-1 and it was 13 mm. And radiograph also shows the bone loss in the interdentally between the 2-1 and 1-1. So the flap was reflected. The flap was reflected with the circular incision with the and in the medial surface of the 2-2, the vertical releasing incision was given, and then the flap was reflected and thoroughly degranulation done, and after that the labially with the palatal the developmental groove which was there, to treat that, the odontoplasty was done at the same time, and then the filler as a the bone graft we are using over here is a cancellous bone material. So cancellous bone graft was filled in the defect, and then defect is closed with the help of the chorionic membrane, and then it is sutured along with the epithelium, and then periodontal dressing is given. So after and antibiotics and analgesic like brufen was given for the 5 days, and then patient was recalled after 10 days for the suture removal and the removal of the periodontal dressing. And after 6 months, we can see the significant bone fill on the radiograph, and even in the clinically, the probing depth, which was initially 13 mm, was after 6 months only 3 mm. So there is a reduction in probing depth also. So conclusion, so as I said earlier, the case report shows the reduction in the pocket probing depth and a significant amount of bone fill with the combination regenerative therapy using cancellous bone allograft and chorionic membrane. Thank you.
Okay, Devang, you were mentioning about the groove, right? What was the cause for this endoperio lesion?
Sorry, sir.
What was the etiological factor for this endoperio lesion?
Sir, it was diagnosed as the perioendo lesion because the presence of the developmental groove, which is present on the labially in the 2-1.
Okay.
Yes,
so what was your rationale for doing a root canal for this patient?
Sir, in the radiograph, the patient has a complaint of patient has also the swelling on the palatal aspect, sir, in the periapical lesion.
Patient had a swelling.
Yes, sir, and the patient has a complaint. Patient told about the pain in the since 7 days when he has reported in the first time in the department.
So how do you evaluate the pulp?
Okay, yes, sir. In the department of endodontics, they have evaluated the teeth and as a non-vital teeth, as they did the pulp vitality test, sir.
Okay.
And the teeth was non-vital.
Teeth was non-vital. Okay.
Yes, sir.
What is this chorion membrane?
Sir, chorionic membrane has gained its importance because of its first of all its healing ability, and it has the less scarring and the less inflammatory reactions. and also the epithelial cells quickly can cross the chorionic membrane and make a seal over the underfilling bone field and to cover the filling material.
Where do you procure it from?
Sir, it is very easily available from the Tata Memorial Hospital in Mumbai.
Okay, thank you, madam.
Yes, sir, and it is easily obtained, and sir, it can be easily harvested for there, sir, and transported.
It is easily harvested.
Sorry, sir.
No, it is. You get it from Tata Memorial Institute, right?
Yeah, yes, sir.
Yeah, okay, okay, ma'am. Please.
Okay, so according to you, what under the Simmons classification, so which is this category?
Ma'am, primary perio, secondary endodontic lesion.
You want to say this as primary perio?
Yes, ma'am. Because due to the presence of developmental groove on the labial side.
Thank you.
Okay.
Thank you, sir.
Thank you.
Can we have the next poster, please? CRPO 226, Dr. Dhwani.
Am I audible?
Yeah, you are.
Hello?
You are audible. Dhwani, you can remove your mask.
Sorry, sir.
Yeah.
Can I please start?
Yeah, please.
Okay. Good afternoon. So my case report is about a microsurgical interdental papilla reconstruction. So basically, because of the increasing aesthetic demands of the modern era that has converted modern dentistry into basically white and pink dentistry, one of the most difficult goals is in the regeneration of the soft tissues, and it is the reconstruction of the interdental papilla. So the gingival black triangle is a cosmetic deformity which refers to the absence of the papilla, resulting in the black spaces or open embrasures, which impairs aesthetic features, phonetics problem, and fluid accumulation. This case report that was a 26-year-old female patient that visited to our department with a chief complaint of space in between her gums in the upper front region of the teeth. On clinical examination, it revealed that there was a partial loss of papilla in between 2.1 and 2.2. Following the initial phase 1 therapy, papilla reconstruction was followed by giving 2 horizontal incisions connecting the 2 vertical incisions. And then a partial thickness flap was raised and coronally repositioned to completely obliterate the open embrasure. And the free end of the suture of the flap was sutured and the periodontal dressing was given. The follow-up was obtained after 1 week. Suture removal was done similarly, and then here we can see the pictures 1 month post-operatively and 3 months post-operatively.
That's it. So you have mentioned here microsurgical interdental papilla reconstruction. So what microsurgery did you do here?
So it was done with the help of microscopes.
Was it?
Oh, sorry.
No. Did you use a loop at least?
Yes, sir.
You have?
Yes, sir.
What about the sutures?
Sir, actually the sutures here use that 4.0, but technically in a microsurgical procedure, we are supposed to be using a more finer suture like 6.0.
Yeah, you should have.
Yes,
understood. This is a very fine, you are dealing with the papilla, which is few millimeter in thickness, you know.
Yes,
so you should have used some magnification. No, you might be able to do it without magnification, but to be more precise and to give more finish to your work, you know, you could have used finer sutures and some amount of magnification, right? Otherwise, I think the results are quite good. Yeah. Okay. Madam?
Yeah. The second part, like sir has covered about the microsurgical part, the reconstruction part, can you just elaborate?
Ma'am, initially, after following the phase 1 therapy, to releasing the vertical incisions were given, which was they were connected by a horizontal incision, after which a partial thickness flap was raised and it was coronally repositioned so that it can completely obliterate or fill the open embrasure. After doing that, they took the free end of the flap and they were sutured using like the direct loop sutures were used, and in this case we used the 4-0 sutures, whereas we could have used finer sutures. And then it was given followed by a periodontal dressing. The patient was recalled after 1 week for to check for the healing, and the sutures were the healing was satisfactory, so the sutures were removed, and then we kept the patient on follow-up for 1 month and 3 months.
Okay, thank you.
Thank you.
Next poster, CRPO 2006. Aina, CRPO 206. Aina.
Yes, good afternoon, ma'am. Good afternoon, everyone.
Good afternoon.
I'm not able to share my screen.
It is already shared. Yeah, we can see
It
this.
is there. Yeah.
Okay. So this is about gingival. Am I audible?
You're audible. You can proceed.
Okay. Gingival tissue response following placement of a light cure dressing and a non-eugenol dressing after periodontal flap surgery. A case report is presented here. Introduction: the periodontal dressings provide the post-operative patient comfort and are known to reduce dead space beneath the periodontal flap. Copac is one of the mostly widely used dressing today and offered a standard to which new dressings can be compared. It is of two-component non-eugenol dressing, also containing bacteriostatic agents. And another product, another material which we are using here is the white light, visible light cured periodontal dressing, which is commercially available as the Barricade, based on the polyether urethane dimethacrylate resin, is stated to be an advanced concept in the protection of a periodontal wound sites. So case description: this case report was presented after the periodontal surgery, which was treated with Copac dressing on one side and other side was treated with Barricade dressing. So these are the clinical parameters like wound healing index, plaque index, modified circular bleeding index, discomfort assessment, and the patient preference were recorded on the 7th day and the 14th day. So material which is used here is the Copac. Comes in a two paste. One is accelerator and another is catalyst. Paste one have the zinc oxide added, some oils, gums, laurethid oil, which act as an antifungal, and the second tube is unsaturated fatty acids and a chlorothiamol, which act as a bacteriostatic. So, and the Barricade is another material which composed of silicon dioxide, crystalline quartz, hydrophobic amorphous fumed silica urethane dimethacrylate resin. So we have two pictures. We have a place the Copac on 7th day and on the day of surgery, and the Barricade on the side B. This is a split mouth study technique. On the 7th day, we recall the patient. We check their gingival status. We check their wound healing and their plaque index. Then recall on another after 1 week we again recall. That was 14th day to again check the wound healing index status, the plaque index status. So what we found that after 7 and 14 days, there was statistically significant better taste, smell, and appearance for Barricade group of patient as when compared to the Copac group. So the light cure dressing show better acceptability and proved to be a better alternative to a Copac as a dressing material.
Madam. Hello. Can you hear me? Hello, can you hear me?
Yes, sir. Yes, sir. Yes, I can hear you.
Yeah. So, which material is better to handle, in your opinion? Is it Copac or Barricade?
Sir, in the matter of handling, the Copac I feel like is better.
Oh, why
it
is
can
that?
manipulate easily, but in the Barricade for a Barricade material, it is quite sticky material, and we need an extra light cure unit, and we have to light cure it for 10 seconds when we're applying with we also need a plastic instrument, or we can use with some or you can mold it with a glove.
Yeah.
But for me to handle proper dressing, I think Copac is better. But in the matter of patient when prefers it, pericard is just appears similarly to the gingival pinkish color, and it has a greater interdental stability, and mostly patient preference because actually Copac non-eugenol is quite
aesthetically unfavorable, right?
Yeah.
Okay, ma'am.
Yeah, considering the cost, what is the cost differences in
actually
both?
both comes in a same range, approximately around 2000, and which is not very costly. I'm using for my patient, and I have already bought 2 packets, and I find it's not very costly. So both have a same range.
It's kind of affordable, but
Yes, ma'am.
according to you, you will say that Copac is more bulkier compared to the other one, Barricade.
Yes, ma'am. Yes, ma'am.
Thank you.
Thank you.
Can we have the last poster for today? That will be CRPO207, Dr. Susan.
Good evening. Am I audible?
Yeah,
yes, you are audible.
Okay, can I start?
Yeah.
Good evening, everyone. I'll be presenting my poster titled Efficacy of Hyaluronic Acid and Connective Tissue Graft and Isolated Gingival Recession Treatment. A 36-year-old male patient came to our department with a chief complaint of sensitivity in his right back tooth region. On clinical examination, we observed that the tooth number 14 was showing a 3 mm of gingival recession. And according to Miller's classification, it comes under type 1 and Cairo's RT1. So we posted this particular case for coronally advanced flap with a CTG and adjunct to hyaluronic acid. So the surgical procedures, it was done by Zucchelli's triangular flap, where the incision lines are predetermined by an ortho wire. Then after the reflection of the flap, we harvested the CTG from the right side of the palate with a single incision technique given by Hersler's and Weng. And then further, we applied the cross-linked hyaluronic acid on the exposed root surface, and the CTG was placed over the hyaluronic acid, and the flap was coronally advanced with a sling suture, and the vertical incisions were sutured by interrupted sutures. And we observed the healing according to Young et al., the 2005 index, on the 2nd, 7th, and 14th day, which all showed score of 1, which was a good healing without any edematous or suppurative or erythematous tissue. And at the end of 6 months, there was complete root coverage achieved. Thus, to conclude, there was a significant change in the recession depth, the recession width, keratinized tissue width, gingival thickness, and 100% root coverage was achieved. So this study suggests that the use of CTG and HA may improve the clinical outcome of root coverage with coronally advanced flap procedure. Thank you.
Hello, Susan.
Yes, sir.
Where did you get this hyaluronic acid from?
Sir, it's called Perfect HA. It was procured from Columbia Hospital, Bangalore, sir.
Okay. And what is the most preferred surgical procedure for individual tooth recession?
Sir, a coronally advanced flap with connected tissue graft is a gold standard, sir.
Yeah. So what extra benefit do you get, what you feel you could achieve with hyaluronic acid? Used
In
along with
respect
this.
to the graft shrinkage and vascularity, in HA it is a highly hygroscopic material which retains water and the rigidity of the area, sir, and it also promotes neovascularization. And also there have been studies that clearly indicates the healing efficacy of hyaluronic acid, which might further help in the treatment of root coverage, sir.
Doing where hyaluronic acid and graft was used, and the graft alone was used.
Sir, sorry, sir, I couldn't hear you.
No, are there any comparative analysis where
Yes,
they
sir,
have used a graft alone and graft in, yeah?
Yes, Piloni et al. Has done a study where CAF
what is
was compared with CTG, sir, and there was a significant significance with the hyaluronic acid, sir.
What are the other application of hyaluronic acid in periodontics other than this application?
So it has been used
what other
to
ways
inject
you can use it?
Injectable for the papillary reconstruction, sir. Also in intrabony defects also they have used HA, and it has shown significant results. But the drawback is in papillar reconstruction, we might have to do it every 6 months.
Okay, Susan, thank you. Madam?
Thank you, sir.
Yeah, what's the cost of this material?
Ma'am, it's 1 ml is almost 10,000, ma'am.
So how much did you buy?
We got 1 ml.
Okay. So anyway, good topic to work upon for your further research. Thank you.
Thank you, ma'am. Thank you, sir.
Thank you.
Also.
Thank you. So with this, we come to an end of the session. Deepa ma'am, Major sir, I would like to thank you for sparing your valuable time for today's session. And thank you to all the participants. So I would like to kindly request the judges to mail their completed evaluation sheets to the mentioned email ID. So I'll be handing over to Dr. Kshitija for the next session. Until then, thank you and have a good day.
Thank you, Rubika.
Thank you so much for having
Thank
us.
you.
Thank
Thank you, ma'am.
Thank you.
Hello, everyone. Very good evening to our judges and all participants. A warm welcome again from the 45th ISP virtual conference. I would like to introduce our judges, Dr. Sheila Gujari and Dr. Deepika PC. Ma'am, have you all logged in? Are you all there? Yes.
Yeah, I am Dr. Sheila. I am there.
Yes, ma'am.
So, good evening.
Good evening, ma'am. I would like to introduce you to Dr. Sheila, ma'am. Dr. Sheila has done a BDS in 1989 and MBS from JSS Dental College. She has headed the department for 10 years. She has 74 publications and received various research grants. She has attended laser course in the University of Texas. She has interest in periodontal medicine and regenerative therapy. She has presented various national and international papers. We welcome you, ma'am.
Good evening.
Good evening. And Dr. Deepika PC. Dr. Deepika PC, ma'am has done a BDS in 1988. Her MDS in 1991. She has a licential exam she cleared from UK in 2008. She has worked in multiple places like India, Oman, and UK. At present, she is a professor and HOD of Department of Perio in JSS Dental College and Hospital, Mysore. She has many national and international publications, and her area of interest is periodontal regeneration. Welcome, ma'am. Yeah. Deepika, ma'am, are you there? I will just check with her. I can't see her anywhere. Just a moment. Yeah, ma'am is logging in. Every participant will get 3 minutes to present, and there'll be question and answer session for 2 minutes. Let's all stick to the timings so we can follow our schedule strictly. Ma'am should be there in a minute, and we could start with the first slide. Deepika ma'am, have you logged in? Deepika ma'am, have you logged in?
Yes, I have logged in.
Yes, ma'am.
You can start.
Yes. Okay, thank you, ma'am. Can we start with the presentations?
Yeah, sure.
Good evening, everyone. Today, my poster presentation is on preservation of extraction socket using a combination of platelet-rich fibrin membrane and demineralized bone mineral xenograft, a case report. Starting with the introduction, as we all know, extraction of the tooth induces significant dimensional changes in the alveolar bone due to bone resorption. These changes in the alveolar bone can cause, according to TAN in 2012, there is a 29 to 63% of horizontal and 11 to 22% of vertical bone loss can be observed following tooth extraction in the first 6 months of tooth extraction. So these alterations can compromise future implant placement and prosthetic design. In order to prevent these dimensional changes, socket preservation can be done. Socket preservation refers to the immediate placement of a biomaterial within the extraction socket following tooth extraction. It was first proposed, the technique was first described by Greenstein in the year 1985, and the term was given by Cohen in 1988. The technique is it is indicated in patients who are planning for future implant placement and in patients where aesthetics are prime importance with poor bone quality, especially in the anterior regions. And the technique is advantageous because it is simple, effective, and can minimize the future need for rich augmentation. Going into the case details, a 29-year-old female patient reported with a chief complaint of loose tooth in the left lower back tooth region since 2 months. After clinical examination, we found that the tooth was grade 2 mobile with a 10 mm probing pocket depth and a grade 3 percussion involvement. On radiographic interpretation, there is greater than 70% of the bone loss extending up to the apical third of the root. So due to its poor prognosis, we decided to extract the tooth and planned for socket preservation for future to enhance the future prosthetic rehabilitation. In this, the tooth was the tooth was extracted and the socket was degranulated to remove any granulation tissue. Later, for the preparation of PRF membrane, a 9 ml of blood was obtained from the patient into a sterile tissue without adding any anticoagulant, and it was subjected to centrifugation based on the Chopin's protocol. The culprit blood was subjected to centrifugation at a rate of 3000 rpm for 10 minutes, and the obtained PRF was condensed to form a membrane. Later, the membrane was combined with a bone graft of 250 micron size, and it is placed into the bone graft and placed into the extraction socket and sutured. After 6-month follow-up, there is a good bone fill was observed on the radiograph, and clinically, the ridge width was initially 8 mm immediately after the extraction, and it was 6 mm following after 6-month follow-up. So I conclude that the addition of PRF, the combination of PRF with the xenograft provides significant bone gain, both in terms of ridge height and ridge width, and can also minimize the dimension changes, gives a good and also gives a better implant outcome. Thank you.
Ma'am, could you ask questions?
Yeah. Now, this tooth appears to be dilacerated. Was it dilacerated?
Yes, ma'am. Actually, the distal root was slightly curved. So, during extraction, some part of the tooth was fractured.
Yeah. Why I asked this is there must have been some periapical involvement also. So, would there have been any infection in the socket? So how did you take care of that?
That's why we degranulate the socket to remove any infection in the socket, ma'am, prior to the preservation.
Yeah, but maybe you could have combined some antibiotic to the bone graft.
Yes, ma'am, we can.
And yeah, and apart from PRF, you have what is sticky bone? You have heard of that?
Yes, ma'am. Yes, ma'am.
What is sticky bone?
It is the injectable PRF combined with the bone graft, and it is kept for a 10 to 15, and kept for a 10 to 15 minutes, so that the PRF gets polymerized with the bone graft and forms a sticky bone-like structure which can be moldable.
So that could have been a better option. Yeah, and yeah, you have depended on the IOPAs. You didn't go for any CT scan?
No, ma'am.
Okay. Anyway, good presentation. Over to you, Deepika, madam.
I think most of it you asked, Sheila. I just wanted to know if you've placed any membrane over this bone graft.
No, ma'am, the PRF itself acts as a membrane.
Yeah, that holds the bone graft together. On top of it, did you place any other membrane? Even a PRF membrane?
Yes, ma'am.
Have you placed?
I placed, ma'am.
Okay.
You have basically placed PRF as the membrane, right? So madam is asking, apart from PRF, did you use any other membrane?
No, ma'am.
No. So this was the membrane that you used.
Yes, ma'am.
Okay. I think we'll conclude. Next presenter can start.
Sure, ma'am. Sure, ma'am. Can we go to the next slide? Yes. Can you start the presentation, please?
Ma'am, am I audible, ma'am?
Yes, you're audible. You can proceed.
So, presenting my poster, Regeneration of Peri-implant Bone Defect, a case report with 18 months follow-up. Moving on to the introduction, peri-implantitis is one of the frequent complications associated with implants. There is a lack of unified protocol for successful management of peri-implantitis. Coming to the case presentation, male patient aged 74 years came to the department with a chief complaint of pain and swelling around the implants placed in relation to 3.6 and 3.7. No relevant medical history was noted. Implants were placed in 2017 September, and later crown was placed in January 2018. Radiographic evaluation showed more than 70% bone loss. Deep pockets were also noted with maximum probing depth of 7 mm in respect to distobuccal aspect of 3.6. Attached gingiva was adequate in the region. BOP was bleeding or probing was positive. Below given are the IOPA and OPG at the initial visit in January 2009. Moving on to the case management, non-surgical therapy didn't show any improvement in clinical scenario. So I decided to go for surgical intervention. Before moving on to the surgery, I removed the crown of the implant and healing abutments were placed. Surgical treatment was carried out using Kirkland flap. Soft tissue curettage was done using plastic curettes. Implant surface was detoxified using tetracycline saline slurry with a titanium brush at slow RPM for 4 to 5 minutes. Xenograft was placed in the defect. Since the graft was contained in the defect, no additional membrane was used in this case. It was sutured back to position using 3-0 black braided silk suture. Post-operative healing was uneventful. Crown was reloaded again after 3 months. Revaluation showed significant reduction in probing depth. IOPA at 18 months revaluation is given below. This shows significant bone fill compared to the initial visit. Conclusion, this case report shows successful management of peri-implantitis by detoxification of implant surface using tetracycline saline slurry and regeneration of bone defect with xenograft. Reference for this case was done by, in accordance to the case report, treatment of peri-implantitis with deproteinized bovine bone and tetracycline, a case report authored by Park, published in Gerodontology in the year 2012.
Good presentation. You presented well. The only special thing you have done here is treating the implant surface with tetracycline.
Yes, ma'am.
And the bone fill also is quite good. I can see that in your last photograph, 18th month. So any other methods in treating such a case? This is one.
Detoxification of implant surface can be done by mechanical, like implantoplasty, which make the surface of the implant smoother. So it can be done also by air polishing, by sodium bicarbonate as an abrasive, then by laser, then citric acid, chlorhexidine, etc. can be used for contamination of the detoxification of the implant surface.
Air polishing when the implant is in situ, I don't think you can. Can you do that?
Yeah. No, ma'am. It is susceptible to air emphysema and all.
Yeah,
so it is not recommended.
Yeah, only if it is a before placement, you can do it outside and then place it in the sort of, you can implant it. Okay, Sheila, over to you.
Yeah, before it progressed to peri-implantitis, there must have been mucositis.
Yes, ma'am.
So,
but the patient didn't report at that time. Only when it became worse, only he came to our department to show this one.
So you were not putting him on any SPT protocol?
We have instructed him to follow 6 months follow-up, but he was initially he didn't come 6 months follow-up. When later the this peri-implantitis happened, then he understood the importance. Then thereafter he was maintaining it properly using water pick and floss and all.
Yeah, and what was the reason why the crown was cut?
Ma'am,
the crown was cut into two, no?
It was not cut into the two because the crown was given like that only. The flat contour was.
I thought you mentioned that it was split.
No, I removed the crown before doing the surgical part, because when the load comes, the graft will resorb. So I removed, then I waited for 3 months to take up the graft, and then only I loaded the crown back into.
So the crown was removed?
Just before the surgery.
Okay, fine. So which was the xenograft that you had used?
Here I have used Tios as xenograft of particle size 0.5 to 1.2 mm.
Okay, good presentation. All the best.
Thank you. Thank you.
Yeah, thank you. Could we go to the next presentation, please? Yeah, thank you. Dr. Bhagyashri, Dr. Apurva, who will be presenting. Can you please begin your presentation?
Yes, ma'am.
Yeah.
The case that I'm presenting today is of an indirect sinus lift in the posterior maxilla with simultaneous placement
placement of implant. The question that always arises with an implant is how stable is my implant? So the factors that affect the implant stability could be the density at the site of implant placement, the thread and geometry of the implant, and the osteotomy preparation that is used. So various techniques have been developed to improve the primary stability for in respect to the surgical protocol. In the case report that I'm presenting today, we have used the osteodensification technique. It is a novel biomechanical osteotomy preparation technique which was introduced in the year 2013 by Dr. Salah Huwais, and it was made clinically possible by the DENSA burrs. In this case report, a 61-year-old male patient reported with missing maxillary first molar, and he wanted the replacement of the tooth. So CBCT analysis showed that the bone height was 6.5 millimeters at the site, and the density of the region as indicated by the Hounsfield unit fell in the D3 category. So for placement of implant, an indirect sinus lift was necessary. So the necessary investigations were done and the patient was scheduled for surgery. After administration of local anesthesia, a mid-crestal incision was given and a full thickness mucoperiosteal flap was reflected. After which the implant osteotomy was started using a 1.5 millimeters pilot drill. The drill was drilled up to 1 millimeter short of the sinus floor, after which the densification burrs were used in an anti-clockwise motion with a pumping action. And they were carefully advanced towards the sinus floor. When you reach towards the sinus floor, you can feel the haptic feedback of the dense cortical floor. And after we carefully modulate the pressure and we carefully breach the floor as to prevent the membrane perforation. Once we observe that a drop is felt in the osteotomy preparation, we stop at that level, and further only the diameter is increased as according to the implant that is to be placed. After that, an alloplastic graft material was propelled inside the osteotomy, which was Novabun patti in this case, and the burr, DENSA burr itself is used for propelling the graft inside the osteotomy at a low RPM and without irrigation. After which the implant was tapped at its location, and the resonance frequency analysis showed an ISQ value of 82, after which the cover screws were placed and the implants were submerged for healing. So the conclusion, this technique preserves bone by compaction autografting, improving the peri-implant bone density, and provides adequate sinus augmentation for implant placement with no violation of the sinus membrane. Thank you.
Madam, you have any questions?
I don't actually. Anything you can ask?
You have, what are the other methods of indirect sinus lift?
Yes, ma'am. Other methods could include, ma'am, the osteotome method can be used to lift the sinus floor. Also, the hydraulic lift can be done. This is a method in which the burr is designed in such a way that it, instead of feeding the bone that is extracted during drilling to the suction, it compacts the bone right at the site, giving it an increased density. So as the posterior maxilla is generally deficient in density, so the compaction autografting provides an improved peri-implant bone density. It is the feature of the burr that enhances the primary stability also with this technique, sir.
So what could have been the possible complications?
Possible complications, generally, ma'am, with this, the drill that we have used, it is basically a safe-ended drill, but always there is a danger that can be, that the perforation of the sinus membrane can be encountered. So for that, we need to carefully manipulate when we are reaching towards the sinus floor. And that is the the most commonest complication that can be encountered.
Good presentation. So thank you.
Thank you. Thank you. Could we go to the next presentation, please? Yeah, thank you. Dr. Veena. Dr. Veena. Dr. Veena, are you there? Dr. Veena?
Will we move
Should
to
we
the next person?
should we go to the next presentation, ma'am?
Yes, and give this person a chance later.
Yes, ma'am. Sure, ma'am. Dr. Ashutosh?
Ma'am, I'm Dr. Samruddhi. I'll be.
Okay, yeah, sure. Start with your presentation.
Yes. Today I'll be presenting a case on the management of gingival enlargement in a patient suffering from Dandy-Walker syndrome. Dandy-Walker syndrome is a rare congenital malformation that involves the cerebellum and fourth ventricle. It is characterized by cystic dilatation of the fourth ventricle. It occurs very rarely, 1 in 20 live births, and it is more frequent in females. The predisposing factor for these are exposure to rubella in the first trimester, cytomegalovirus, toxoplasmosis, warfarin, or alcoholism. And the etiology is heterogeneous and familiar occurrences has also been reported. This case is of a 13-year-old female patient who had come with the chief complaint of swollen gums. Then on detailed medical history, it was found that she was suffering from Dandy-Walker syndrome, and she had been diagnosed of it at the age of 4. The symptom of the syndrome typically includes a developmental delay with decreased IQ level and seizures. These seizures were managed by anticonvulsant drugs, and she had been taking a sodium valproate 100 mg twice daily since the age of 6. Thereafter, they started noticing, her parents started noticing the enlargement from the age of 7 and a half. After which it kept on gradually increasing, and they noticed her facial profile being prognathic. So then we first, as you can see in the pre-operative condition, all the 4 quadrants were involved with the gingival enlargement. We had done a thorough scaling and root planing to eliminate any local causes. Then 4 weeks after root scaling and root planing, we planned the gingivectomy, and it was planned quadrant-wise. First, we took the first quadrant from tooth number 1-1 to tooth number 1-6. We had prior to the surgery, we had taken probing depth so that it will be easier, because the patient was a child patient, so it would have been easier later on for her cooperation. And then we marked it with ink, and we gave an external bevel incision with the scalpel, and we contoured it with using electrocautery scalpel. It was easier to remove the bulk of the tissue with scalpel, and then electrocautery was used to give a proper shaping of the interdental area as well. Then 6 months post-operatively, we can see the first quadrant and compare it with the second quadrant as well. Second quadrant was taken exactly after 6 months of the first quadrant. It was similar incision was given, and again for the second quadrant, 6 months post-operative can be seen. I would conclude by saying that due to the complexity of this syndrome, the patient, the individual, they present a distinct clinical presentation, and because of the varied intellectual development, it is challenging for them to maintain the oral hygiene. And this patient, it was difficult for her to even to cooperate while sitting on the dental chair. So just managing the patient on the dental chair successfully under local anesthesia was a task by itself. Thank you.
Have you heard of...
Sorry, you carry on, madam.
Okay. Have you heard of internal bevel gingivectomy?
Yes, ma'am. We had performed it on the palatal aspect in the first quadrant, and because the contour, the thickness palatally was very fibrous, and it was so thick that it was difficult to coapt both the sites. So we had to give internal bevel incision palatally.
Okay, so you've done internal bevel gingivectomy. What are the advantages over external bevel? When is it indicated, internal bevel?
Ma'am, internal bevel, wherever we want to maintain the margin of the gingiva at the place where we don't want it to displace apically. So there internal bevel can be given.
What are the advantages of it?
Advantage that we remove the pocket lining.
You preserve something in that. Never mind. I think Sheila, you can carry on.
Yeah, like how long did you wait? Did you consult with the physician for any change of the anticonvulsant? Because
yes, ma'am.
Yes.
Ma'am, we had sent her parents to the physician who had been giving. So we said that the required dosage of the sodium valproate, it is very suitable for her. And also that he also said that it is very rarely seen, as in articles also they have mentioned that in sodium valproate it has been seen very rarely, and that too at 100 mg twice daily. This concentration was rare. He also suggested that it may be any other local factors, but we also made sure that we removed all the local factors as well.
So how long was it since the patient was on sodium valproate?
Patient was taking that medication since she was 6 or 6.5 years old. And then they started noticing it after 7.5 years of age.
So yeah, is there any other method of controlling this enlargement?
Yes, ma'am. Good oral hygiene could have been maintained, as gingivitis, plaque-induced gingivitis also it is a cause of it causes drug-induced gingivitis. If adequate oral hygiene would have been maintained, maybe this magnitude of enlargement would have not been seen. But also in this syndrome, because the patient has a low decreased IQ level, it was also difficult to explain to the patient to maintain oral hygiene.
You could have managed it under GA.
Yes, ma'am.
You could have managed it under GA.
Yes, ma'am, we could have done it under GA, but because of her systemic condition, it was also, and ma'am, because according to other articles, under local anesthesia also it could have been done. So we did it under local anesthesia. Also, the patient was not as uncooperative as we would have expected her to be, because we had called her for multiple sittings, even for scaling and root planing, and we had an idea that she could have be cooperative for local anesthesia as such.
A stent could have been given also.
Yes, ma'am, stent could also had been given, but because she has a history of seizures, so in that she could have it would have traumatized her, or she would have not be able to use it as well.
Okay, good. So thank you for your presentation.
Thank you so much.
Thank you. Thank you. Could we go to the next presentation, please?
Good evening,
Dr. Namrata. Yeah.
Okay. Am I audible?
Yes, you are. You can continue.
Judges. My topic for poster is plasma cell gingivitis. There are many types of gingival enlargement can be classified according to etiologic factors and pathological changes like inflammatory, drug-induced gingival enlargement, enlargement associated with systemic diseases which are causing gingival enlargement. One of them being plasma cell gingivitis. So plasma cell gingivitis is also referred to atypical gingivitis and plasma cell gingivostomatitis. It is a rare benign condition of gingiva. As the name suggests, it is a diffuse and massive infiltration of plasma cells. This condition was first reported by Kerr et al. In 1981. Teams et al. Has classified plasma cell gingivitis into 3 types. First, due to allergens, second, due to neoplastic origin, and third is due to unknown cause. Now coming to the case report. 2 patients reported to the Department of Periodontics with a chief complaint of growth in gums in upper and lower front teeth region associated with pain and bleeding. Patients initially noticed a small swelling of gingiva, which gradually increased to current size. Past medical history was not significant. Patient also had poor oral hygiene and generalized plaque and calculus. Gingiva had a reddish pink appearance and bleeding on probing was present. OPG revealed no alveolar bone pathologies. Thorough hematological screening was performed for both the patients. We performed incisional biopsy of the lesion under the ALA. Tissue was subjected to histopathological examination, which reported to be the plasma cell gingivitis. In both the cases, non-surgical periodontal therapy, that is thorough scaling and root planing, was performed. Oral hygiene instructions were given to the patient and chemical plaque control measures was followed for 3 to 4 weeks until the inflammation subsided. But even after the stringent elimination of possible allergens and known food which causes the allergy, there was no backsliding of swelling. Hence, we decided to perform the gingivectomy. In these pictures, as we can see, the incision line was marked and the external bevel incision was given using number 15 blade. Particular incision was given using the number 12 blade. These are the pictures, pre and post operative pictures of the patients. We can see the healing was satisfactory and there was the resolution of inflammation in both the cases. So I would like to conclude by saying this case series emphasizes on the need for comprehensive case history taking, hematological examination and allergy testing in order to arrive at correct diagnosis and treatment plan. And gingivectomy followed by good oral hygiene measures is considered to be the definitive treatment in cases which does not respond to conventional non-surgical therapy. Thank you.
What was causing the allergy? Did you find out?
Yeah, ma'am, for first patient, we couldn't find out the cause for the enlargement. But for the second patient, we asked him to get the allergy testing done. And we found out that the patient was allergic to milk and milk products.
Milk and milk products. What was he allergic to?
Milk, ma'am.
Oh.
Mint. M-I-N-T, mint?
Milk.
What are the common causes for plasma cell gingivitis? Some typical ingredients cause allergy very commonly.
Suggests that cinnamon, mint, and all these ingredients which earlier used to present in the herbal toothpaste were the reason. But in these cases, the patient was not using any of those toothpaste or were not allergic to cinnamon or any of those things. We asked him to get the allergy testing done and we could find out that he was allergic to milk.
So that he must be having some other symptoms also if he's allergic to milk because it is consumed regularly. Any other signs?
No, it was shown the allergy testing report, but he said that he doesn't have milk that much.
Oh.
So we couldn't really find out the exact reason for the swelling.
Can plaque be one of the factors for plasma cell gingivitis? Are there reports where plaque has been found to be a cause for the plasma cell gingivitis?
Yes, ma'am. There was a lot of plaque and calculus present in both the patients.
No, I'm asking you, are there reports, case reports, which establish that plaque could be the cause for the plasma cell gingivitis? Have you come across any case reports?
Most of the reports, it has been written that along with the plaque, there is some agents like allergens which are responsible for the etiology of the plasma cell gingivitis.
Fine. Okay.
Okay, thank you. Could we go to the next presentation, please? Yeah, Dr. Santosh.
Ma'am.
Yeah, Dr. Janvi. Yes, you can begin with your presentation.
Yeah. So good evening, everyone. So I'm presenting today on effective additives as minimally invasive alternatives to autologous palatal grafts for root coverage, which is a case series. To start off with a background, so advances in research and patient demands have given rise to need for minimally invasive alternatives for palatal grafts that have been long used in periodontal plastic surgery. So hereby I'm presenting in the case one we have used, it's a 27-year-old female patient with a Miller's class 2 recession where we used citric acid and EMD with a Corian membrane, and it was a coronally advanced flap. So as we can see at the 1 month post-operative, we could achieve about a 90% of root coverage. And coming to the case 2, where there was a Miller's class 3 gingival recessions that we can see here. So at the end of 3 months, we could observe almost about 80 to 90% of complete root coverage by the use of collagen membrane, APRF, and coronally positioning the flap. And in case 3, we have used a Corian membrane again, and we could see the initial papilla that is been not present. And at the 1 month post-operative, there was a good an amount of papilla that is that we observed that there was a gain. So among the 3 cases, the patient satisfaction scores were quite good, and even the gain of width of attached gingival keratinized tissue was good enough, along with the satisfactory root coverage. So I would like to conclude saying that these alternatives, minimally invasive alternatives, form very effective alternatives to that of palatal grafts, which can be painful to the patient. So the future of tissue engineering encompasses these alternatives which are effective for root coverage procedures. Thank you.
Do you think 1 month post-op is very indicative of success in mucogingival surgery?
Ma'am, ideally, no, ma'am. A long-term follow-up should have been, and which I'm still doing it, which I'm still pursuing it at the 2nd and 3rd. At one case, I have included a 3-month post-op, but a long-term follow-up is definitely needed, ma'am.
Yeah, up to 2 years, 2.5 years
Yes,
is the follow-up.
I shall be doing it. Yes, ma'am.
6 months is the minimum, actually. 1 month, you won't do anything.
Yes, ma'am.
So our the success of this hangs in the air.
Yes, ma'am.
Okay.
Another thing, I don't think you should be using minimal invasive alternatives because that's not suited. Okay. Some other title would have been better.
Yes, ma'am.
Because you, I think you should know what is the meaning of minimal invasive.
Yes, ma'am.
Okay.
Yeah.
So, yeah. So I do not agree with the title. Maybe you could have put a better title.
Yes, ma'am. I chose
yes,
this because in our Kerenza's 13th edition, it was now recently in tissue engineering chapter, he's quoted it as to be these alternatives as minimally invasive. So as I, with my experience of one case of free gingival graft, I felt that the patient comfort was much way better. It's not totally minimally invasive that you're talking about. It's only as compared to the palatal grafts only. So the patient morbidity was completely high as compared to the free gingival grafts.
Yeah,
so,
that's what I'm saying. You are talking about an alternative to the palatal graft
only,
so,
yeah.
So yes, so you could have used something else.
Yeah.
And you know, your alternatives were, like you said, Corian membrane, and you can have even amniotic membrane.
Yes,
so yes, and also what is the effect of that citric acid? Do you think citric acid is going to give Any benefit?
Yes, ma'am. Citric acid has found to have a very good effect for regenerative purposes, ma'am, especially. And also it is said to have evidence suggests that there are true regeneration that can happen with citric acid. It can go up to 4 micrometers depth. It can open the tubules, dentinal tubules, and it can enhance the true regeneration that is going to happen.
Do you have any recent articles on it?
Ma'am, yeah, there are systematic, there is one systematic review, and in Perio 2000, volume number 76, it was given, ma'am, about regeneration. And also, ma'am, there is one more article by Papineau et al. It was also given in Perio 2000. So he has critically and reviewed all the available options, and he has stressed upon citric acid and its efficacy, especially in root coverage procedures, ma'am.
Yeah, I think even Dr. Miller has also expressed a doubt on citric acid conditioning.
Yes, ma'am.
Okay, so that's still questionable. So you should have proper studies on it. You have to evaluate on it.
It should have, yes, ma'am. It needs further evaluation. Yes.
Anyway, good.
Yeah,
okay.
Thank you, ma'am.
We go to the next.
Yeah, sure. Thank you. Could we have the next slide? Yes. Dr. Akshara?
Yes, ma'am.
Yeah, please begin with your presentation.
Ma'am, can I start?
Yes, yes.
Respected judges, so my poster top.
Dr. Akshara, we can't hear you.
Hello, ma'am. Am I audible?
Yeah, now you're audible. Dr. Akshara, you lost your voice again. Are you there, Dr. Akshara? Dr. Akshara, are you there? Dr. Akshara? Should we go to the next presentation and get back to her later?
Yeah, I think that's better.
Sure, ma'am. Can we have the next slide, please?
Morning, good morning, everyone. Good afternoon, everyone.
Yeah, good afternoon. You can start with the presentation.
Okay, ma'am. Very good evening to each and every one of you. The topic of my presentation today is on ridge expansion and guided bone regeneration for rehabilitating missing maxillary lateral incisors. Now, coming to the introduction, the implant-supported prosthesis is one of the most preferred options for replacing a missing tooth in both anterior as well as posterior. However, it is common to find alveolar ridge deficiency, especially in such cases which can present a challenge to the dentist in achieving adequate functional and aesthetic results. Now, ridge expansion and guided bone regeneration are modest ways to achieve this goal. They can be used either simultaneously or before implant placement to increase the alveolar width. So simultaneous procedures not only provide adequate bone for implant placement, but also reduce the patient morbidity by decreasing the number of surgeries. Now, in addition, ridge expansion also reduces the risk of cortical plate fracture, which has been reported with ridge split technique, further reducing the complications. Now, as a 19-year-old of such case, a 19-year-old male has reported to the department and reported a bilaterally congenital missing lateral incisors. Now, on examination, there was concavity on the right lateral incisor with buccolingual width of 3.3 millimeter at mid-crest, whereas on the left lateral incisor, there was a buccolingual width of 3.7 at mid-crest. Now, later on, after evaluation on radiographs as well as CBCT and also bone sounding with a bone gauge, we finally decided that we will be inserting an implant of 3.5 by 12 millimeter. And on that, it was placed on the left edentulous space with only ridge expansion alone, while on the right side, which had only a 0.3 millimeter, we required an additional guide by generation of the series of osteotome, and the video was successfully restored with all ceramic crowns. Now, the final osteotome used before placing the implant was 3.0, and care was taken while using an osteotome to pause in between taps. Now, the discussion after the alveolar bone in the maxillary anterior region less dense, making this technique easier and more predictable. Now, osteotomes do not excise bone during the preparation of the bed. Rather, they exert a lateral compression, which increases bone density and results in dense bone interface. Now, time is short and there is no risk of exposure of the membrane or bone graft that could lead to infection, unlike in block grafts or GTR. Use of the osteotome also results in less thermal damage, and expansion of thin labial plate results in a better facial contour. However, this technique can only be applied for horizontal defects and where there is spongy calculus bone is present. Now, in conclusion, implant placement following expansion of narrow.
Sorry, actually, it's time up.
Okay,
Can we
yes,
have the
ma'am.
question answers, please? Ma'am, could you ask questions, please?
Yeah, what are the method? What other methods do you have for the ridge expansion?
We can do a ridge split technique also. It's another technique which we can use, but in that case, there are mostly chances of fracture of the cortical plate. Whereas in compared to this ridge expansion technique where we give like intermittent taps and at the same time waiting for pauses, because of the viscoelastic nature of the bone, it will expand without fracture. Also, ma'am, during these osteotomies, we can like because of the biochemical creep change in the bone over time, it also this is also one advantage for doing this ridge expansion technique.
Now, what GBR did you use?
Ma'am?
You said you used a GBR, right?
Yes, ma'am. Yes. For this case, we have we used a beta TCP, beta tricalcium phosphate, ma'am.
Yeah.
Yeah. In this area, we have used a beta TCP bone graft. Am I audible, ma'am?
Yeah, yeah. Okay. So how long did you follow up this?
Ma'am, actually, because of the lockdown scenario and all, we were not able to really follow the patient. But for this was a case for almost 1 year before the lockdown started.
Good. Madam?
No questions, Sheila. Let me go to the next presenter.
Thank you. Thank you, everyone.
Yeah, thank you. Can we have the next presentation? Yes. Who would be presenting this? Doctor? CRPO 286? Are you here? CRPO 286? Should we go to the next slide then?
Yes, we can. Yeah.
Yeah, because we.
Hello.
Dr. Nair, are you here? Yes.
Yeah. Can I start, ma'am?
Yes, you can start.
Yeah. Good evening, everyone. My case report is on linear gingival erythema in a patient with a history of COVID-19. Coming to the introduction, so COVID-19 is caused by the SARS-CoV-2 virus, which is a single-stranded RNA virus, and COVID-19 has been declared as a pandemic by the WHO. Recently, we have detected few oral lesions that have been associated with the virus. Some of the oral lesions are aphthous ulcers, herpetiform ulcers, white and red plaque lesions. With that, coming to the patient details, a 42-year-old female patient reported to our department with a chief complaint of generalized irritation and burning sensation in her gums since 10 to 15 days. She also complained of bleeding on brushing. And she complained that the irritation increased on consuming food. On on recording a detailed patient history, the patient reported to be COVID positive in the month of May, which was 3 months prior to her dental visit. She was hospitalized for the same, and she also underwent the treatment and took the drug regimen as per the protocol. She reported of no other relevant history. On examination, it was seen that the patient's oral hygiene was fair and the gingiva had a linear band of erythema involving the marginal gingiva, and it was generalized. The patient was then advised a laboratory testing, which included the hematological testing as well as ELISA. The patient was recalled 1 day later, and she underwent scaling, and a 3 millimeter punch biopsy was done. The tissue involving the marginal and attached gingiva was taken from the premolar region, and the patient was prescribed chlorhexidine mouthwash for 2 weeks. The patient was then reevaluated in the second visit, where the patient reported of reduced irritation. The patient then, in the third visit, when recalled and reevaluated, the patient reported that her chief complaint had completely subsided, and it was also observed that there was reduced erythema in certain areas of the gingiva. The biopsy results showed fibrocollagenous tissue focally lined by stratified squamous epithelium, denudation of the lining epithelium, papillary changes, moderate subepithelial infiltrate, lymphocytes, plasma cells, and few neutrophils. And this confirms the diagnosis of non-plaque induced gingivitis. So coming to the conclusion, to the best of my knowledge, this is the first reported case of linear gingival erythema in a patient with a history of COVID-19. And though these oral lesions cannot be associated with as a direct manifestation of COVID-19, it can be due to the immunocompromised state of the patient. Thank you.
What are the other causes of linear gingival erythema?
Yes, ma'am. The differential diagnosis can be HIV associated or even herpetic gingivitis, ma'am.
So was that ruled out?
Yes, ma'am. We had done ELISA, ma'am, and the tests were negative, ma'am, for HIV.
So how long after the patient was infected with COVID was this noticed?
Ma'am, 3 months after, ma'am.
Okay. 3 months after. Was
Yes,
there plaque and local factors were there?
Ma'am, her oral hygiene was fair, ma'am. So the initial visit, according to the indices, her oral, it was fair, ma'am.
I'm not very sure if you can directly relate it to COVID.
No, ma'am. It can be a secondary manifestation, ma'am, because of the decrease in the generalized systemic health of the patient as well as the treatment, ma'am, because she has had various antibiotics, ma'am, antiviral and also steroids, ma'am.
No direct relation, but anything with COVID is novel. Okay. Sheila, any questions you can ask? Questions?
Yeah, that's the same thing that I also would like to say, because it's difficult to definitely, you could have done some PCR tests and things like that.
Okay.
And yeah, and what precautions did you take when you treated this patient? How long after this, what is the ideal time for you to treat the patient after COVID?
Okay, ma'am. Ma'am, the patient tested positive 3 months prior. So 1 to 2 months is the ideal time for the treatment, ma'am, for dental treatment to.
Ideal time for treatment?
Yes, ma'am. As per one of the articles, ma'am, the ideal time for dental treatment, ma'am, after a patient has tested positive for COVID is 1 to 2 months, ma'am.
After infection?
After infection, yes, ma'am.
Which article is this? Which
ma'am, I don't have that. I've not.
I think 1 month is too soon.
Okay.
And yeah, so did you get any retesting done before you started?
Yes, ma'am. Her RT-PCR was negative, ma'am. So before the testing, we had a 1 week prior, we had done the test, ma'am, for RT-PCR. Before the treatment, ma'am, sorry, before the treatment, we had done RT-PCR, ma'am. So that was negative.
So you have any idea like how long back was the scaling done for her?
Before she tested positive, is it, ma'am?
Yeah. No,
Ma'am,
what I meant, before she developed all this, did she have any recent scaling done? Because you said the oral hygiene was quite good.
no, ma'am, she hadn't undergone scaling in the recent past.
Fine. Okay. Fine.
Okay.
Thank you. Could you go to the next presentation, please?
Am I audible?
Yes, you're audible.
Very good evening to everyone present here. My poster presentation is a case report of mucormycosis, an alarming sign for periodontitis in COVID recovered patients. So as we all know, the globe is facing a crisis with the coronavirus pandemic, and it's putting a very heavy toll on the health of people all over the world. So this virus is constantly mutating, and with day to day, with each passing day, it is exhibiting various complications. And one such complication is mucormycosis in even COVID recovered patients. So mucormycosis is a fast potentially lethal angioinvasive fungal infection that is caused by filamentous fungi from the class Zygomycetes and order Mucorales. So it is very important to understand the pathogenesis, spread, and the treatment of COVID-19. So in our case report, a 33-year-old female had reported to our department with a complaint of swelling in the gums on the right side of the upper jaw since 3 weeks. So she had a history of COVID-19 infection 3 weeks back. She was hospitalized for a period of 10 days. And during that period of hospitalization, she was given injection dexamethasone and injection remdesivir. And after her discharge, after about a week, she began experiencing swelling and pain on the right side of her gums, on the upper jaw. So she reported to the department, and on clinical examination, what we could see was there were multiple abscesses with respect on the buccal as well as the palatal aspect with respect to the teeth in the first quadrant, and there were probing depths were deeper than 10 mm. So we advised intraoral periapical radiographs, and in that it was evident that there was no apparent bone loss. There was also segmental mobility with respect to the teeth in the first quadrant. So since there was no bone loss, and with her history of COVID-19 infection and all these signs and symptoms, we advised a CT, and in the CT it was seen that there was irregular osteolytic area in the right alveolar ridge and the floor of the maxillary sinus. So in order to confirm the diagnosis of mucormycosis, we took pus samples from the draining sinus and we sent it for fungal culture. And after histopathologic examination, it was seen that there were presence of non-septate hyphae. So this brought us to the conclusion of mucormycosis of the right maxillary sinus and alveolar ridge. We referred her to the Department of Oral Surgery and maxillofacial surgery, and with collaborating with them, we performed a maxillectomy of the right maxillary sinus as well as the alveolar ridge, and the patient was given an interim obturator, and a final obturator, permanent obturator will be given after the healing is completed. So coming to the conclusion, it is extremely important that we as periodontists identify such signs and symptoms in this COVID era. So after COVID, if patients are exhibiting atypical periodontitis features, so it is very important that we diagnose these, and early diagnosis so will help us in treating the patient early, and it will reduce the morbidity and the mortality rate. Thank you.
It's a nice case. Were any antifungals given to her?
Yes, ma'am. Systemic antifungals, amphotericin B was given. Injection.
What was the dosage?
Ma'am, it was 5 mg per kg per day. A single injection, single dose per day.
Okay, Sheila, you can go on with the questions.
It's a good presentation.
Thank you, ma'am.
And a good case. Yeah. How is the? Yeah. So the patient now you have given an obturator, or you're waiting for it.
Ma'am, an interim obturator was given just after surgery, so we are waiting for the healing to be completed so that we can give a final obturator.
Okay. So basically, the treatment was done by surgeons, oral surgery.
Yes, ma'am. What we
So
did was it helped we could diagnose the case, ma'am.
yeah, your main part was to diagnose the case.
Yes, ma'am.
And yeah, so that's good. Good presentation.
Thank you, ma'am.
So we can move to the next.
Sure, ma'am. Thank you. Could we have the next slide, please? Could we have the next presentation, please? Yeah, thank you. Who will be presenting CRPO 289?
Am I audible, ma'am?
Yes, you are audible.
Good evening, ma'am. Topic of my poster is a novel approach for the treatment of intra-bony defect with PRF membrane, and it is a case report. So this is a case report of 28 years old male patient visited our department of periodontology with the chief complaint of bleeding and pus discharge from lower front tooth region since 1 month. And as we can see in the our first picture of patient having periodontal abscess in relation to 4.2 and 4.3, and patient having 8 mm probing depth pre-operatively, and this is the pre-operative radiograph in which we can see a intra-bony defect in relation to 4.2 and 4.3. After giving local anesthesia, circular incision was given using a 15 number of blade, and then we reflective flap and debridement of the site of the was done by the curates, and then placement of the PRF membrane in the defect, and then sutures are taken, and this is the post-operative 7 days follow, and this is the post-operative 3 months follow, in which we can see a 4 mm pocket depth reduction was seen, and in the 3 mm radiographic a follow-up, a significant bone fill was present. So, I would like to conclude that the use of PRF improve clinical and radiographic parameters in this type of intra-bony defects after the 3 months, and the use of PRF with various biomolecules such as metformin, antibiotics, bisphosphonate, and statins may improve the clinical outcome of the this type of defect, and these are the references.
You take a radiograph at 3-month interval?
Yeah, ma'am.
I don't think so. It is not 6 months is minimum where you can see a bone formation. 3 months is too early to see any, or radiographically if there is any bone formed or not.
Yeah, ma'am.
Minimum time limit to take a post-op X-ray is 6, and of course, as you go further, it is better. 1 year, 1.5 years, like that. 3 is too early, I think. You just placed PRF in the defect, isn't it? Nothing, just PRF.
Yeah, ma'am. I was just doing the open flap debridement and placing a PRF in the defect.
Just PRF, yeah. So, do you think it has the dimensional stability to stay there and hold the space? When does it reabsorb? What is the longevity of a PRF? How long will it be present there? When will it reabsorb? I think it's a very short-lived PRF. So you usually mix it with something sticky bone or any other graft and things like that. That would have been better. This is a very simple thing. You have done nothing novel in this. Okay, Sheila, you can continue with the questions.
You were saying an intra-bony defect, but it is looking more of a horizontal defect. And also, is there any caries with the central incisors?
Yeah, I'm a patient having like a small internal resorption on in that area. But clinically, our caries are not present, ma'am.
So what was your reason for using PRF? You could have There are so many other alternatives. What made you to go for PRF?
Because it can enhance PRF, enhance the soft tissue and the bone tissue healing, and in PRF, presence of natural fibrin network which protect the growth factor into that particular site, and it favors the development of the microvascularization, which can lead to a better cell migration to that particular area.
Okay, you need a longer follow-up because like Madam said, within 3 months, you just start seeing some difference, but the exact more differences are seen at 6 months and 12 months. So 3 months is actually a short period for you to evaluate. You may see some changes, but you cannot say that that is, do you say it's a bone fill or do you say it is what do you say? Can you conclude that it's a bone fill? And how do you make out whether it is a bone fill or a regeneration, or is it a repair that has taken place? How can you come to a conclusion? Okay, so be careful when you're selecting your cases. Okay, so, and yeah, that's what, there are so many alternatives that are there. So since you will have still some more time, I hope you will select some better cases. Okay, and try it out and follow up the case for a longer period. Then only you will come to know. Okay, yeah.
And we can use a sticky bone as well.
Yeah, you can use a sticky bone also.
But patient not afford any bone graft for like that. So we are using only PRF membrane.
No, in that case, you can use even autogenous bone graft, scrapings. Yeah. So if patient, then they're very cheap bone grafts also available.
Yeah.
So yeah, you can best is autogenous bone graft, which you can take by the scraping of the thing. So you can mix that with the IPRF and or any other.
Yeah.
Anyway, all the best.
Thank you.
So we'll go to the next.
Thank you, ma'am. Can we go to the next presentation, please? Dr. Bikram?
Am I audible?
Yes, you're audible. You can begin with your presentation.
Thank you, ma'am. Good evening, everyone. Today I'm presenting my poster on a case report that is socket preservation using GBR with advanced platelet-rich fibrin and modified cross mattress. Now, to begin with, post-extraction crestal bone resorption is a common phenomenon and is unavoidable and can lead to significant ridge dimensional changes. So here, GBR comes into play and is one such technique for ridge augmentation, which correct horizontal and vertical adverse bone defect using membranes to cover osseous wound space from the ingrowth of undesirable soft tissue. Now, over the period of time, socket preservation using biomaterials and autologous platelet concentrations, including PRF, have been employed. Now, this PRF is a second-generation autologous growth factor, which encourages healing and is associated with effective and early organization of bone substance and bone volume percentage. Now, moving on to the case report, a 55-year-old patient reported with the chief complaint of pain in the lower left back tooth region. Following clinical examination, TOP was present in respect to 3.3 and 3.4, and further radiographic evaluation revealed periapical pathology, as can be seen in the pre-op IOPA and figure 1. And considerable bone loss was also noticed. Now, proceeding to the surgical procedure, atraumatic extraction of 3.4 was carried out under LA, which is followed by soft tissue flap elevation, and the design chosen was a conventional Kirkland flap. This was followed by debridement of the socket. The preparation of the APRF was carried by drawing 5 ml autologous blood and centrifuging it at 2,500 RPM for 5 minutes. Now, the APRF was then separated and then placed between 2 glass slabs to prepare the APRF membrane. Now, following this, placement of HA graft was carried out along with placement of APRF membrane. And this was continued with adaptation of barrier membrane, which was periocle. Now, closure of the area was done using modified cross mattress, which is also known as the hidden X suture. Now, the patient was recalled for suture removal after 7 days. Following this, patient was recalled for radiographic evaluation at 3 months, which showed adequate amount of bone formation. Now, to conclude, APRF appears to be an ideal provider of autologous cells, creating a synergistic relationship in the interest of tissue regeneration. And the use of modified cross mattress successfully served the grafted material and secured it, and also caused minimal retraction of buccal tissue, which led to progressive results. Thank you.
What is the machine that you used for the APRF?
Ma'am, it was a centrifugal machine itself from the department.
Yeah, but what was the name of that machine?
Sorry, ma'am, actually, I won't.
Can you get APRF with all the normal centrifuges?
No, ma'am. I have limited idea on that, ma'am.
Yeah, what was the reason why you preferred to go for APRF and not PRF? What was the advantage of using APRF over other modifications of PRF?
Ma'am, APRF, firstly, ma'am, because ma'am, APRF was chosen over ma'am normal PRF because of ma'am the higher growth factors that is released over the sustain on a slowly period of time, over a sustained period of time of like 4 weeks, ma'am. And it was like it also provided a much better microvascularization to the area. So more so APRF was used.
No, I think you know all the generations of PRF.
Yeah, ma'am, there is the IPRF, then there's the APRF, then APRF plus, then there is also ma'am CPRF.
Deepika, madam.
No questions, no questions.
Okay, thank you.
Thank
Can we go to the next presentation, please? Yeah, thank you. Dr. Pariya, right? CRPO 291. Who will be presenting this? Dr. Pariya. CRPO 291. Are you there? Should we go further? Then we can get back to this post.
Yeah, we'll go further.
Yeah, thank you.
Good evening, ma'am. Good evening, judges. My topic for case report is I used autogenous tooth graft in the treatment of infrabony defects. So initially, I would like to introduce why the kind of defect I've selected. It's in intrabony, basically. Earlier, it was said that it was 1, 2, 3. All the wall defects were intrabony defects. But then by Weinberg and Escott 2000 classification, only 3 walled defects were included in intrabony. So all the bone grafts that are available, autogenous bone graft is said to be the gold standard because it exhibits all the 3 ideal properties of osteogenesis, induction, and osteoconduction, but it has its own limitations, like the harvest amount is limited, and there is bone resorption after graft is placed, and then the donor, the second defect is generated in the donor site area. So to overcome these shortcomings, other bone grafts came into light, but then they also have allogenic xenograft. They also had their own limitations. So the need for a newer ideal bone graft was there. So in 1993, autogenous tooth graft was developed and first used to conduct experimental studies. And first human study was done in 2000. by Kim et al. In 2000 were developed, and then autogenous tooth graft was said to be an ideal bone graft and compared to the autogenous bone graft because it has a chemical resemblance, or the tooth has the chemical resemblance with alveolar bone, and many clinical and histological studies have proved the same. And it is rich in bone growth factors and BMPs, and biocompatibility is very high. So coming to the case report, a 40-year-old male patient visited to the department with a chief complaint of mobile teeth and difficulty in chewing in the left back tooth region. So on clinical examination, it was grade 3 mobile with Miller's class 4 recession with respect to 2.6 was observed. And the probing depths were more than 6 mm in the third quadrant. So we raised the flap with respect to 3.5, 3.6, 3.7, and 3.8. And there was 3 mm intrabony defect with respect to distal to 3.6, and distal to 3.7, there was a circumferential defect of 5 mm. So we prepared the autogenous tooth graft after extracting 2.6, and then placed and prepared the tooth graft chair side, and then we placed it into the defect area and sutured it. This is post-op 6 months. So at the baseline, the defect over the radiographic, the baseline view is this, and then after 6 months, this is after the placement of tooth graft, post-op 2 weeks, and this
Madam,
is after.
your time is over. Could we start with the question answer sessions, ma'am?
Yes, ma'am. Yes, ma'am.
What was the autogenous bone graft? How was it placed, prepared?
Ma'am, autogenous tooth graft, we extracted the tooth and we separated the crown from the root, and then the root was the outer layer was we removed the outer layer with the burr, using the burr, and then we made hole into the root area so that it became the structure could be weakened, and then with the help of the bone mill we crushed the root, and then we prepared the bone. And then after this we got the particles, we washed it in 20% ethanol with 0.1 normal sodium hydroxide for 5 minutes, and then we used PBS, that is phosphate buffer solution, for 1 minute to wash the bone particles, and then we washed again for 1 minute with PBS to for further cleansing of the bone particles, and then we placed it into the defect area.
You didn't have any so basically use the mortar and pestle, or did you use any did you have any equipment like the smart tendon grinder? You've heard of smart tendon grinder? Did you use that?
Yes, ma'am, I've heard of it, but then we only had the bone mill in our department. So we used the bone mill to crush the root structure.
So what was the particle size?
Ma'am, we couldn't actually measure the particle size with the estimation only. We made the small bone particles, and then we placed into that area.
But what would have been the ideal particle size? Because,
ma'am,
for how long did you evaluate this?
Ma'am, particle size, the recommended size is between 500 to 1000 mm, and we evaluated after 6 months.
You evaluated it for 6 months?
Yes, ma'am.
6 months is too soon.
Yes, ma'am.
Probably it has to go ahead for 1 year, 1.5 years. The minimum is 6 actually, but preferably 1 year plus. So there was no standardization of the particle size.
Yes, ma'am.
Any did the patient come up with any adverse reactions or anything like that, or it was all well healed?
Ma'am, it was all well healed. Patient was not maintaining that area in between 3.7 and 3.8. That's why the pocket remained at 5 mm only. Otherwise, there was no other reaction, adverse reaction.
So you removed the outermost portion of the root, isn't it?
Yes, ma'am. Yes, ma'am.
What is the rationale behind that? Why did you do that?
Ma'am, we are basically exposing the dentine so that we can expose the BMPs and growth factors in the organic content. Basically, we need more organic content.
Okay, so this patient also had to have a tooth which had to be extracted.
Yes, ma'am. It was 2.6, ma'am. This
Periodontal involved 2.6.
Yes, ma'am. It was class 4 Miller's recession was there, and it was mobile, grade 3 mobile, and there was no caries and no other.
There is also a study, isn't it? A periodontally involved tooth, when it was tested in vitro, there were still toxins. So I was wondering, that would have been one more reason for you to remove the outer layers. That would have helped that also.
Yes, ma'am. We remove the debris. That's why we wash it in ethanol and sodium hydroxide. Yes, ma'am.
What about the pulp? What about the pulp?
Ma'am, since ma'am, the tooth was almost non-vital when we removed, because it was grade 3 mobile also. So it was
non-vital will have more problems. So toxins from inside also would have gone into the dental tubules. Probably it was vital, and you
Yes,
not
sir.
sort of thought of the pulp, I think.
Yes, ma'am. But when we put the holes, we try to clear the canal area also.
Yeah, and also
Are
it
you
goes.
aware of any Indian studies? The original study was done in Korea, right?
Yes, ma'am. Yes, ma'am. By Kim et al.
Yeah.
Yes, ma'am.
So even they had, do we have a tooth bank?
Ma'am, ma'am, I have no idea about that. I'll search about it.
Okay, fine.
Thank you, ma'am.
You know why we are asking so many questions? We have a smart dentin grinder in our department. And has happened on this. So we are all very well aware. Okay. And your font size is too small, man. Next time, bigger font size and lesser matter should be there. So it's easily readable.
Yes,
ma'am. Okay, then. All the best.
Thank you. Can we go to the next slide, please? Dr. Neha? Dr. Neha?
Yes, ma'am.
Yes, can you begin? Yeah, can you begin your presentation?
Stop sharing. Actually, previous participant has not stopped the
No, your screen is visible. We can see your poster here.
Okay, ma'am. Should I start?
Yeah. Just on your camera and start your presentation.
Yes. Good evening, ma'am, and good evening, everyone. My case report is on the treatment of gingival recession using APRF, IPRF, and DFDBA. In the introduction part, various techniques have been reported in the literature for the reconstruction of gingival recession defects. PRF has been described as an autologous membrane source of growth factors like vascular endothelial growth factors, platelet-derived growth factors associated with soft tissue regeneration processes. APRF is a second generation platelet concentrate obtained using lower G forces that clinically translate in an increased concentration of growth factors and neoangiogenic potential. Injectable APRF is a platelet concentrate in the liquid form that can be polymerized with bone graft, and DFDBA is an allograft that possesses osteoinductive and osteoconductive properties, and it has the potential for osteoinduction due to increased expression of bone morphogenic proteins. So coming on to the case report, a 30-year female reported to the Department of Periodontology with the chief complaint of sensitivity in the lower right back tooth region since 6 months. On detailed examination of mandibular right premolar,
presented with Miller's class 1 gingival recession, in which the recession depth is more than or equal to 2 mm with the thin gingival phenotype that is less than 1 mm. So the aim of the case report is to evaluate clinically the efficacy of composite mixture of APRF, IPRF and DFDBA using coronally advanced flap technique in gingival recession defects. So the method we used in this, the patient first evaluated after phase 1 therapy, following which the recession defects were treated with the mixture of APRF, IPRF and DFDBA along with coronally advanced flap, and then after that, probing depth, recession depth and clinical attachment level, keratinized tissue width and gingival thickness was done. Evaluation was done at baseline 3 months and 6 months. So these are the clinical photographs. In this, the preoperative recession depth with respect to 4.4 and 4.5, that is 2 mm, and then keratinized tissue width is taken, in which the keratinized tissue width in relation to 4.4 it is 2 mm and 4.5 it is 3 mm. After that, gingival thickness was taken, that is less than 1 mm. In this, we have used the gingival recession coverage technique by Pini-Preto et al. In this, first we have given the horizontal incision at the cemento-enamel junction, and then the vertical incision is given. After that, full thickness flap is raised, and then at the 3 to 4 mm below the recession depth, the partial thickness flap is raised, and then the composite mixture of APRF and IPRF and DFDBA is placed at the recession defect, and then 4.0 sutures were given and Copac dressing was given. This photograph is of the post-operative 1 week photograph, and then post-operative the 3 months.
Ma'am, your time is up.
And
could we start
6
with the
months.
question and answer session, please? Ma'am, could we start with the questions?
The follow-up was for how long?
Ma'am, it is 6-month follow-up is there.
Fine. So couldn't the presentation was a bit too fast. Basically, you concluded that composite mixture of A and IPRF and
Yes, ma'am. Combined mixture of APRF and IPRF, ma'am, like a sticky bone.
Effectively used method in the treatment of gingival recession defects.
Yes.
This sort of a membrane was covered by flap, isn't it?
No, ma'am. I prepared the mixture like a sticky bone and then covered the defect with the flap.
Okay, this membrane was covered by flap?
Yes, ma'am.
It has to be, yeah. So you did coronally advance it?
Yes, ma'am. Coronally advanced flap.
Could you have used a minimal invasive technique? Have you heard of gumdrop?
Ma'am,
Vista technique?
Yes, ma'am. We can use in this defect, this type of defect. We can use this technique, but because of the technique, because this techniques of combined mixture of bone graft have not so much used, and I have not seen many articles like this. So and sticky bone mixture, ma'am, in intrabony defects they have given the good result, and it provide the stability to the graft materials. That's why I have used this mixture in the that recession defect. And it also gave at the 6 month, it gives a good result. And the
Yeah, I agree that you would have got a good result, but it would have been better if you used a more minimal invasive technique.
Yes, ma'am.
That would have been better. Okay. So, yeah, a good presentation.
Thank
you. I think we can go to the next.
Yes, ma'am. Could we have the next presentation? Yes. Dr. Vikram? Dr. Vikram? Are you here? Dr. Vikram? Dr. Vikram? Should we go to the next presentation, ma'am?
Please do. Yeah.
Dr. Swati?
Yes, ma'am. Am I
Yeah,
audible?
could you? Yes, you're audible. You can start your presentation.
Good evening, one and all. So the topic for my case report is peripheral ossifying fibroma. So coming to the introduction, reactive gingival enlargements frequently occur in the oral cavity, and these lesions mainly include the peripheral giant cell granuloma, the pyogenic granuloma, the traumatic fibromas, and the peripheral ossifying fibroma as a result of irritants such as trauma, microorganism, the plaque, or the restorations and dental appliance. Among these lesions, the peripheral ossifying fibroma is an infrequently occurring outgrowth of the interdental papilla, which is focal. And these are reactive and non-neoplastic and tumor-like lesions. So coming to the case report, a 45-year-old male patient visited the department with the chief complaint of swelling that had gradually increased in size the past 1 year and had no medical history. So on intraoral examination, it appeared to be a solitary pedunculated outgrowth, which was seen on the marginal gingiva and the interdental papilla in relation to 3.2 and 3.3. So it measured around 4 centimeters and 6 centimeters of hypoocclusion. On palpation, it was painful and non-tender, and it was forming consistently, and it was bleeding occasionally, or when it was traumatized with a toothbrush. So radiographically, there was no significant bony changes were seen, and coming to the treatment aspect, the area of interest was anesthetized. Following the lesion was excised by using electrocautery, and the periodontal dressing was applied. And then microscopically, it revealed fibrocellular connective tissue interspersed with fibroblast. And there was evidence of scattered basophilic calcifications in the hypercellular fibroblastic stroma, which was a diagnostic of peripheral ossifying fibroma. And the healing was adequate, 3 months. And however, after a year, there was a recurrence of the lesion at the same site. And so this time the lesion was excised by making use of a surgical excision, which was carried out in the region of 3.2 and 3.3 under anesthesia. And also debridement was also done by elevation of the mucoperiosteal flap, and curettage was also done to prevent any further recurrence of the lesion. So by the 6th month of follow-up, it showed a normal healing area. So to conclude, the peripheral ossifying fibroma, it appears to be as one of the common solitary swelling in the oral cavity, which can be clinically be misdiagnosed with other clinically appearing lesions such as pyogenic granuloma. So therefore, thorough radiological and histological examinations are required for the confirmation of its diagnosis, and surgical interventions are employed in order to eliminate the etiological factors. Thank you.
What stopped the recurrence the second time? What did you do differently the second time?
Ma'am, the second time when I made use of a surgical excision, I tried to remove as much of as even the periosteum and also the PDL. So
you have to excise up to the periosteum. Only then it will not recur.
Yes, ma'am.
Okay. Fine. It's a simple report, case report, nevertheless, okay. Sheila, you can ask questions.
No, that's fine. You can go on to the next.
Thank you, ma'am.
Sure. Thank you, ma'am. Could we have the next presentation, please?
Shall I start, ma'am?
Yes, you can take it. Sure.
Good evening, everyone. So my title for today's poster presentation is Tunneling Technique in Combination with PRF for Miller's Class 3 Recession. So in this case report, a female patient with age of 35 years old, she had reported to the Department of Periodontology with a chief complaint of sensitivity in the lower front region pertaining to the front region of the jaw. On diagnosis, it was diagnosed that she had Miller's Class 3 recession.
Is anyone else apart from Dr. Chaitrali on unmute? There's some disturbance. Yeah, you can continue. Dr. Chaitrali, you can continue. Dr. Chaitrali?
Hello.
Yeah, you can continue.
Yeah, sorry, ma'am. So there was Miller's class 3 recession, which was seen in respect to 4.1, 3.1 and 3.2. The technique that was suggested for the recession coverage was of tunneling technique that we had suggested for the case. So a tunnel was prepared with respect to 4.1, 3.1 and 3.2 from the most distal aspect of 4.1 to the distal aspect of 3.2. After the complete preparation of tunnel using the tunneling instruments, the PRF insertion was done. After the first PRF insertion, we had gone for a second PRF insertion until we got the fullness of the tissue. After we got the fullness of the tissue, we had placed suspensory sutures using composite stops on with respect to 4.1, 3.1 and 3.2 to coronally advance the tissue. After advancement of the tissue, there was vestibuloplasty which was done to relieve the tension over the flap. Post releasing of the releasing of the tension over the flap, we had placed Cura spawn over the surgical site. After that, we had done a follow-up for the first day, 14th day, 1 month, 3 months, and 6 months. So in the first month follow-up, we had seen a comparable recession coverage, but at a 6 months follow-up, we had seen a considerable recession coverage with respect to 4.1, 3.1, and 3.2. So tunneling technique can be an alternative option for recession coverage with respect to Miller's class 3 recession is what we concluded by this case report that we had done. Thank you.
What was the suturing technique used?
Ma'am, we had used 40 Mercer suture and only suspensory sutures were given.
What is Curaspan? Some sort of a sponge, is it?
Ma'am, Curaspan is basically a porcine-derived gelatin gel, which is formed as it comes as a gelatin sponge that we see. It is basically from Netherlands, and it is absorbable. It cannot be dissolved in water, but it has got absorbing qualities. And when you apply it on the wound, it sucks up, and then there is increased healing effect which is seen, and also the the thrombocytic activity is increased. So therefore the healing and the repair is also initiated faster, and a better outcome was seen, ma'am.
Where are the X-rays for the, sorry, because it's a class 3 recession. So
yes,
in
ma'am.
class 3 recession,
Sorry, ma'am.
what about the, yeah,
yes, ma'am. Sorry that I did not include the RVG in this, but we termed it as class 3 because interdental bone loss was also seen, and also there was malpositioning of the lower anteriors when we saw it occlusally as well as in occlusion. So that is the reason we termed it as a class 3 recession.
Yeah, that's what, because we would have liked to see the X-rays pre and post, and just by this.
Yes, ma'am. Actually, I do have a radiographic evidence, but did not add it into the poster. Sorry for that inconvenience from my side.
It would have been good if you had added it. Yeah,
sorry,
madam.
ma'am. Thank you.
Okay,
Madam?
we'll move to the next one, next poster.
Can you go to the next poster? Yeah, Dr. Swati, Dr. Soma.
Yes, ma'am.
Yeah.
Can I start my presentation, ma'am?
Yes, you can start.
Yeah. Good evening, everyone. I am here to present my case report on the topic orodental manifestations in a rare syndrome, that is Lawrence-Boone-Barrett-Biddle syndrome, also as a LMBB syndrome. Lawrence-Boone-Barrett-Biddle syndrome is a rare monogenic autosomal recessive ciliopathy with the different clinical symptoms and genetic variations.
It was first described by George Bardet and Arthur Biddle, and it is an autosomal recessive condition. Explaining the features of the syndrome, the primary features includes rod cone dystrophy, polydactyly, obesity, learning disabilities, hypogonadism, and renal abnormalities. And the secondary features includes brachydactyly or syndactyly, speech delay, ataxia, anosmia or hyposmia, dental anomalies like crowding, high-arched palate, hypodontia, small tooth roots, and medical conditions like cardiopathy, diabetes mellitus, and deafness. Coming on to the case report, a 16-year-old female patient reported to the Department of Periodontology with the chief complaint of pain in the left and right lower back jaw region of the jaw. When the medical history was asked from the patient was found to be apparently normal until 6 years of age. But after that, after 6 years, the patient started to get a slight visual impairment, and it was at that time the patient was diagnosed with Lawrence Moon-Bardet-Biddle syndrome. But the family neglected the condition initially. But then at the age of around 10 years, the patient, there was a drastic weight gain in the patient, developing obesity. And after that, the patient was taken good care of the patient, of the parents. Then patient's mother gave the history of consanguineous marriage between the parents. And she also gave the history that the patient had gained puberty, and she exerted dyspnea on exertion. On extraoral examination revealed that the patient had exophthalmos, hypertelorism, flat nasal bridge, convex profile, micrognathia, and potentially competent lips. Digital OPG was taken for the patient. In the OPG, it was found that the molars exhibited taurodontism, and there was a cariously distracted retained deciduous teeth with 6 in the second quadrant, and there was found to be 3 missing teeth in relation to 2.2, 2.5, and 3.2. Then the intraoral findings, poor oral hygiene was exhibited by the patient, and there was unilateral chewing habit by the patient. Then microdontia, hypodontia, taurodontism, and high-arched palate. These are all classical features of Lawrence Moon-Bardet-Biddle syndrome. Then crowding and proclination of maxillary anteriors was there. There was crossbite with 1.5 and retained deciduous with 6.5. Then gingival enlargement involving the third quadrant and palatal gingiva was also seen. The treatment plan formulated for the patient was thorough phase 1 therapy should be performed. Then the extraction of the carious over retained deciduous 6.5 should be removed. Then gingivectomy for the correction of gingival enlargement can be planned. And finally, the orthodontic correction and management for crowding, proclination, and deep bite can be performed. To conclude, this syndrome requires...
Time up. Yeah, it's time up. Should we go to the proceed with the question and answer session?
Yes.
Ma'am, could we ask question?
Yeah. What was even though this is a syndrome, her chief complaint was pain in the left and right lower back tooth region. So what was the cause for that?
Yes, ma'am. It was like the premolars were erupting, ma'am. She was having eruption pain actually in both the third and the fourth quadrant.
Okay. And could the occlusion have also, there is a disturbance in the occlusion.
Yes, ma'am.
So could that also have contributed to the pain?
Yes, ma'am, that was there. But in the premolars, we can see the flap covering, like the operculum was covering the tooth, and but the tooth was erupting normally, as the we can see that in OPG.
Okay. So this is basically, you had, and you need an interdisciplinary treatment for this.
Yes, ma'am.
Yeah. So yeah, good. It's a very good case report. It's nice.
Thank
you. Yeah, madam.
No questions. No questions.
Thank you.
Thank you. Could we go to the next slide? Dr. Pooja? Dr. Pooja?
Yes, ma'am.
Yeah, could you start your presentation?
Good evening, ma'am. My topic today is comparative results of frenectomy by different surgical technique, a case series. An aesthetic smile is a prime concern of the people nowadays. Smile designing gets more focused to achieve this. Patient with midline diastema visit the dentist to demand its closure to achieve a pleasing smile. maxillary label frenum is capable of creating a diastema and recession affecting the aesthetics. In addition to that, high frenum also hinders the oral hygiene maintenance. Apparent frenal attachment is a common problem in the general population. We can test for frenal attachment by Blanch test and the tension test. The aim is the present case series was attempted to evaluate the difference in the post-operative pain by using the VAS scale at 24 hours and 7th day of the frenectomy by using different surgical techniques. The case 1 was done with the conventional technique, the case 2 was done with the electrocautery, the case 3 was done with the laser, case 4 with the Z-plasty, and the case 5 is with the paneling technique. The result was that the patient treated with the diode laser had less post-operative pain. The scores according to the VAS scale at the 24 hours and the 7th day, the post-frenectomy as compared to the patient with the other technique as shown in the table. Aberrant frenum etiological factor for the midline diastema focuses on the frenum is more essential. Soft tissue diode laser is an alternative to a scalpel. Gazetted et al. In 2009, he described that the diode laser is considered as an excellent soft tissue laser as it does not interact with the dental hard tissue. Diode laser has a less post-operative pain at the 24-hour as compared to the scalpel, electrocautery, and the Z-plasty technique. Hattek et al. In 2006, he described laser treatment has less post-operative pain as compared to the scalpel. So the conclusion is that the soft tissue diode laser is considered as the most comfortable surgical technique with a less post-operative pain. Thank you.
Yeah, the thing is, you have used Z-plasty, you have used paralleling technique, conventional technique, they all come under conventional. Means conventional, the surgical techniques. Yeah, surgical techniques, different modes. So it depends on the incision, the expertise of the patient, of the operator. So I think you cannot compare like this because you are comparing, you said you're comparing laser, electrocautery, fine, and a conventional technique. Yes. So you should not have included Z-plasty paralleling technique because that is, it won't be right. So you're actually comparing the different modes. So when you're comparing different modes, then this is what I would suggest. And yes, if you had included about the wound healing, that would have given an extra edge to it. So you could have put some wound healing index. You could have used a wound healing index, or you could have done any other method of checking the healing. Okay, you could have used even the past technique also. So yeah, I think your case would have been still better if you had done it a little bit more. So this is from my side. Madam, yeah, and laser, you said laser showed a best benefit out of, the VAS scale was better, the patient was more comfortable. So what could be the reasons for that?
Ma'am, the endorphin enzyme, which is the pain inhibiting enzyme, it is increased in the case of the laser. And second, it also inhibits a pain pathway also, ma'am.
Yeah, but are there some more methods by which?
And ma'am, because of laser, the bleeding is also less, so patient has less discomfort, ma'am. As it has a property of electrocoagulation, cutting property, electrocoagulation property. So bleeding is less, so it's better. It's easy access for the surgery, ma'am.
Madam, any questions?
Yeah, I agree with what Dr. Sheila said. Three different surgical techniques compared with laser and cautery is not correct. Conventional technique, laser and cautery is how you should go. Or you could compare the surgical techniques with each other. That's a different thing. Because Z-plasty, I'm sure, is very painful. And indications are also different for all these surgical techniques. I basically agree with whatever Sheila said, so I won't repeat it. We'll go to the next presenter.
Thank you, ma'am.
Thank you.
Thank you.
Bye-bye.
I think this was the last in the sequence. We had missed few. So I would just like to call out the numbers. And Janvi, would it be possible for us to go to those slides if the presenters are here? CRPO 78. Are you here?
Ma'am, am I audible?
Yeah.
Okay.
78.
Shall I start, ma'am?
Yes, right. Thank you. Yes, you can start.
Good evening to all. My topic for today's presentation is lasers, making great inroads into periodontal surgery. Laser, as we know, is the acronym for light amplification by stimulated emission of radiation, and they have been used extensively in the medical field ever since they were introduced. Presently, there are a wide variety of lasers available for dental use, such as argon laser, carbon dioxide laser, ND-YAG, diode, erbium YAG, etc. About the history of laser in brief, the first laser device was made by Theodor H. Maiman in the year 1960, and this was based on Albert Einstein's theory of spontaneous and stimulated emission of radiation, which was put forth in the year 1917. In dentistry, the first laser introduced was the ruby laser by Goldman in the year 1964. Now, how do they function? As we can see in the top left diagrammatic representation, laser beam is produced as a result of the optical activity which takes place in the medium, which is energized using an external power source. So the resultant spontaneous as well as stimulated emission radiations are subsequently amplified within the medium by means of the two mirrors which are located on either ends of this resonating chamber, and this finally gives out the laser beam. Now, coming to the case reports, the patients included here were those who reported to the Department of Periodontics in the age group between 18 to 50 years with various chief complaints, including dark or black colored gums, swollen gums, restricted tongue movements, etc. After successful etiotrophic phase, the patients were subjected to the respective laser therapies and evaluation of various aspects was done, including pain, bleeding, scarring, and wound healing. So as you can see, the first set of photographs depicts the depigmentation process that was done. The first is the pre-operative photograph, followed by the immediate post-operative, and the third is a 1-week follow-up. Second is the pre-operative and post-operative frontal and lateral view of tongue ankylosing correction done. And the third set shows gingivectomy, pre-operative and post-operative pictures. And the last set of diagrams, the picture shows frenectomy that was done, maxillary labial frenectomy done using lasers. So the conclusion that we obtained from all these cases is that lasers are beneficial in reducing the traditional surgical problems, such as bleeding, reduced vision, scarring, pain, infection, etc. The patient acceptance also was considerably high with the use of lasers as compared to the conventional surgical procedures. Thank you.
You very superficially touched on lasers, where I've shown only soft tissue lasers.
Yes, ma'am.
Can you name any hard tissue laser which is used?
Erbium YAG lasers are hard tissue lasers, ma'am.
So no. Tell me something about it. What does it do? What are the properties?
What it does is it causes various effects on the body cells, such as photothermal reaction, disruptive reaction, then photobiomodulation. So these are the mechanisms by which it acts on the body cells.
And also you could have included LANAP.
Yes, ma'am.
Yes, that is also
Yes.
an important thing now we are doing. This is very superficial, what you
Yes.
said, soft tissue laser.
Yes,
and
ma'am.
Very special in this. It's all very done, routine procedures these are.
Yes, yes, ma'am.
So LANAP is left out, which you would have be doing, I'm sure.
Yes,
and soft tissue side of the pocket is also being treated by laser now in flap.
Yes, yes, ma'am.
Soft tissue lasers. Of course, we don't go to the tooth side.
Yeah.
For that, we need erbium yttrium.
Erbium, yeah, yes, ma'am.
You presented well, but it's not very novel, your topic.
Yes, yes.
Presentation is good though.
Thank you.
Yeah, your poster is very clear.
Thank you.
But yeah, as Madam said, this comes as a review paper, I think. And yeah, you can't say it exactly as it's some case reports of some of the procedures you have done using laser, but you have not mentioned which soft tissue laser you have used.
Sorry, ma'am.
And what is the wavelength of that laser
Yes,
that
ma'am.
you
Here we have
use?
used bi-laser, edge-laser with 940 nanometers. Diode laser was used here.
Yeah, so it would have been better if you had put a picture
Yes.
of the laser that you used and what is the what is the wattage, what is the wavelength that you have used and things like that.
Yes.
And are there any other latest lasers that are available?
Not sure, ma'am.
Fine. Let's go to the next paper.
Okay, thank you.
Thank you.
Again, CRPO 283. Are you here?
Yes, ma'am.
Can we go to that poster 283? Yes, Akshara?
Yes, ma'am.
Yeah, can you begin your presentation?
Respected judges, moving on to my poster, the topic is fusion deposited starch-based gates for the implant placement or case report. So moving on to introduction, the fusion deposition is an additive manufacturing technique in which the simulated models could be printed as a multiple layers, which is made up of a thermoplastic substance, which is called as a polylactic acid. So this polylactic acid is a thermoplastic polymer, which is derived from starch, which is commonly used for a prototyping. So these starch-based scaffolds are used for tissue bioprinting, and the same technology can also be used for fabricating surgical guides. So the starch-based guides can be made by ring opening polymerization of lactic acid. So moving on to clinical presentation, 22-year-old male patient reported to our department with a chief complaint of missing one tooth. CBCT and digital impression of upper and lower arches were recorded and superimposed. Then digital planning and simulation, that's a picture shows a cross-sectional view showing the position of the implant in relation to the digital waxer. A digital waxer was created using a Blue Sky Bio software, and the implant position was planned according to the digital waxer. So from this implant position, a guide was fabricated using the same software, and the STL of the guide was exported and 3D printed using a polylactic acid. So moving on to procedure. So we have placed a surgical guide with a sleeve, and we have sequential drilling done. Implant is placed and temporization was given. So why did we choose this material? There are different types of materials that we use for the guides. For example, we have resins, we have polylactic acid, polycarbonate, then we have powder forms, and we have metals. So PLA is better than resin because it is eco-friendly, it is economic, it is biodegradable, it's biocompatible, and it is non-reactive to tissues. In a study by David et al. In 2017, he have used a block type graph using a PLA for implant placement, and the result shows a better safety and predictability. So I would like to conclude by saying that PLA can be the best replacement for the photopolymer resins. Thank you.
Yeah, what is the importance of why can't we use the normal stents? Why we need to use these stents where it's going to be more costly? You need a bioprinter. So not in many places you can do that. And yeah, what was your idea behind using this?
Ma'am, usually this polylactic acid is it has various advantages, like it is biodegradable, it is non-reactive to tissues, it is more biocompatible, and it is economic also. So this is actually, we have derived from a starch. The polylactic acid is derived from a starch, which is usually commonly used for a prototyping.
Okay, so it is customized to the particular patient.
Yes, ma'am.
And what would be the cost of it?
Ma'am, for this surgical guide, it might cost rupees around 200, like that. Only bioprinter, it is expensive, but for these guides, it is cheap only, ma'am. It's economic. It is.
Okay, good.
Thank you.
At least you use the recent technologies, and this digital printing is coming up. So it's a very good idea, and that too eco-friendly. So good.
Thank you.
Good presentation.
Thank
Yes,
you,
madam.
No questions. No questions.
Thank you.
Thank you. Do we have CRPO 286? CRPO 286, CRPO 291, and 294. Are they present? I repeat the questions, or else we can end with the session. CRPO 286, 291, and 294. Ma'am, I don't think they are present.
Okay, then we'll conclude.
We will conclude. Yes, ma'am. Then. Thank you so much, Dr. Deepika, ma'am, and Dr. Sheila, ma'am, for judging our session. And ma'am, I would request you to send the evaluation sheet. I will be sending you the email address.
Yes.
And thank you, everyone. Thank you, all the participants. Dr. Rashmi, ma'am, over to you for the next session.
No, thank you very much.
Thank you.
Thank you, ma'am.
Good evening and a very warm and hearty welcome to all the delegates and judges on behalf of 45th ISP National Conference. So this session today will be from the category review poster session. So for this session today, I would like to welcome two eminent judges, Dr. Shruti Gupta. Very good evening, ma'am. And she's currently working as a reader in Department of Periodontics at Rana Dental College, Hospital and Research Center, Kanpur. Ma'am has completed her master's degree from the same institute, and ma'am is more focused in growing her skills in all conventional and new periodontal procedures. She has also attended and chaired various conferences and CDA programs at state and national levels. So ma'am has several publications to her credit in various national and international journals. Next judge for the day, we have Dr. Ira Gupta. Good evening, ma'am.
Good evening.
Ma'am is currently working as professor in Department of Periodontics and Oral Implantology in Rama Dental College, Hospital and Research Center. Ma'am has an experience in periodontics since last 14 years. Her areas of clinical skills are focused on diagnosis and treatment of periodontal disease. Ma'am has also attended and chaired various sessions and posters in national and international conferences. And ma'am has also been invited as speaker at various dental events and has several publications to her credit in the national and international journals. It's our pleasure to have you both as our judge for this session.
Thank you, Dr. Gopika. Thank you
Thank
so
you,
much.
ma'am.
Thank you, ma'am.
Our pleasure. Ma'am, so with the session, we will commence. With this, we'll commence the session. So participants kindly know that you will be getting total 5 minutes of time. So 3 minutes will be for the presentation and 2 minutes will be for the Q&A session. So kindly please do stick to the time frame. So starting with the first poster, it is RPO 001, Dr. Rupanchal.
Yeah, am I audible?
Yes, you're audible. You can proceed.
Yeah, good evening, one and all. The topic for today's review poster presentation is Entire Papilla Preservation Technique, an innovative approach to periodontal microsurgery. So periodontal regeneration techniques are one of the common treatment for intrabony defects. However, these techniques require high technique sensitivity and there are multiple factors related to the success. Now, one new dimension is the introduction to periodontal microsurgery. Periodontal microsurgery is the refinement of the basic surgical techniques made possible by the improved visual acuity gained with the use of a surgical microscope. Now, to promote the early soft tissue healing, minimize the trauma of the papilla, and reduce the post-operative gingival recession, papilla preservation techniques were proposed. Now, the concept and the series of minimal invasive technique was given by Cotton et al. in 2007 However, it was modified by Barabato et al. In 2020 into modified minimally invasive surgical technique, also called as the modified MIST, in which the papilla is raised only on the buccal side. That is the single flap approach. Now, 3 novel approaches for preserving the entire papilla applied for bony regeneration include Aslan et al. In 2017 gave entire papilla preservation technique. Moreno Rodriguez et al. In 2018 gave the non-incised papilla surgical approach or the NIPSA technique, and Najafi et al. In 2018 gave the modified vestibular incision subperiosteal tanallaxis or the M-Vista technique. Now to focus on the entire papilla preservation technique. So the entire papilla preservation technique aimed to preserve the whole integrity of the defect-associated papilla, providing a tunnel-like undermining incision. Now a short, as in the picture B or the second picture, a short vertical incision at the neighboring papilla was given and an angled tunneling instrument used to prepare the undermining tunnel. Debridement and placement of biomaterials done, and microsuturing by 6-0 absorbable monofilament sutures. Now, having said about this technique, the take-home message from this review poster is that it has the simplest suturing technique, and since we are preserving the intact papilla, it provided an intact gingival chamber to stabilize the blood clot and hence achieve a primary closure and hence a better wound healing. Now, this is my reference, and I would like to thank Professor Dr. Cottonelli et al. And Dr. Zheng Pai for allowing me to use this picture for the said review poster presentation. Thank you so much.
Shruti ma'am, any questions?
Dr. Rupanjan, in this technique, what is the significance of the transgingival probing?
Ma'am, the significance of transgingival probing is that we have to know that if the defect is both on the buccal and the lingual side, we can't go for this technique because then the three-dimensional pocket reduction won't be done with this technique. So the transgingival technique, before it actually helps us to analyze whether we should go ahead with this technique or we can go ahead with a conventional technique of raising the full flap.
So can we say that it is the limitation of this technique?
Yeah, definitely, ma'am. Definitely, this is the limitation of this technique. And for that reason only, we have to go for the transgengival probing or bone sounding to detect whether we can go ahead or not with the conventional technique.
Okay. As you know, the surgical loops are used in this technique.
Yes,
what are the magnification for that?
Ma'am, the magnification for this surgical loop is basically 4.5 that has been given in this article, and which which we also prefer in our clinics, in our department. Basically it's required for the suturing, that is for the 6-0 absorbable suture, 4.5x magnification.
Okay.
Panjan, can you please tell me what is the basic complication that you're trying to avoid through this particular technique?
Ma'am, the main agenda of using this technique is that we are trying to achieve a primary wound closure. So if we are following the normal conventional flap technique where we are extending the incision one teeth distal and one teeth mesial to the concerned defect, so there is a secondary healing and we are not preserving the papilla. So here we are completely preserving the papilla and providing an intact gingival chamber, which will help in better healing and attain primary closure.
So how is it different from NIPSA?
Ma'am, NIPSA technique is that the non-incised papilla surgical approach, and that we are giving the incision completely 1 centimeter below the papilla. Both the horizontal incisions will be given below the papilla, and the crescent shape window is being made below, and we will proceed from that region. But in this region, we are giving the incision only on one side of the defect, or not on both the side of the defect.
Okay, thank you. Dr. Panjan, you're a first year student?
Second year, ma'am.
Third year?
Second year, ma'am. Since we are admitted in 2020 batch, so they have said that 2020 batch people can go for review posters because this was our first ISP.
Okay. Yes. Thank you.
Thank you.
Can we have our next poster, please? RPO 002, Dr. Robit.
Good evening, everyone. Am I audible?
Yes, you are audible.
Yes, we're audible.
Okay. Good evening, everyone. I'm Dr. Rohit Kapoor. The topic of my poster is extracorporeal shockwave therapy. These are high-frequency acoustic shockwave generated underwater with high voltage, blow-up, and vaporization. The methods of generation includes the electrohydraulic, electromagnetic, and piezoelectric methods. Today, we are going to discuss on the electrohydraulic methods. So basically, these are transient pressure disturbance that propagates rapidly in 3 dimensions. It utilizes sonic pulse having high peak pressure, short life cycle, fast pressure rise, and broad frequency spectrum. The mechanism of action includes the bidirect stresses associated with high amplitude of shock waves and stresses, and microjets associated with growth and violent collapse of cavitation bubbles. It was introduced in Germany in 1980 for treatment of urolithiasis, cholelithiasis, and cyalolithiasis. The device used to generate shock waves is a oxyhydrogen detonation-driven miniature shock tube assembly, which comprises of first oxyhydrogen generator and a miniature shock tube assembly. So now coming on to the applications in periodontology, first is the induction of bone regeneration. In this, energy point of 0.16 millijoule per millimeter square in range between 250 to 500 impulses is used and it was given by Satish et al. In 2008. Then next is bactericidal efficacy, in which low doses of 100 impulses at 0.3 millijoule per millimeter square was used for selective bactericidal effect on Streptococcus mutans and Porphyromonas gingivalis, given by Novak et al. In 2008. Then management of periimplantitis, as we discussed, the induction of bone regeneration and bactericidal efficacy. So due to both these effects, there is help in the reosseointegration, and it improves the success rate of implants, given by Lex et al. In 2010. Then for the dental calculus removal, the Muller et al. 2011 found efficiency of biofilm removal comparable with an ultrasonic instrument. And the last, osseointegration of implants, W.P. Song et al. In 2020 said these shock waves stimulates osteoblasts, fibroblasts, induction of new vascularization, and increased expression of bone morphogenetic protein. These are my references. Thank you.
Ira ma'am, any questions?
Dr. Rohit, can you please tell me, can you use ESWT at the sites of active infection?
Ma'am, actually, these shockwaves have not been used in vivo till now. They have only used in vitro studies. There is only in vitro studies and animal studies. So research is still going on in this field. So I'm not sure about if it can be used in the active field or not.
So in the in vitro studies where it has been compared with the ultrasonic instruments,
yes, ma'am.
Has it been found better than that, or is it lagging behind in some area?
Ma'am, it is lagging behind in some areas comparable to ultrasonic, but it is still comparable. They have mentioned that. So it still needs improvement in that section.
No, which particular thing? Actually, it's comparable. Only it's certain point it lags behind. Which is that? Can you tell me? Can you specify?
Ma'am, like in the efficiency of biofilm removal was not as good as an ultrasonic scaler did. So,
Dr. Shruti.
Dr. Rohit.
Yes, ma'am.
What are the, apart from the perio, where we can use this approach, ESWT?
Ma'am, it has been used in for treatment of urolithiasis, cholelithiasis, and cyalolithiasis. Also, later on, they have used it in the treatment of dermal wounds, orthopedic condition, and various musculoskeletal conditions, ma'am.
But apart from perio in the dentistry?
Ma'am, I have not come across any.
Okay, how can we use it in the peri-implantitis cases?
Ma'am, for the peri-implantitis, ma'am, there is, because of the it has induction of bone regeneration and it has bactericidal efficacy, so it is used for the reosseointegration of the implants, ma'am. And also it improves the success rate of implants.
Can you explain the analgesic effect of this technique?
Analgesic effect, ma'am. I'm not sure, ma'am.
Okay, thank you.
Thank you.
Thank you, ma'am.
Can we go to the next poster, RPO 003, Dr. Harshita. Dr. Harshita, are you there? RPO 003, Dr. Harshita. Okay, we'll go to the next poster.
Yes, ma'am.
RPO 004, Dr. Shubhankar.
Am I audible, ma'am?
Yes, you are audible. You can proceed.
Okay. Good evening, one and all. My poster reviews zygomatic implants, which present a diversified sector in the management of posterior maxillary atrophy. Taking a look at the implant macro design, zygomatic implants present with an angulated abutment, a constricted neck, elongated polished shaft to derive anchorage from the distant zygoma, and apical threads to achieve bicortical fixation. Similarly, when seeing the surgical protocols, zygoma implant placement differs in terms of a preliminary use of a twist drill and a specific angulated depth indicator for accurate assessment of the osteotomy. The rationale for these devices include prolonged prosthetic solutions, surpassing augmentation procedures, quick rehabilitation, and specifically allows patients with mid-facial oncologic defects to enjoy prosthetic care. The original zygoma implant technique innovated by Bronmark in 1998 included an intrasinus path along with palatal emergence of the processes leading to biological as well as prosthetic complications. Thus, to efficiently tackle these challenges, sinus slot technique was introduced, which included the stepwise preparation of a slot leading which allowed fixture guidance into a prosthetic driven position and simultaneously eliminated the need for sinus elevation. A survival rate of 98 to 100% was noted with this technique. In 2003, a quad zygoma technique was presented that allowed restoration of the completely edentulous maxilla. To further improve upon patient satisfaction, immediate loading of zygoma implant was introduced in the same year. Apparecchio in 2012 gave a Zaga classification based on anatomic guided approach. A recent technical modification of the extrasinus technique by Grecci et al. Allowed hybrid slot preparation with a specialized force burr, followed by using a twist drill to join the markings at the zygoma and the crestal emergence to place an innovatively designed zygomatic implant. The survival rate of 97.99% was seen here. Based on 3 systematic reviews and meta-analysis, sinusitis was reported to be the most frequent complication of zygoma implant therapy. The ORIS success criteria for zygomatic restorations is dictated by measuring the offset of the processes, evaluating the sinus status, soft tissue condition, and the process's stability. A PubMed search narrowed down to 30 relevant articles allowed us to draw the following evidence-based results, which are important for us as periodontists to know. A survival rate of 95.2 to 98.2% was noted with zygoma implants. Zygoma implants were found to be superior than conventional implants in terms of fewer prosthetic failures and significantly reduced time for functional loading. Superior aesthetic satisfaction with zygoma implants was offered to the patients. Extent of peri-implantitis was around 4.4 to 8%. In a cohort study, 72% of experienced practitioners responded that specific ZI designs, zygomatic implant designs, are the most predictable treatment option for posterior maxillary resorption. So, in conclusion, in zygomatic implantology, proper treatment planning is the crucial phase along with proper maintenance. Thank you.
Okay. Doctor, can you tell me, as you were talking, there is angulated abutment part.
Yes, ma'am.
What is the degree of angulation and why is it so?
So, ma'am, the angulated abutment in these designs is around 40 to 55 degrees. And to compensate for that, we use multi-angulated abutments at the crest to achieve the stability which we are deriving from the zygoma. So as the zygoma is positioned at an angle from the crest, we need to derive anchorage, and at the crest, we support the processes with the help of this implant.
No, my question is why this particular angulation?
Ma'am, this particular angulation is needed so as to achieve better distribution of the forces to the zygoma crest, to the zygomatic bone, so that the masticatory forces are balanced there.
Okay. What is the height for the ideal case? In the ideal cases, in the conventional implantology, what is the maximum bone height you need to have in the case of posterior maxilla? Minimum height.
Ma'am, that depends from each scenario based on what kind of sinus lift procedures can also be indicated based on the amount of bone that is available. So basically, if we are doing a conventional implant without sinus lift, we try for at least 10 mm to place an 8 mm implant. But nowadays there are more implant options available. Shorter implants are also being placed in the posterior maxilla, around 6 mm implants. So a clearance of at least 2 mm from the sinus is needed. But in many cases we see, due to the severe resorption, only about around 3 to 4 mm bone levels are seen. So we frequently need to go for sinus elevation and multiple other augmentation procedures which can be surpassed with zygoma implant technique.
Subhankar, you told me that major complication for these implants is sinusitis. How
Yes,
can you avoid it?
Ma'am, so initially the brainmark implants, they followed an intrasinus path. So sinusitis was then seen commonly, but more in the previous 20 years, there have been many innovations. Extra sinus techniques have developed where we just derive some support from the lateral wall of the sinus. And as we have seen in this modified extra sinus technique, a hybrid slot is prepared, which allows the placement into the position and sinus elevation is eliminated. So there is no contact with the Schneiderian membrane, and thus sinus techniques have been reduced with the sinusitis has been reduced.
Okay, thank you.
Thank you, ma'am.
Next poster, please. RPO 005, Dr. Hinduvi.
Good evening, respected panelists. Today's my topic for the review poster is application of tissue engineering in biomaterials used in the periodontal therapy. The evolution of biomaterial sciences incorporating the principles of tissue engineering have helped in enhancing the outcomes of corrective surgical therapy. The aim to highlight the advances in bioscaffolds and matrices in addition to incorporation of the stem cells and growth modifiers and factors in reconstructive surgical procedure to enhance the biologic response and promote the healing. The tissue engineering involves the three key elements: cells, signaling molecules, scaffolds, and the biomatrices. Cells, which are the mesenchymal stem cells, osteoblasts, fibroblasts, and cementoblasts. Signaling molecules, growth factors, and growth modifiers. Recombinant human platelet-derived growth factor, bone morphogenic protein BMP2, enamel matrix derivatives, and platelet-rich plasma. Bioscaffolds, which involves the ceramic-based materials, are the bioactive glass, chitosan, hydroxyapatite, biphasic and triphasic scaffolds. Chitosan is a natural polymer. And cell sheet technology, it is a novel cell transforming method. Cell sheet technology, it creates the functional tissue sheet with cells derived from the various tissue, in which the temperature responsive polymer is grafted onto the surface of cell culture dish to create the cell culture sheet, in which the temperature is below 32 degrees Celsius, which is capable of keeping the extracellular matrix proteins and the cell to cell interaction intact. And PEBs and P15 and laminin, epicell, hydrogel. Hydrogel, it has the distinct three-dimensional structure. Due to which the water due to high water content, it provides the ideal environment for the cell survival. Barrier membranes. The collagen membranes are human collagen membrane, chorionic collagen membrane, bovine collagen membrane. The principles of the tissue engineering: past principle, primary wound closure, angiogenesis, space creation or maintenance, stability of the blood clots. It has the property, they should have the property of biocompatibility. They are the osteoconductive, osteoinductive, and osteogenic. And the conclusion for this is the advances in the tissue engineering incorporated within the biomaterial science development help to deliver the reliable and desirable healing outcomes following corrective periodontal therapy. These are the references. Thank you.
Dr. Hindavi, can you
Yes,
tell
ma'am.
me something about the role of nanotechnology in tissue engineering in case of biomaterials?
Nanotechnology, it involves the bioactive glass nanoparticles, which has the size of the 90 to 120 microns.
Anything else?
When these materials comes into these bioactive glass materials, which involve the silicon dioxide, sodium and calcium salts, when these materials comes in contact with the tissue fluids, the surface of these particles become coated with the hydroxyapatite component, which incorporates the organic ground proteins such as the chondroitin sulfase, glycosamine glycans, and it attracts the osteoblast so that the rapidly bone formation occurs.
Okay. Who was the author who first talked about the role of tissue engineering in periodontal regeneration?
Ma'am, the Langer and Vacanti. Langer and Vacanti.
Which year?
In 1990. I'm not sure, ma'am.
Okay. Dr. Shruti?
Yes, ma'am. Dr. Hindevi?
Yes, ma'am.
Can you tell me why the tissue engineering is called as a magic filler?
Sorry,
the
ma'am.
term magic filler. Am I audible?
Hello. Sorry, ma'am.
Hello. Huh. My question is that why tissue engineering is called is magic filler?
In the tissue engineering, the lost or the injured part in such it is replaced in such a way that architecture and the function of the lost or injured tissue is completely restored, and it has they are biocompatible, less immunogenic. They have the osteoconductive and osteoinductive properties due to that.
Okay. Thank you.
Thank you, ma'am.
Next poster, please. RPO 007, Dr. Kirti.
Ma'am, am I audible? This is not mine. The poster being shown is not mine.
RPO 007, Dr. Kirti.
Ma'am, this is Z6. I'm waiting for my poster on screen.
Janvi ma'am, can you play RPO 007, Dr. Kirti?
Ma'am, should I start?
ऐकलंस तू?
Yes, you can proceed.
Ma'am, should I start?
Yes, you can proceed.
Thank you. मग माझं ते हे होत नव्हतं व्यवस्थित pronounce होत नव्हते words. मला असं घाबरून हे होत होतं.
Good evening to the panel members and everyone present in this room. I, Kirti Rawat, will be presenting poster on Seal and Heal, in which I'll be talking about tissue adhesives and sealants. These are liquid or semi-liquid compounds applied on tissue incision, that is soft tissues, during periodontal surgeries to close the wound surface and provide hemostasis. The first report use of adhesives was in 1963 by Rifojo et al. And Webster et al. And it was done for ocular surgeries. And it have been long sought for surgical use by Cooper and Falb in 1968. There are two types of adhesives, traditional and emerging tissue adhesives. Traditional adhesives examples are cyanoacrylate, bioglue, fibrin, gelatin sealants, whereas for emerging adhesives, examples are methaacetylate polymers, gelatin tissue adhesives, mucil-inspired tissue adhesives. So they are externally employed and they have features like short gluing time and high gluing strength. When applied, they produce heat during bonding process and formation of toxic degradation products such as formaldehyde and cyanoacrylate, as shown in the center image. It takes place with lipid and O2, forming lipid hydroperoxide, leading to increase in thromboxane A2, prostaglandin, leukotriene, making blood clot and undergoing local ischemia, necrosis, leading to tissue damage. Second part of the diagram shows how body reacts with adhesives. So adhesives are low in tissue absorption, showing foreign body reaction, attracting macrophages, polymorphonucleosides on dermis, for which phagocytosis takes place and leading to lysosome degranulation and cell death. The commercially available adhesives, as I've shown here, Tcil, which is fibrin based. Duracil is polyethylene glycol based, and Dermabond is cyanoacrylate wound adhesive. The advantages for adhesives are that they are bacteriostatic, they are hemostatic, no inflammation, and no local anesthesia is required. Whereas disadvantages is short shelf life, high cost, non-operative site adherence. Here are some periodontal surgeries where adhesives are used. Examples are mucogingival surgery, gingivectomy, flap surgery, and operculectomy. Studies done which include adhesives are Coulthard P. et al. In 2014 investigated tissue adhesives for closure of surgical incision, whereas Majid et al. In 2020 did a study on wound healing adhesives. Finally, I would like to conclude my poster saying that various adhesives and sealants act as wound closure and healing devices by acting a skin substitute to induce tissue growth, accelerating wound closure, and they reduce scar formation in periodontal surgeries. A lot of research have been done with adhesives and sealants with rapid advancements in medical biotechnology. Newer bioadhesives can overcome various drawbacks and necessities of current bioadhesives. Thank you.
Doctor,
yes, ma'am.
Would you like to say that they can totally, these adhesives can totally replace sutures?
No, ma'am. Actually, there is a drawback for adhesives also, as they can be toxic. They produce toxic byproducts after they are applied on skin. So that's why they are not generally used currently in current scenario. They are not like worldwide used on regular basis because sutures are much preferred over adhesives on most of the cases. Yeah, ma'am, that's nothing.
No, that's what. So that is a major drawback then.
Yes, ma'am. Like it is considered on most of the like deeper surgical sites. So adhesives are like contraindicated on those sites.
Do they have any effect on fibroblast proliferation?
Yes, ma'am. They induce the intermixing of the fibroblastic connections. So they induce it.
Dr. Shruti.
Dr. Kirti.
Yes, ma'am.
Name the contraindication of these adhesive.
Name contraindication.
Point it out. Please point it out. The
Ma'am, like they provide inadequate hemostasis and the wounds at mucocutaneous borders, they are contraindicated in there. And in high moisture areas where there is like secretions, they are contraindicated. Like moisture, where there is moisture, they are contraindicated.
Dr. Shruti, are you done?
Yes.
Okay. Can you tell me, is there any, would you like to say that they can be applied to all the kind of flaps? Are you trying to say this? Or what is your take on it?
Ma'am, I would say it's easy to apply adhesives on buccal flaps and lingual where there is reach to apply them. And
no, I'm trying to ask you, like, if we have conventional flaps, then we have coronally position flaps, apically position flap, literary position flaps. So would you recommend it even for the flaps other than the conventional flaps?
No, ma'am.
Why?
Ma'am, because of the approximation which could be compromised.
Okay, thank you.
Thank you, ma'am.
Next poster, please. RPO-008, Dr. Kritika.
Ma'am, am I audible?
Yes, we can proceed.
Am I audible, ma'am?
Audible.
Okay, should I start now? Good evening, respected panel members and everyone present in this room. The topic of my poster is epigenetics and periodontology. Periodontitis may have a slow, moderate, and rapid rate of progression due to the presence or absence of local factors. So why do some patients, in spite of maintaining proper oral hygiene, still have periodontal breakdown? The answer to this can be on the basis of multifactorial etiology of periodontal disease, of which genetics is an important component. Epigenetics is a term conceived by Conrad H. Waddington in 1942. It is defined as stably heritable phenotype resulting from changes in a chromosome without alterations in the DNA sequence. Epigenetic modifications include chemical alterations of DNA and associated proteins, leading to the remodeling of the chromatin and activation and inactivation of the gene. The key mechanism of epigenetics is DNA methylation and histone modification. It can be induced or altered by environmental factors that modulate the gene expression and affect various gene functions, such as imprinting, development of diseases such as cancer, periodontitis, etc. Therefore, it produces a link between inherited genome and the environment. DNA methylation is an important step in gene transcription. And histone modification also plays its epigenetic role in the organization of chromatin domains and the upregulation or downregulation of gene expression. Biofilm pathogens within gingival crevice initiate gingival inflammation that leads to cell death, tissue repair, and reepithelialization. Continuation of this process may change the dynamics of epithelial cells phenotype that may create immune dysbiosis. Cells of innate immune system undergo epigenetic modification at DNA and histone, creating distinct phenotype upon biofilm stimuli. These modifications control gene regulation process and may either turn off or on the key genes of innate inflammatory pathway. This dysregulated innate inflammatory system could disrupt adaptive immune responses in the development of periodontitis. Barros and Offenbacher in 2014 stated that the epigenome differs between inflamed periodontal sites and non-inflamed sites in the same individuals. Authors have also stated that a difference in the methylation patterns associated with different pathways exists in inflamed tissue of periodontitis patient as compared to tissue from healthy individuals. I conclude my poster by saying pharmacological agents can be used to revert the effects of epigenetic variations. This is under research and still require a lot of research before they can be introduced to clinical practice. Thank you.
Dr. Kritika?
Yes, ma'am.
Yeah. Can you please tell me, when you're talking in terms of epigenetics, what is ENCODE? What is ENCODE project?
Ma'am, ENCODE, ma'am, I'm not very sure about it.
Okay. As you were talking of the epigenetic modifications, you were telling basically, like as the subject itself tells, that basically the modification does not take place at a DNA level, but the expression is changed. So where exactly this modification is taking place in terms of gingival inflammation? At which interface? Did you get the question? Am I audible? Dr. Kritika, am I audible to you?
Dr. Kritika? Ma'am, should we proceed to the next poster?
Sure.
Can we have the next poster, please? RPO 009, Dr. Ekta.
Yes, ma'am. Am I audible?
Yes, you are audible. You can proceed.
Good evening, respected panel members and everyone present in this room. I'll be presenting my poster on the topic Personalized Precision Periodontics, Need of the Hour. The basis of personalized periodontics targets treatment to a patient's specific needs on the basis of genetics, biomarkers, epigenetics, phenotypic, socioeconomic, and psychosocial determinants that distinguish an individual from one another with similar clinical presentation. Identifying individual risk for periodontitis starts by stratification of every patient into a well-defined category and further identifying disease pathway before the development of its severe form to prevent disease progression and its complication. Since periodontal diagnosis is based on clinical and radiological parameters, the use of biomarkers serves as the first step towards adoption of precision medicine concept in periodontology. Biomarkers in periodontology can be classified as predictive markers, diagnostic markers, prognostic markers, and surrogate endpoints. The guide for individualizing periodontal care involves unifying patients' history, clinical data, and environmental factors with genetic risk factor analysis. This can help a clinician to reach a correct diagnosis and subsequently formulate a treatment plan. The significant advancement in molecular biology utilizes clustered, regularly interspaced palindromic repeats system, which plays a key role in bacterial defense by detecting and destroying DNA fragments during subsequent bacteriophage invasion. According to a study conducted by Barber et al. In 2021, he discussed the potential of utilizing CRISPR-Cas system in periodontal field to develop personalized periodontal care. CRISPR-Cas9 can be a useful tool to create knockouts in vitro, in vivo as a screening tool to identify cellular pathways involved in pathogenesis of periodontitis. Currently, the utility of CRISPR-Cas application in clinical setting is limited as researches have been only done on animal models. And finally, I conclude my topic by saying that the personalized medicine is an extended form of traditional approach in understanding and treating disease with greater precision when combined with genetics and environmental factors to prevent the progression and susceptibility of the periodontal disease. Thank you.
Dr. Ekta, can you please tell me precision periodontics is based on which plaque hypothesis basically?
Ma'am, non-specific plaque hypothesis.
No, not at all. And what is culturomics? Am I audible?
Yes, ma'am.
Yeah.
It is the mainly the study of human behavior and cultural trends, and we quantitatively analyze.
No, why would I ask you that in this topic? Okay, can you classify biomarkers for me?
Yes, ma'am.
Yeah, please do that.
Ma'am, biomarkers based on the requested diagnostic information, they can be classified as preventive biomarkers. Then we have diagnostic biomarkers. Then prognostic biomarkers and surrogate endpoints. And then we have pharmacological biomarkers as well.
Dr. Shruti?
Yes, ma'am. Dr. Ekta, do you categorize the biomarkers, prognostic, diagnostic, surrogate? What are the prognostic markers?
Ma'am, they are mainly used for the assessment of, to assess the progression of the disease.
Name some biomarker which you used. Ekta, I am audible?
Yes, ma'am. Yes, ma'am. Ma'am, I'm not sure.
Okay. Name the some biomarker which used to assess the disease progression, periodontal disease progression.
Okay.
Okay, Ekta.
Let's proceed to the next one, please.
Can we have the next poster, RPO-010, Dr. Munni, and participants kindly note to switch on their videos. while presenting the poster. They're requested to keep it on.
Good evening, ma'am and everyone. Today my poster topic is haptics, the virtual reality in periodontics. As we know, over the past decade, utilization of technology-based learning processes as well as training in both fields of dental and medical education has increased. Haptics is such technology, which refers to the area of robotic and virtual reality and deals with the simulation devices used for sensing pressure, vibration, and other senses related to touch. Dental simulator along with haptic devices allows users to touch, feel the object, and perform operation on soft and hard tissues with tactile senses. In historical background, Luciano in 2006 first developed PerioSim. It is a virtual reality dental training device which allows training to practice diagnosis of periodontal diseases. And coming to the haptic device and its component, it included a monitor where virtual model of patient mouth or tooth is displayed, and instead of real instrument, we operator use haptic stylus, where operator can manipulate the real instrument, and which in turn reproduce clinical sensation in the hand of operator through the tactile senses. And virtual instrument included periodontal probe, explorer, and scaler. Coming to the application in the periodontics, haptics used for pocket measurement is pocket measurements. Pocket measurements is different in various angulation and other. In applying haptics, we can proceed correct pocket measurement. And in calculus removal, as we know, subgingival calculus, removal of subgingival calculus is mainly depend on tactile sensation, which can be mastered by using haptic while learning. And in advantages, reinforcement of learned dental concepts, correct use of dental instrument, correct ergonomic positioning, good psychomotor skills, positive patient student perception. And disadvantages are dental simulators are at an early or experimental stage, and tactile perception for gingiva is not very real. The initial cost can be substantial, or it is also difficult in maintenance and repair. And I concluded that the technology of virtual reality overcome the limitation of phantom hand system and provide standardization, case objective assessment, and interactivity.
Dr. Munmi, can you please tell me something about the role of haptics in this COVID era, how important it is?
Yes, ma'am.
Am I audible?
Yes, ma'am. Yes, ma'am.
Yeah. You want me to repeat the question?
Yes, ma'am.
Okay. Tell me something about the role of haptics in the COVID era. COVID era.
Yes, ma'am. Due to the COVID, there is available in real case. There is lack of available in real cases. So the training process of the dentist also.
Dr. Shruti.
Yes, ma'am. Dr. Munmi, tell me the name of probe which used in this haptic system. What is the name of that probe?
Name of it in this article, its name is virtual periodontal probe, but
no.
PerioSim,
Okay.
Okay, thank you.
Thank you.
Next poster, RPO-011, Dr. Surbi. Dr. Surbi, are you there? Dr. Surbi? I think we'll go to the next poster. RPO 012, Dr. David.
Yes, ma'am. Am I audible, ma'am?
Yes, you are audible. You can proceed.
Today in post presentation, presenting about